both inflow of the RV, pardon? Both inflow of the RV and LV, they are parallel. But in most complex disease, where the inflows become crossed, when the epicenter also cross. Instead of a normal twisting, it goes and twists like this. By crossing the heart like that, that is called a crisscross heart where the inflows cross, or it's also called a supra-inferior ventricle or a double-decker ventricle. Most difficult to correct. Most of them will go for a univentricular route. So that's the 4th week. And now we'll go to the 5th week of septation. So this heart, which is in the form of the heart, but still blood goes in one direction, it will now become 2 directions. So look at my hand. So watch it carefully. This is my sinus venosus. It has got 2 horns, right and left. The entire sinus venosus, the both horns, the left horn regresses, but it is represented by a coronary sinus. The right horn has the SVC and IVC joining. The both, everything, the body and right horn, it is absorbed into the right atrium. So this is my primitive atrium. Now I'm going to be separated into 2. So the venous end is totally into the right atrium. So what happens to the left atrium? This is the left atrium. From left atrium, the primary pulmonary vein starts and goes and brings all the 4 pulmonary veins into the left atrium. If primary pulmonary vein doesn't develop, that becomes a TAPVC, or it fails to bring 1 or 2 other pulmonary veins also back to the LA, it becomes a PAPVC. So these are the anomalies in the venous return. Now the most interesting thing here is the formation of the AV canal. So remember, this is the atrium and this is the primitive ventricle. So there develops the superior and inferior endocardial cushions on either side of the AV canal that deepens towards the midline and forms the, in the middle forms the septum intermedium. So in between these two, it develops in the mitral wall. Here it develops in the tricuspid wall. So now the septum from here, the primum septum goes and joins the septum intermedium. That's a normal development. 2 walls there and 1 septum there. Suppose septum primum doesn't join the septum intermedium, which is not formed fully, nicely. So that will become a primum AST. And if there is a deficiency in the septum primum at the floor of the first wall, is the secondum AST. If neither of the septum primum and secondum they don't develop, it will become a common atrium. But what is important is the septum intermedium gives rise to membranous septum. The thick membranous septum is formed by the septum intermedium. Suppose that is not good, that is not fully formed, still these walls are at the same level, and that is a the partial AV canal defect. And if the AV canals, they don't join these 2 walls in the center and it's just floating, it is a common AV canal defect. So now regarding the crux of the heart, this is a horizontal limb, this is a vertical limb. The one limb has to be found, that is from the ventricular septation. So just imagine, so I have separated this, so this is the left atrium, this is the right atrium, and similarly, so now we will start with the separation of the ventricle, where this is a ventricle. The first septum of the ventricle is nothing but the bulboventricular septum. When it joins like this septum in between that grooves into a septum which goes up to the crux there. So that's a crux there. The crux of the heart has now a limb here, that is a septum which forms in the inlet to the ventricle. The inlet septum also joins there to form the crux of the heart. Suppose this septum doesn't develop in the inlet at all, so the entire AV canal, the 2 walls will be draining into the left ventricle only. So that is the genesis of what you call it a Holmes heart, or a double inlet left ventricle. You can never have a double inlet right ventricle because of the same reason. And in that case, this single large ventricle will be communicating to the outflow with a communication. That communication is classically called a bulboventricular foramen. That terminology is not used in other situations. A bulboventricular foramen is from a large single ventricle to the outlet. Right. So that is a defect in the inlet septum. Now that is power. We will come to the septation of the arterial side. So this is the truncus arteriosus, which divides into aorta and pulmonary artery by formation of a spiral septum inside. The spiral septum, they are all derivatives of the neural crest cells which forms the secondary heart field. So spiral septum divides aorta and pulmonary artery. The same way it divides the conotruncal junction into two walls. You have a pulmonary wall here and you have a aortic wall inside here. So the coronal septum, the truncus is divided, conotruncal junction is divided, and what is to be now divided is the conus. So you have come up to the interventricular septum, come to the crux, you have come up to the conus here. So now concentrate on the coronal septum, this conus. The conus cordis has also got to start with two coni. So this is a conus, subpulmonary conus, which divides aortic valve and the pulmonary wall. And whereas subaortic conus, there is a subaortic conus which disappears. When the subaortic conus disappears, you see inside, when the subaortic conus disappears, the aortic wall, the mitral wall, tricuspid wall, aortic mitral continuity happens, and all the three walls will form the crux of the heart. This is how the crux is formed by the three walls, and the poor pulmonary wall is away above the subpulmonary conus. So that is a development up to here now. So we will show it in the septum, in the model. So we have come up to the crux is formed. Now what happens here? Let's say inlet septum. Now in the conus septum, the subpulmonary conus disappears. This is how it disappears. Subpulmonary conus disappears now. No subpulmonary conus. So here you can see the mitral wall, tricuspid wall, and the aortic wall, they are together. That is the crux formation. Now what is left is only the communication at the outflow between the two halves of the heart. Only that communication. What is that communication called? That communication is called primary interventricular foramen. It is like a VSD. That's a communication. Borders may be same, but you don't call it a VSD because primary interventricular foramen is a normal communication which is going to close up. VSD is, it doesn't close up, it becomes due to other reason, VSD forms later. So this is not called a VSD, but practically it is a VSD. Now concentrate on my outflow. This is the outflow of my own heart. You correlate anatomically with your heart. My right hand in front is the outflow septum. This is the inlet septum. Outflow septum, it is in the form of a Y. It has got an anterior limb, a posterior limb, and a Y-shaped thing. This is the, so the inside is LV, outside is RV. So what is at the other end? Other end is the coronal septum. Inside is the aortic wall, outside is the pulmonary wall, and this is what is going to close. Now I can see through that. Now that it is not closed, through the interventricular foramen, I am looking through the tricuspid wall. This is the tricuspid wall. I am looking through the tricuspid wall. I can see the aorta. I can see a white structure above the aorta. This structure above the aorta, which is seen through the primary foramen, is the ventriculoinfundibular fold, or it is also called the inner curvature of the heart. When the heart folds to the greater curvature because overgrowth, the portion if it doesn't grow at all remains as a lesser curvature. This is the most important landmark in the heart, which is not seen normally, and it is. But if you next time when you see you do a VSD, you can always see this interventricular fold through a VSD. That's what I am seeing now. I can see the fold. So this thumb represents the parietal band, which is part of the infundibular septum. So some people call the parietal band and the coronal septum together crista ventricula, supraventricularis, all terminology. So what happened now? There is a simple mechanism of a counterclockwise rotation of the conotrungus, which the conus gets attached to the middle of the limb of the Y, in between the two limbs of the Y, and the posterior division goes and closes the ventricular fold connection. Now I cannot see the aortic wall, I cannot see the crux, I cannot see the membranous septum. That's a normal heart. If God makes 1,000 hearts, 990 hearts will be like this. So 10% he will have some problem. So what are the problems here? The most complex anomalies around here only. The commonest is a VSD. Suppose this is like this. You just see it doesn't close at all. Some deficiency of the muscle, VSD happens. Through the VSD, you can see the aortic wall. I can see the ventricular fold, and I can see the membranous septum also. That VSD is between the conus and the ventricle. It's classically called conoventricular defect. 70% of VSDs are like that only. So what is the other type of VSD? That is when the coronal septum is absent. You have the pulmonary wall and the aortic wall together. That is you simply call it a doubly committed VSD. Now, more important things are called conotruncal anomalies. when there is in addition to the VSD, there is a truncal, there is an outflow anomaly also. The simplest is instead of getting attached in between, the coronal septum is deviated and gets attached anterior, the anterior limb, producing REOT obstruction and a overriding aorta like this from the RV. So that's a classical tetralogy of Fallow. Opposite that, if there is a posterior deviation of the coronal septum with aortic obstructions and interrupted aorta, that's a classical interrupted aortic arch. And the third defect, next two defects, with the aortopulmonary septum is not normal. Instead of spiraling, there is no spiraling, so it becomes parallel. So the next classical defective, when there is a clockwise rotation of the conotrungus, making the aortic wall coming into the RV, and that two coni, subaortic conus persist, subpulmonary conus, bilateral coni, and the parallel vessels, outlet vessels are parallel horizontally, side by side. That's a classical DORV. More than that, if the conotruncal rotation goes like this, and you can see the aortic wall is totally in the RV, and the pulmonary wall, subpulmonary conus disappears, subaortic persists, and pulmonary wall goes down to meet the mitral wall in the LV, and the parallel thing is anteroposterior gate vessels. That is a classical TGA. And next is what about the conotruncal septum? Very interesting. The simplest is a hole in the septum. You call it AP window. But when the entire coronal septum is absent, you will not have a division of the semilunar valves into two. There will be one big 3-5 leaflet wall called a truncal wall and a coronal defect of a VSD. That's a classical truncus arteriosus. I think with this, I think most of the lesions we have covered. 95% of the lesions occur in this 5th month of your life. And I wish all the very best to you. And I pray God that He will cut down the number of complications He created. So in the coming years, more and more, almost 1,000 hearts, He should make it all 1,000 hearts normally. Thanks a lot and all the best. Goodbye.
Much, Dr. Krishna Manohar. That was a very, very useful and very innovative and fantastic way of explaining things. Thank you so much, sir.
Oh, thank you, Jacob. Thanks a lot.
Next, we move on to the next talk. We would talk about a little bit about mediastinum, where the heart sits, and a little bit of the external morphology of the heart. Can we have the slides, ma'am, please? The mediastinum is defined as whatever is there between the two mediastinal pleura. So it starts from the thoracic inlet or the outlet, both the same, thoracic inlet and outlet, both the same, to the diaphragm. So arbitrarily, we divide it into a superior mediastinum and an inferior mediastinum. The plane of division is that which passes through the manubrioglandular junction and the T4, T5 intervertebral disc. So that plane divides it into a superior mediastinum and an inferior mediastinum. The inferior mediastinum consists of an anterior mediastinum, a middle mediastinum, and a posterior mediastinum. And we all love the middle mediastinum. That's where our interest is. So the middle mediastinum mostly consists of the pericardial cavity and the heart that it contains, and the proximal portions of the great arteries. When you do a stenotomy, this is what you see. So the heart, which beats, the pericardium, which is open. So this is what we see. You can see the cut edges of the pericardium. Most of what we see is the right ventricle. The LAD is seen there, and what is beyond the LAD is the left ventricle. A very small portion of the left ventricle is seen. The right ventricle, the right atrial appendage, which is the blunt triangle-shaped appendage, comes out and lies over the proximal ascending aorta. The aorta and the pulmonary artery, the great arteries, are seen exiting from their respective chambers. The aorta comes from within, and then it goes over the pulmonary artery. The base of the heart is towards our right shoulder. Okay, and the heart in itself is probably a four-sided structure. It's a triangular pyramid. So we have three surfaces apart from the base: the anterior sternal surface, the costal surface, and the diaphragmatic surface. So the sternal surface and the diaphragmatic surface join at the acute margin. The sternal surface and the costal surface join at the obtuse margin. So the vessels going on the acute margins are called the acute marginals, and the vessels going around the obtuse margin are called the OMs, or the obtuse marginals. There is an indistinct posterior margin, which is the margin between the diaphragmatic surface and the costal surface, but nobody really talks about it. All of us need to know the surface marking and the projection onto the chest wall, which actually is trapezoidal. So most of the heart, but the midline separates 1/3 of the heart, which lies on the right side of the midline, and 2/3 of the heart lies on the left side. So from the anterior view, what we see, as we said, is mostly the right ventricle, the right atrium and its appendage, with the SVC entering it. Okay, the great vessels also are seen, but nothing more than that. Slides are running away. Okay. So when we look at it from behind, we find the descending aorta. We also see the trachea and its bifurcation. So the trachea and its bifurcation are part of the middle mediastinum, and the descending aorta and the esophagus are part of the posterior mediastinum. So that's where the middle and posterior are separated. We can see the left atrium with its four pulmonary veins draining into it. Little bit about the aorta. The weak part of the aorta is called the isthmus of the aorta. That's where the ligamentum arteriosum is attached. So that is a little bit beyond the subclavian. And whenever you have a major trauma, say like a first rib fracture, huge RTA, you find that the dissections, traumatic dissections happen there. So that's the weak part of the aorta. So all of us should know which is the isthmus of the aorta. With a lot of interventions, we also need to know a little bit about the landing zones. So the zone 0 is up to the innominate. Usually the zone 0 landing happens proximal to the innominate. Zone 1 is somewhere in the region of the carotid artery. Zone 2, the subclavian. Beyond that is the zone 3. The Criado classification tells us that beyond the isthmus is zone 4. And the Ishimaru classification tells us that zone 4 is way down. So we need to know a little bit about the landing zone classifications, and I have illustrated 2 classifications for you. When you move the specimen of the heart, it's always good to hold a specimen of the heart, go down to the anatomy or the morgue, get a specimen of the heart and look at it. Turn it around. When you look at something, an image in the cath lab, and the camera is spinning around, we need to know what structures will be seen in what views. So when you go to a right lateral view, what's right at the back is the left atrium with its draining pulmonary veins, and what's entirely at the front is the right ventricle, and you can see the right ventricular outflow tract, pulmonary arteries swinging around the aorta there. So you see the entire RA with the RA appendage right towards you in the middle. If it's a little bit oblique, you see a little bit more of the right ventricle, and some of the LA disappears. When you look at it from the left lateral side, you find that the great vessels go around both your bronchus and your LPA. So you can see your pulmonary vein and your LPA end down in this view, and within the RVOT pulmonary artery coursing around, you find the left atrial appendage. Most of what you see would be the left ventricle, and that's the lateral wall. The obtuse marginals would be in that wall. Okay. When you look at it as in left anterior oblique, what's staring right at you would be the LAD. You see equally the both ventricles on either sides of it in that view. Looking at it from the top, you find the great arteries taking origin of the arch of the aorta. From the diaphragm, if you look at it, you find the inferior wall, the diaphragmatic surface, which is the left and right ventricles on either side of the interventricular groove in which the posterior descending artery travels. If we see, we should talk a little bit about the pericardium. So the pericardium has a fibrous pericardium, which is the tough collagen-rich outer layer, and the serous pericardium, which is the inner layer. The serous pericardium actually is like a bag into which the heart has invested itself and is of two layers. The parietal layer lines the fibrous pericardium, the visceral layer lines the heart and is also called the epicardium. So when you remove the heart, like as say a donor cardiectomy, this is what you see. So the IVC 4 pulmonary veins, they define the cul-de-sac, which is the oblique sinus, and behind the great vessels is what you see is the transverse pericardial sinus. So these two cul-de-sacs we need to know about. The finger is there in the transverse sinus. Okay, and when you lift the heart up, that's where the oblique sinus is. When you look at an X-ray, where do each of the chambers, where do each of the structures sit? That is something which is very important for us. So a projection onto an X-ray is something which all of us need to be familiar with. So if you see a bang anterior view of the heart, then you will, of the cardiac specimen, you will know exactly where each of the things sits. So this is something which needs to be in your mind when you look at an X-ray. This is a cross section which tells you how behind the sternum is the right ventricle. And especially in a redo situation, when you open the sternum with a redo saw, you need to know how far away the RV is, how far away the cardiac structures are. And doing a CT scan or an MRI will give you that much of information to do a safe stenotomy. I will now show you a couple of specimens to have a look at a few structures on the mediastinum. So this is how it all sits, right? So this is how it all sits. Okay, so we have the three lobes, the upper, middle, and the inferior lobe of the right lung, and the bilobed left lung. And this would be the diaphragm. Okay, so this is the diaphragm, and that has been dissected off, and the cut edge of the pericardium is here. Okay, so this would be the cut edge of the pericardium. Okay, so looking at it from anteriorly, you find the front of the heart. Most of it is the right ventricle, and that's the LAD. And this is the left ventricle, a little bit of it is seen beyond. Okay. So we were talking about the surfaces of the heart. Okay. So this would be the sternal surface. This would be the costal surface. So this is the obtuse margin, and it's obtuse because of this. Okay, this angle is obtuse. Okay, so that is why it's an obtuse margin. And this is the diaphragmatic surface. The PDA in the posterior interventricular groove is here, and this margin is the acute margin. So this is acute. Okay, this is acute. Okay, that is why it is acute. Okay, so this angle. Okay, so and this would be the more ill-defined posterior border. Okay, we don't need to worry about that. All right. So as we see from the front, we find that this is the SVC, which is entering the right atrium, the right atrial appendage, which is the blunt triangular appendage. The IVC enters here. Okay. So when you see it on a lateral view, you find IVC here, you find SVC here, and right atrial body. So this enters into what is called the sinus venera. This line here would be the sulcus terminalis. This groove is called the terminal sulcus. This is what corresponds on the inside to the crista terminalis, and all these would be the pectinate muscles going this way. When you come this way, when you look at the heart as such, this is how we see it on table. And when you dissect here, this is the interatrial groove. Okay, so this would be the interatrial groove. Okay, so that is the groove of Waterston, and the interatrial plane is the plane of Sondergaard. Okay, so the pulmonary. So the pulmonary veins are here, and this is the plane between the right atrium and the left atrium. And that is where you enter into the LA to do your mitral surgery. Okay, so that is the gateway to the mitral valve. Please have a look where my finger is. My finger is behind the great arteries. So this is the transverse sinus. All right. So this is the transverse sinus. When you lift the heart like that, that is the oblique sinus. Okay. Okay. So this is the oblique sinus. Okay. So the IVC, the four pulmonary veins like that, and this would be the left lower pulmonary vein. Okay, so that is the oblique sinus. Some people route their graphs through the transverse sinus sometimes. So you will find sometimes the rima going through the transverse sinus and getting to some of the lateral wall vessels. So we need to know all these pathways. Okay, so when you turn and go behind, you find this is the esophagus. Okay, so that's where the TE probe will sit. Okay, so that's the esophagus, and this is the descending aorta. Okay, so this is the trachea with the bronchial, with the carina and the bronchi. Okay, so the trachea bifurcates into the bronchi at the carina. The descending aorta sits over the left bronchus, and the esophagus is behind us. So these two are the posterior mediastinal structures, and the trachea and the bifurcation, along with the pericardial contents, are the middle mediastinum. the left bronchus is seen here, and that goes under the pulmonary artery. So okay, so this is the left pulmonary artery, and the bronchus is below that. So this is called a hyparterial bronchus because it is below the artery. So it's a hyparterial bronchus. In contrast to the right side, where the bronchus is above the artery and is called the eparterial bronchus. So the right artery is the right bronchus is the eparterial bronchus because it is above the artery. Okay, so the artery is below the bronchus on the right side. So I think this gives us a good okay. So looking at the superior surface, this is a thin tubular heart. Okay, one of those vertical hearts where you find those ECGs in a funny way. So here we find the great vessels, the innominate artery, the carotid artery, and the subclavian artery. Behind is the trachea. Okay, so the aortic arch with the three great arteries on top. Okay, if you look at it from the lateral side, you find the appendage here and the RVOT PA going around. The end-on view of the LPA and the pulmonary vein is seen here. Okay, that's the bronchus, pulmonary vein, pulmonary artery. Okay, so I think that should be fine as an introduction. We go on to the next topic, which is the coronary artery. So we will talk a little bit about the coronary arteries. My slide is not moving. Slide. What I will do. Okay, so we'll talk a little bit about the coronary arteries. And once we have a look at a few slides, I will show you the coronary arteries and its branches on a specimen. Okay, so we have the right coronary artery and the left coronary artery coming off their respective sinuses in the aorta. So you have the, let's talk about the planes through which these arteries traverse. Okay, so you have an atrioventricular plane and an interventricular plane. The atrioventricular plane, where the atrioventricular groove resides, that's where the right coronary artery and the circumflex artery go around. Okay, the interventricular plane, that's why you have the anterior interventricular groove and the posterior interventricular groove. The LAD goes on the anterior interventricular groove, and the posterior descending artery goes on the posterior interventricular groove. So we have what is called a circle and a loop concept. So we have a circle which is formed by the right coronary artery going around and the left circumflex going around. So this looks like a crown, okay? Which is why the coronary artery is called the coronary artery. Corona means crown, and this is the crown of the heart, and these arteries are called coronary arteries because they resemble a crown on the heart. Okay, the loop is formed by the LAD and the PDA. Okay, so this specimen shows the dissected vessels, the LAD coming around the pulmonary artery and entering into the atrioventricular groove. I'm sorry, into the anterior interventricular groove, and the right coronary artery coming around, giving off the acute marginal artery there. When we move the PA anteriorly and look at the aorta, we find the left main artery there coming off. As it comes anteriorly and laterally and goes inferiorly, it forms what is called an incisura. It gives off the LAD anteriorly and the circumflex into the atrioventricular groove, the left atrioventricular groove. The right coronary artery is seen there. It's a little diminutive in this particular specimen. It comes off the right coronary sinus. Both these arteries come off the sinus at the mid level. Okay, they come off the sinus at the mid level, which is the same level as where the leaflets are suspended. Okay, so the leaflet level and the mid coronary level at the sinus would be the same level. Okay, so here we have removed the RV-RVOTP area, and we can see the septals have been dissected. So the septal branches comes off into the septum. The diagonal branches opposite that get into the lateral wall. Okay, so here you can find the supraventricular crest, and just where the ventricular infundibular fold is. And when if you get outside through the above the ventricular infundibular fold, you will come to the area where the right coronary artery sits. Okay. We talk a little bit about the intercoronary anastomosis. Okay. The coronal arteries, one of the first branches of both the LAD and the right coronary artery is the coronal artery, and they communicate anteriorly, and that forms what is called a Vuissens ring. Raymond Vuissens was the Frenchman who described the anatomy of the heart, one of the earliest guys to do so. He did it in 1706, and he described this, the Vuissens ring. So we have three rings like this, which are collaterals between the right and the left system. The precoronal ring, which is the Vuissens ring, the retrocoronal ring, which goes behind the conus, and we also have a retroaortic ring, where the branch from the circ most likely, and the Kugel's artery from the left, and the branch from the right will communicate, and that is called a Kugel's ring. Okay, we talk a little bit about the sinus nodal artery. The first branch of the right coronary artery is the sinus nodal artery, and this normally encircles the SVC-RA junction clockwise, sometimes anti-clockwise, sometimes around. So these are some of the arrangements, and we need to be careful to avoid going across this when we make atrial incisions. Here you find the circumflex artery gives off a branch, the sinus nodal branch. Sometimes that happens as well. So these are the various ways in which the sinus nodal artery comes off. The atrioventricular branch comes off the PDA, where the RCA becomes the PDA, and at the crux. That is where the AV nodal artery comes off. So here you find the AV nodal artery coming off that area, and that supplies the AV node, which is in the membranous septal area or the right fibrous trigone area. Okay. So now we'll have a look at a specimen, and we'll have a look at the coronary arteries. Okay, so here we have dissected some of the coronary arteries. So we will start with the aorta. Okay, so this is the aorta, and inside you can see the. I'm very difficult, forget it. Okay, so the right coronary sinus and the right coronary sinus and the left sinus. You find the left main coming off the left sinus. This can be very short or as long as 20 millimeters. So it's about 2 to 20 millimeters in length. Here it's about 7 millimeters in length. So this gives off the LAD here and the circumflex here. So what is this fellow? This is the ramus. Okay. So you find it's a trifurcation. Okay. So here you find the LAD, the ramus, and the left circumflex. It's a trifurcation. Okay. So this is what we refer to as the incisura. When you have all the soft tissues around it, then it probably looks like an incisura. The LAD curves around the pulmonary trunk and gets into the atrioventricular groove. Okay, so this is the atrioventricular groove where the LAD sits. Okay, so we dissected a little bit to show you the septals. Okay, so that is the first septal artery. So can you see the first septal artery? So that gets into there. When you remove the pulmonary artery as in a Kono-Rastan operation or a Ross operation, where you want to switch, and then you need to be careful not to damage this. Okay, if you damage this, you get that bit of the septum infarcted. Okay, so septal artery, that's the first septal artery. Okay, so a lot of septals will come off this way. Okay. The diagonals come off this way. So this is the diagonal artery. So this is the diagonal. So the diagonals come off this way. Okay. In this particular case, it's a type 3 LAD which goes around the apex. So you find that the LAD has gone quite a bit around the apex. It goes almost up to here. So that is type 3 LAD. We saw that the right was a little bit smaller. So that from that we can infer that the left will be a little bit bigger. Okay. So here you find the ramus getting onto the lateral wall. The circumflex gives off the obtuse marginal arteries. So the obtuse marginal arteries come this way. Okay. And the circumflex goes around here and becomes off. Okay. So these are the obtuse marginal artery territory. Okay. Now we will look at the right coronary artery. So here we find the right sinus, right coronary artery going anteriorly, inferiorly, entering the atrioventricular groove. Okay, so that's the right coronary artery traversing the atrioventricular groove. This is the coronal branch. Okay, so are we able to see? That is the coronal branch which comes this way. So that will form the Fusens ring. Okay, so coronal branch coming anteriorly, so it comes to the RBOT side. The sinus nodal artery it's supposed to come from the opposite the coronal artery. Okay, so it's not present there, but the sinus nodal artery is there. So where does this fellow come from? If you trace this guy, you find that he actually comes off the circumflex. Okay, so for that we need to go behind the aorta, and you find that the sinus nodal artery actually is coming off the circumflex and getting here onto the right atrial appendage. Okay, so the sinus nodal artery. So that's the right atrial appendage, and that's the sinus node will be there, and the sinus nodal artery is here, coming off the circumflex, getting behind the aorta and getting onto the SA nodal area. Now, if you follow the right coronary artery, comes around here, then goes around the AV groove. Okay, so that's the right atrioventricular groove. Okay, and this is the crux. So this is the area crux where it turns down into the interventricular groove posteriorly. Okay, posterior interventricular groove. This is the PDA. Okay, so RCA becoming the PDA here. Okay, this is the diaphragmatic surface of the heart. Here, if you dissect and see, you can find the AV nodal artery. Okay, so that is the AV nodal artery. So that comes off at the crux, gets into the AV node. The AV nodal artery is given off by whichever is dominant. This is a right dominant system. So the AV nodal artery comes from here. Okay, so how do you figure out the dominance? The right artery has to come down up to here and then go beyond and give a posterolateral branch. That means it's a right dominant system. If the PDA comes off the circ comes like this and gives off the PDA, then it is a left dominant system. If the last branch of the right coronary artery is the PDA and the PLB area is supplied from the left, it is a co-dominant system. Okay, so I think this is probably the best way. Many textbooks say many things, but I think we will stick with this. PDA coming off the right, and one more artery beyond that, the PLB also coming off the right, means a right dominant system. The PDA being the last branch means it's a co-dominant system. If the PDA comes off the circ, it means it is a left dominant system. Okay, so I think that would be how we would divide it. Okay, so I think that we've decided, we've demonstrated all the branches of the coronary arteries. Now, how do we view the coronary arteries in a cath lab? So that's the next step. So let's have a look at that. Cath lab. So this is our cath lab today. So this is the patient. Head end would be the cephalic end or the cranial end, and the leg end is the caudal end. And that's the left and this is the right. So this is our cath lab camera. Okay, so this here at the bottom is the gun which shoots the X-rays. Okay, and this here is the camera. So we are the camera. So who are you? How do you view things? We view from the camera. We forget the gun. Okay, now don't even think about the gun. Think only about this. We are the camera and we are looking at the patient. So how are we looking at the patient now? Anterior. So if you take a straight shot like this, that's an anterior view. It's an AP view. Okay. And if you move like that to the left, it becomes a left oblique. And if you move more, it's a left lateral. Okay. And if you move towards this side, it becomes a right lateral. Okay. So wherever the camera is, that is how you view it. Okay. So that would tell us a right oblique or a left oblique view. Okay. So only think about camera. If you move the camera cranially, it becomes a cranial view. And if you move the camera caudally, it becomes a caudal view. Okay. So you can combine both. Okay. So if you need to have a cranial and a lefted, so this would be iliocranial, and say you go this way to be iliocaudal. Okay. This would be right, and this would be a right araeocranial or araeocaudal. Okay, so these are all the different views in which you would view the coronary artery. So I would show you a wire model of coronary artery. So depending on how the shadow falls, we can figure out how the angiogram will, or what the angiogram will look like. Okay, so this is a wire model of the left system. You have the left main artery here and the lady there giving off the diagonals on one side and the septals on the other. And this is the circumflex artery giving off the obtuse marginals here. We also have a model of the right coronary artery. So this is the RCA and this is the PDA. We also have a PLD a bit beyond that. Okay, so when you run it, go back, I think. Go back to the previous slide. First slide. This little video is there to show you what it looks like on a LAO and an RAO. So we're moving around. So here the spine moves to the left and it's an RAO view. If the spine moves to the right, it's a LAO view. Okay, so by looking at the spine, we know what view it is. Okay. Next one. So this one would show you a caudal and a cranial tilt. When you tilt it cranially, you see more of the diaphragm. So as you go up, you see more of the diaphragm. And when you tilt it caudally, the diaphragm moves away. Okay, so that is how, with the presence of the diaphragm, you can say it's a caudal view or a cranial view. So combining these, we know from the spine and the diaphragm what view it is. Okay, next. So if we need to show an RAO cranial view, so how would we do that? So this would be a RAO cranial view. Okay, so we view it. So normally it would be like this. That's the okay. So we move it this way. So that's the right and a bit of a cranial tilt. Whenever you tilt the camera cranially, you see the mid and distal portions of the blood vessels better. And whenever you tilt it caudally, you see the proximal portions of the vessels better. Okay, so that is something you need to remember. And shall we have a look at an angiogram? So this is the areocranial, and here you find the septals to that side and the diagonals to this side. The mid and the distal part of the LAD being concentrated upon. Okay, good. So next one. So this is the LAocranial. So we move it to the other side. Okay. So now in this view you find all your diagonals being focused on. Okay, angiogram. So in an LAocranial, you get into this lateral wall and you look at your diagonals here. Okay, so that is, this view is for that. Okay, good. Next one. So now let us tilt it a bit more caudally. Okay, so when you tilt it caudally, you find your left main and your proximal portions of the LAD and the circ getting into better view. Okay, so this is the spider angiogram. So here you find the left main and the LAD that way and the circumflex this way. So in this spider view, you see the proximal vessels and you can find out what disease is there in those areas. Next one. Okay. So this would be a areocaudal. So when you move the whole thing, caudal, you tilt it a bit caudally and move it out, you get into the OM territory. Okay, so this view is for looking at the obtuse marginal arteries. Next view. So here you find all the lateral wall vessels, the obtuse marginal arteries being seen better. So this view would be for the obtuse marginal vessels. Next one. Okay. So now we go into the right coronary artery. So a plain RAO will show the atrioventricular group thus. So you find a more straight right coronary artery. If you need to show the right coronary artery a bit better, you need to move to the left side. So LAO view will show you the artery as a C, and an RAO will be more like this. And in an RAO, you find that these two vessels will kind of overlap each other. Angiogram. So here you find the right coronary artery, which is more as a straight line, and here these vessels are kind of overlapping each other. To concentrate more on the lateral view, we would move it even a little bit more thus. Okay, so this view would show us the mid portion of the coronary, of the right coronary artery. This view is for finding disease in this area and stenting that. So a lateral view. So here you find the lateral view and it shows the mid RCA the best. Okay. So now next. So you move on to a LAO cranial tilt, and here you find that the PDA and PLB vessels separate out. So when you tilt it this way, if you don't have a tilt, they overlap, and when you tilt, you can separate out the PDA and the PLB and have a look at these vessels. So here you find the PDA here and the PLB there, and by tilting it cranially, we separate out these vessels. So now I think we will go ahead and complete the PowerPoint presentation. This diagram shows us both a cross-sectional view and a longitudinal section view of the heart. So we know which part of the septum is supplied by which vessel. The orange is the LAD, so that goes around the apex, and the mid portion, mid-posterior walls being supplied by the circumflex arteries. The anterolateral papillary muscle is supplied by the obtuse marginal or a big diagonal, and the posteromedial papillary muscle being supplied by that blood vessel which goes in the posterior interventricular groove, the PDA. So if it is the right PDA, it would be supplied by that. If it's a circ PDA, it would be supplied by the circ. Next. So here we have a 2-chamber view and a 3-chamber view. And here we find that the mid-septum and the basal septum being supplied by the PDA, and the entire, the upper 2/3 of the septum being supplied by the LAD. The coronary artery study, surgery study, they have put in a classification in wherein they have numbered all the blood vessels. So knowing that would be a good thing for us. I would show you a little bit on how you would look at the blood vessels when you do an off-pump coronary grafting. Okay, so here in this slide, you find we are between the two inferior pulmonary veins, and we are taking a bite there to pitch a gauze strip there. So this will help us to verticalize the heart or move the heart around to the different positions to do our grafting. So you have a little tunicate which holds this gauze in position. The vectors that would act on the heart are these. When you pull the rubber tunicate, it moves in this direction of the arrow. The other arrow shows us the way the heart will be pulled when you pull the gauze strip. And the resultant vector is this, moving the heart in that direction, which is opposite. Okay, so we move the pericardium behind the heart and we shift the heart out to the different positions. So when you just pull the rubber tunicate and do not do anything to the gauze strip, the LAD comes into view. The heart gets elevated and beautifully brings the LAD right into view. Here you find the LAD being positioned with a stabilizer, the rubber tunicate being taut, and nothing done to the gauze strip. So that's the LAD. When you want the lateral wall vessels to come into view, this is what you will do. Slides running away. Okay, so when you pull the gauze strip a little up, the diagonals come into view. And when you pull the gauze strip much more, the obtuse marginals would come into view. Okay. So here you find that the entire heart has been verticalized and the posterior interventricular groove is being stabilized. So we are stabilizing for the posterior descending artery here. So you need to tense both your rubber tunicate and your gauze to elevate the heart thus. And this is a verticalized way of doing a PDA. Sometimes without these rubber tunicates, you can do an early PDA by just tilting or lifting up the acute margin with your hand. And for that, you do not need this tunicate. This is to verticalize and do it in an upright position. Here you find the obtuse marginal. This is the last OM being stabilized. So here you find the obtuse marginal being stabilized. Okay, so I think we have talked a little bit about the coronary arteries. We had a look at all the coronary vessels and their branches. And now we will talk a little bit about the venous drainage of the heart. So the coronary venous drainage follows 3 pathways. You have the coronary sinus and their tributaries, the anterior cardiac veins, and the venae caudas minime, okay, or the Thebesian veins. Okay, so the coronary sinus and the tributaries. Okay, here we are. The coronary sinus. Okay, all these vessels follow the coronary arteries. and in the reverse way. Okay, so the anterior interventricular groove has got the great cardiac vein, which follows the LAD. Okay, so this great cardiac vein collects all these branches from the diagonal artery, etc., goes up, turns around into the left groove, and as it does that, it collects all the veins from the left ventricle. So you have the lateral vein, you have the posterolateral vein, etc. As it turns around, an important vein or an obliterated vein enters from the left atrium. That is the oblique vein. So this oblique vein of Marshall, once it enters into the great cardiac vein, it becomes the coronary sinus. Okay, so that's the obliterated common cardinal vein or the duct of Cuvier. So this guy is seen there, and as it enters, it becomes the coronary sinus. Few branches enter into the coronary sinus. The important ones are the middle cardiac vein, which has followed the PDA, and the small cardiac vein, which comes from the right atrioventricular groove. So this is the structure of the venous drainage of the heart, and most of the drainage happens this way. This picture shows the oblique vein of Marshall there entering into the great cardiac vein, and it becomes the coronary sinus. In that region, you find a little dimple sometimes, and that is caused by the venous valve of Vuissens. So this valve is something which sometimes gives trouble to the interventional cardiologist as he tries to place a coronary sinus catheter. This valve is divided into 5 types. It may have 1 to 3 leaflets, and the leaflets may be flat or concave, and the combination giving you the 5 different types of the valve of Vuissens. Below the Thebesian valve, you find, or the coronary sinus orifice, you find a pouch on the right atrial wall. And this subthebesian pouch, or the pouch of Keith as it is called, is an area of arrhythmias. So when you do an RFA, you need to be aware of the subthebesian pouch, which is in this area below the Thebesian valve. Okay, the anterior cardiac veins are the veins which drain the anterior right ventricle, and they may enter as one or multiple veins into the right atrium. The venae caudas minimae are the small veins which enter from the chambers from the individual chambers. They are present more in the atria than in the ventricle, and more on the right side than on the left side. Okay, so in this one, we find a little, find the coronary sinus being injected, the posterolateral vein, the area of the obtuse marginal arteries, the lateral wall, that is where one would place the left ventricular catheter or the coronary sinus catheter when you do a CRTD. So here you find those leads which have been placed in these respective vessels. So you have one lead in the right atrial appendage, one in the RV apex, and the other one is what has gone through the coronary sinus into the posterobasal vein. So here you find a recapitulation of all the different veins. That's the middle cardiac vein. The posterior cardiac vein, we are going reverse from how we described it earlier. So coronary sinus, middle cardiac vein, posterior cardiac vein, posterolateral cardiac vein, the lateral cardiac veins. So we're moving anteriorly now, and the great cardiac vein. So that's in the reverse. That's the anterolateral cardiac veins. So this model tells us how the different veins. So as the catheter goes in, these veins would come one by one. So that's how this model has been viewed. So this tells us all about the coronary veins and how they have been placed. So now let's go into the different chamber anatomies. And we have Dr. Hiramat with us, who would tell us now about the right atrium. Over to Dr. Hiramat.
Good morning, At the outset, let me thank Dr. James Jacob and his entire team for organizing this event. In fact, it's the 12th morphological event which he has been conducting live, and I've been attending almost most of the sessions. And it's quite informative for all the residents, and especially those who have just joined the courses, wherein to know the exact anatomy of the heart, different views. This time, a topic allotted to me was right atrium, and I've tried to make it more simplified and more clinically oriented. I hope you are able to see my slides, sir. Are my slides visible?
Yes, sir.
Yeah, thanks. No conflict of interest. To the positive operative photographs, I have restored to illustrations to make this presentation. Now, an outline, I would like to go on these headings. One is the embryological basis. Second is on situs and position, boundaries and its neighbors, and surgical considerations. The embryonic mesoderm differentiates form the cardiogenic tubes. As we already had a class on embryology earlier, the first class, I'll just brief it. The two cardiogenic tubes fuse into a single tube, that's the heart tube, and about 2 weeks, the tube with bulges is visible. The tube contains 5 distinct bulges. That is truncus arteriosus, bulbus cordis, ventricle, atrium, and sinus venosus. All this gets completed by 23 days. The precursors of the right atrium are mainly the atrium and the sinus venosus. The primitive atrium chamber mainly gives rise to the anterior segment of the atria, the horns of the atria, that is the auricles and the appendages. And the sinus venosus part mainly gives the posterior segment of the right atrium, the SA node, and the coronary sinus. The tube starts forming by the 22nd day. Heart beats for the first time. In fact, this is the MCQ question. When does the heart start beating? At the 22nd day of the embryo, the heart starts beating. However, 2 distinct chambers are separated only by 28th day. The right atrium and the right ventricle are not intrinsically connected. The tertiary atrioventricular self seals off the right atrium from right ventricle precursors to the tricuspid atresia. Right ventricle. In fact, it's a precursor to tricuspid atresia. It's a very important finding. What I would like to describe it as. If you see this diagram, this is the right atrium, the left atrium, and the ventricles. And this is the shelf, what I was telling you. And this shelf normally gets regressed. Failure of this shelf to get regressed leads to tricuspid atresia. Let me explain it much better. And I would like to thank Dr. Anderson for sharing this slide. The right atrium and the right ventricles are not intrinsically connected initially. The tertiary atrioventricular self, which I showed now, seals up the right atrium from the right ventricle. If it fails to withdraw, then it causes tricuspid atresia. All the blood flowing from the right atrium is dispersed into the left atrium. This lays the basis of the right to left shunt during development. The tertiary self gradually resides as the atrioventricular complex has developed and great vessels have turned and take their place. This is another slide which I had to borrow from Dr. Anderson. And here's the anatomy. You see the SVC, right atrial appendage, the SA nodal artery, which the area of terminal sulcus, and the AV group per se. Now coming to components of the right atrium. The right atrium has an appendage, the body, septum, and venous connections and the vestibule. The appendage is the most constant feature of the heart. The situs and the morphology are assessed by the format of sequential segmental analysis. The right atrial appendage, if you see my operative photograph here, it's rough, that is pectinated, wide mouth, and triangular. You can appreciate the appendage here. And to be on the lighter side, I have compared it with 2 noses who are the most common figures. This is on a lighter note where they were quite rough and tough politicians with a wide mouth. In fact, if you see the noses of, I think everybody knows who is he. He's Akhilesh Yadav and late Prime Minister of India, Mrs. Indira Gandhi. And if you see the nose of the appendage, it's almost similar to that. Now, what's in the appendage? The most consistent entity to establish the ground for isomerism and heterotraxy. The clear distinction in length to orifice and gross appearance are illustrated here. That's the right appendage and that's the left appendage. Now, posterior intra-atrial groove is the extension of the septum posterior to the atria. That is a Watterson or Sondergaard's groove, what we call it as, is posterior to the intra-atrial groove. Note the zone of confluence of the SVC to RA and the pulmonary veins to the LA. Extension of the septum posterior to the atria, that is a Watterson or Sondergaard's groove, what we call it, approximately 5 millimeters of this confluence marks this groove. Coming to the arterial supply, predominantly it is supplied by the branches of the right coronary artery. Lateral surface by the intermediate atrial branch and the AV group through the RCA, and the posterior surface is ramus ostia cavo superioris. The medial inner surface by the AV nodal artery. But the venous drainage is the Thebesian veins or vena cordis minimi, anterior cardiac veins, coronary sinus confluence of the great cardiac veins, middle cardiac vein, and small cardiac veins. The rest of the population can have a varying configuration of the node, with the most common anomaly being the horse junction that embarks on the terminal sulcus and the SVC. This is notably known as the horseshoe node. This is the normal location. In about 90% of the population, the node is entirely lateral to the SVC-RA junction. The rest of the population can have a varying configuration of the node, with the most commonly anomaly being the horseshoe junction that embarks on the terminal sulcus and the SVC. This is notably known as the horseshoe node. The iatrogenic impacts of the horseshoe node at the atrial area, this commonly happens especially while insertion of a cannula through the right atrial appendage. We as cardiac surgeons normally cannulate even the right atrial appendage or SVC or and the IVC. So especially while going through the RA appendage, the cannulating can injure the nodal artery. That's one thing one has to be careful. Or even by the process of snaring the artery, snaring the SVC, you can injure the SA node. Various combinations do happen during the process of blood supply to the SA node. It can exist. Conventional understanding has been that of the ramus ostia cavo superioris is the response for the blood supply to the node. Newer diagnostic tools have enabled simplification with two parameters that can be factor. Who is the parent coronary artery one has to look into, what course it takes, that has to be taken care. Make an attempt to assess the arterial supply to the SA nodal area as soon as the pericardial stays are taken whenever we are doing an open heart surgeries. Due diligence can spare the patient from unnecessary morbidity. Now, the parent coronary artery, it can vary at different places. This is just an illustration diagram what we have drawn, and that is the SVC RA node junction. This is the SA nodal area, the SVC and the RA. This is the LA. The aorta will be here, and the pulmonary artery. Now, you find the left main coronary artery giving rise to branches to the LCX and the LAD, and also to the, and we have the right coronary artery rising from the right coronary ostium. Now, combinations of blood supply I will show you, where branches from the right coronary artery can arise, which is quite common. The next is the branch from the proximal left circumflex artery. As you see, the yellow line what we have drawn is the artery supply to the SA nodal area. One has to be familiar with these variations. Next is branch from the distal LCX also can arise, and branch from the left main coronary artery itself, or branches from the non-coronary sinus. Separate artery can arise to the SA nodal artery, or a dual origin both from the right coronary artery and the left coronary artery. And how does it course the site of origin from once it arises? Either it can go to the retrocaval course or anticaval course. It can come in front of the SVC or go around. And exercise caution before atriotomy with careful inspection of this vessel. Sometimes it can go circumferential also. And this one has to be careful of the external artery, mainly because of various surgeries, especially the sinus venosus ASD closure or in a Warden's procedure. One has to be careful. Not only that, and whenever we need to do any surgeries related to the right atrium, when we open the right atrium or cannulations of the SVC, one has to be familiar with this course. Coming to the interior of the right atrium, pectate muscles are seen there with the acute marginal border, SVC, and the right atrial appendage. We have cristae terminalis, which is marked clearly. And one has to be careful when we use RAs in right atrial aneurysms and all, when we try to excise the right atrial wall in the process of reduction of the RA per se, one has to not cross the cristae terminalis. We end up crossing here, we end up having arrhythmias in the postoperative period, and the atrial kick sometimes if we end up losing it because we end up in disturbing the conduction system which runs from the AV node, SN node area to the AV node area. So any cutting work we need to do, sometimes we use ASD patch using the right atrial appendage also. And that time we use only the area of the pectinate muscle area, not the, we never go this area. This part of this muscle is taken off, the wall is taken off, and we can close it, the right, the ASD can be closed with that technique. So one has to be familiar with this. And the eustachian ridge, which I'll come to it later, the Sebastian valve, which helps to cover, which guards the coronary sinus. The tricuspid valve has been seen. What is aortic mound? Red area, which I have drawn here, shows this is the aortic mound, which is very important, which many of us need to know about it. In the opening of the right atrium, on opening, it reveals a muscular prominence at its floor of the right atrium. People, either even anatomical dissection you can see on a cadaveric heart, or I would request students to go back once they are in the OR, and when the right atrium is opened, you can ask your professors to show which is the aortic mound. Now, what is the importance of this mound? This prominence overlies the root of the aorta and the central fibrous body. To the left and inferior of the tricuspid valve is the aortic mound. Left and inferior, that's very important. This is a separation between the non and the right coronary sinus and the right atrium. Terminal cristae between the rims of the openings of the SVC and IVC and the orifice of the coronary sinus, cristae terminalis springs from within the atrial appendage. This is where the cristae terminalis springs into. The atrial vestibule, insertion of the atrial myocardium and the cristae to the fibrous skeleton. That is the atrial vestibule, what you can see here. The body of the atrium, the areas of insertions of the vestibule, and the true atrial septum. The posteriorly, the atrioventricular groove we have. Coming to the muscular AV septum, that is the inferior isthmus, what we call it as. The muscle bundle widens into a broad strip that runs alongside the triangle of Koch, erstwhile known as the area of the muscular atrioventricular septum. The muscle bundle widens into a broad strip that runs into a septal leaflet of the tricuspid valve, forming a muscular area of variable dimensions that separate the attachment of the tricuspid leaflet from the coronary sinus and the fossa ovalis. This is the inferior isthmus, which is continuous superiorly with the septal part of the tricuspid vestibule that overlies part of the ventricular septum and therefore separates the right atrium from the left ventricle. We used to call this area the muscular atrioventricular septum. What is the surgical importance? I'll come to it. This is the aortic mound, what I mentioned, and that is the inferior isthmus. What is true septum? A note of caution for atrial septectomy or BAS. BAS is the atrial septectomy where we normally do, especially in cases of TGAs, wherein when we want to stabilize the child or to gain some time to go for an arterial switch, we do end up doing an atrial septectomy. And in this, one has to be familiar to know what is the true atrial septum. Sometimes what happens, we end up entering the false septum. Now, this is the communication still within the heart, what I would like to show. And this is where we end up communication with the extracardial space while creating a BAS, that is atrial septectomy. And in such conditions, we enter outside the heart and we cause hemopericardium and end up losing the child. And that is the pseudoseptal fold, which sometimes cardiacs also get confused on a cath lab, wherein we end up opening the pseudoseptal fold. Ideally, it should be the true septum, which has to be opened when you do a BAS. Coming to Gerber defect, there is incomplete muscularization of the inferior isthmus. This is what I was talking to. One has to know what is the isthmus, inferior isthmus, which when it enables, it causes the left ventricle to right atrial shunt. That is a pre-tricuspid shunt. In fact, this comes into one of the pre-tricuspid shunts, wherein the Gerber defect, as you see here, is seen, and this is the operative picture, wherein just it is at the inferior part in inferior isthmus area. This is the VSD, the left ventricle to the right atrial shunt, what we call it as a Gerber defect. Coming to other surgical considerations, the tendon of Tadaro. In fact, this is a short note triangle of Koch, tendon of Tadaro and all. This is a self-explanatory picture when you find this tendon of Tadaro. Now, they may ask you, what is tendon of Tadaro? Tendon of Tadaro is a remnant of Eustachian valve. I will show you in the next picture. The remnant of Eustachian valve is the tendon of Tadaro. One has to be very clear what is tendon of Tadaro. And this is the coronary sinus, and this we call the triangle of Koch. This is septal reflective the tricuspid valve, and invariably the AV node seats here. This is a diagram which we have drawn to show. And if you see, I have put a hook at the Eustachian valve. You are not seeing the tendon of Tadaro now. When we retract the Eustachian valve, tendon of hook retracting, the ridge becomes prominent. The tendon of Tadaro becomes prominent once we hitch the Eustachian ridge, and it becomes prominent. And there you see the triangle of Koch and the AV node. One has to be careful. In fact, I keep telling my students while closing an ASD, which is the commonest surgery what the residents start with, and also what we have started with, we should not hold the medial margin of the ASD with the pickup. That's what we'll be telling, because this is the area where the bundle runs and we do not know how the fibers run in each and every case. One case you hold, you may escape. Invariably, you have arrhythmias in the postoperative period. So avoid holding it, just support it and take your bites there. That's what we advise. Coming to other surgical importance in right atrium, aneurysm sinus of Valsalva, how it is related to the right atrium. Now, as you see, the aortic mound, which I was telling, what is the surgical importance of this mound? As we go, this is a CT scan image wherein you find the trisynostral arrangement of the relations of the right atrium, right coronary cusp or non-coronary cusp, and the left coronary cusp. Now, that is the right atrium, right coronary artery, and the right AV groove. This you can see it's unruptured. It's not ruptured. It's the unruptured sinus of valsalva aneurysm. And if you see the bulge here, it bulges into the right atrium. The bulge happens at the aortic mound. Rupture occurs in the aortic mound, just superior to the tricuspid valve. If you have seen the RSOV rupturing into the RA, that's the aortic mound area. That's why it's been mentioned like that. And it ruptures there, and you can define, and we need to close both ends. RSOV is handled but both ends. One from the aortic end, you put a patch, and even open the RA and put a patch at the aortic mound. One has to be careful not to injure any of the conduction systems there. Coming to other surgical importance of the RA. As everybody knows, Rowan Nix aortoplasty for enlargement of aortic root. In fact, it is one of the aortic root enlargement procedures which has been described by Rowan, and wherein we make a nick in the non-coronary cusp, just stopping short of the mitral annulus. It's a midpoint of the non-coronary cusp where the Nix procedure is done, where we can increase the valve by a size in a small aortic root. What happens if the incision extends beyond the margin, rising, opening to the right atrium? We end up opening the right atrium. As you see here, NCC, as you open down, suppose at the same time when you do the other procedure, that is the Siebold-Epting Manoogian procedure, wherein we open through the non-coronary cusp and the left coronary cusp, we go down here. When we go down here, we open into the AML. We deliberately open to enlarge the aortic root to put a bigger size valve. Similarly, here in relation to the right atrium, when we open into the non-coronary cusp, we open further down, we end up opening the right atrium. That's the right atrium, and that's the non-coronary cusp. So one has to be careful. You can't extend your non-coronary cusp incision down into the mitral valve area. Otherwise, you end up opening the right atrium, causing a aorto-right atrial tunnel or a fistula-like picture. What are the other surgical considerations in the right atrium? I think everybody can identify him. He is Dr. Cabral. A Cabral fistula. Cabral's fistula, what we call it as. The fistula was the last resort to address uncontrolled bleeding in ascending aortic aneurysms and in any of the root procedures. So in such conditions, it is better known as a perigraft RA shunt. It can be performed either by enveloping the root with the native aorta and anastomosing a PTFE graft around 80 mm from the perigraft space to the right atrial appendage. I think many of them would not be knowing this procedure. It's not done routinely now because of the advanced techniques and availability of various hemostatic agents, and the technique per se, the operative techniques per se have improved over a period of time. Alternatively, it can be performed by retracting the RA roof or the RA appendage, incising the roof and connecting the site of bleeding to the right atrium. This is an operative picture. I got it from How Does a Cabral Fistula Look at Reoperation from Annals of Thoracic Surgery in the year 2019. And you can appreciate that's the aneurysm area which is covered, and from there he has put 8 mm graft into the right atrial appendage. This is the perigraft space. These were techniques which were followed earlier, and even some of surgeons, even today, they end up doing this, wherein they cover it, and so that the bleeding per se, without having much blood loss, they end up directing into the right atrium. And over a period of time, the bleeder seals off slowly. Apart from this, preload should not translate into overload. If you see, this is normal chest X-ray. The right atrium, you can see here, this is the right atrium. But if you have something like this, what is this? Wherein this is a case of a right atrial aneurysm. In fact, it was I had submitted a series of cases in our institute, right atrial appendage aneurysm, published last year only in our journal. So, congenital weakening of the atrial myocardium can occur, and is usually a precursor for development of aneurysms of the atrial appendage, which is very phenomenal. And patients invariably present with arrhythmias. They invariably present with various kinds of atrial arrhythmias, and once that is taken care, usually it's a very drastic recovery what we see after the atrial appendage aneurysms or atrial aneurysms are taken care of. This is the MRI picture. You see how large the right atrium is and the aneurysm part. And now coming to other aspects, surgical aspects of right atrium, I would like to emphasize on the various incisions what we put normally. This is the common site, right atrial appendage area, where we cannulate the right atrium, and dissection of the Sondergaard's groove. I think whenever you want to open the left atrium, we do dissect, and we try to get an additional margin, especially when it is a small left atrium. We try to dissect that groove area, and we have an access to the left atrial also. And the other standard incisions parallel to the AB groove for any approach to the right atrium, either closure of an ASD or closure of a VSD can be done. Another superior sagittal incisions are done, especially in approaching the biatrial approach for the mitral valve, where we from the RA go to the roof of the LA, and then we do it a biatrial approach. And other incisions are mainly for PAPVCs and supracardiac PAPVC, the shoemaker's technique, wherein a transverse incision is made from the appendage down, go into the right atrium and across the ASD into the left atrium, and we open it. Other incisions like sending atrial switch parallel to the interatrial groove, limiting between the crystal terminus and the eustachian valve, very important because the incision on the right atrium matters a lot in creating a flap in the sending atrial switch procedures. Mobilization of Sondergaard's groove provides additional length of the septal and the atrial flaps, which causes a relatively unobstructed flow for the venous drainage. The procedures like the maze procedures, as you see, either it's a cautery maze or a cut and sew techniques. We excise the appendage area and we sew it, or from SVC to IVC area also, we end up incising and resewing, or even the cautery maze or the radio ablation technique can be utilized. To conclude, right atrium is diverse in its relations to functional and anatomical components of the heart, which is explained by embryological model of the heart tube. Atrium consists of functional and anatomical landmarks within itself and is characteristically defined by its body, appendage, venous component, vestibule, and the septum, which I explained in detail. The Cox triangle is one has to be very much familiar as a cardiac surgeon. It's almost always consistent, except in case of IVC interruption, complete AV canal defects, or character transpositions, where the architecture and the fibroskeletal ring is itself modified. That time, the Cox triangle gets varied. And the definition of a true and spurious septae are crucial markers to avoid making simple procedures rather complicated. The aortic root atrial arrangement can be pathologically managed or surgically modified to patient's advantage. Thank you.
Thank you, Dr. Hiramat. That was indeed a very lucid and very illustrated talk. Excellent. Thank you so much.
Thank you, sir.
For the next cardiac morphology, actually, we are planning to have a history special, which means we will also talk about how these structures came to be described and who are the guys behind it and what they thought and how they arrived at what they arrived at. So that would be a lot more interesting. Hiramat has done a lot of look into the history as well. So he has been part of us for very many years. So thank you, Dr. Hiramat. Thank you so much. Next, we have Dr. Vijit Cherian to talk to us about the tricuspid valve. Dr. Vijit, Chief of Surgery at the MIOT hospitals. Over to you, Dr. Vijit.
Good morning. Good morning, friends. So my topic for today, I hope you can see my screen. Jacob?
Yes, sir.
Hello?
Yes.
Yeah, okay. So my topic for today is the tricuspid valve. The tricuspid valve is a complex anatomical valve, and it is a valve which has been neglected for many years. You'll be surprised to know that even the anatomy of the valve was studied relatively late. And what they found was it's a complex 3D structure which consists of the leaflets, the anterior, posterior, and the septal leaflets, the chordae tendineae, the two papillary muscles, which are the anterior and the medial papillary muscles, the fibrous annulus, and the right atrium and the ventricular myocardium. So if you look at the anatomy, it is a structure which is surrounded by a lot of what Dr. Hiramat was talking about. You have the tendon of Todaro, the coronary sinus, the AV node, and then the rest of the right atrial structures like the right atrial appendage and the myocardium, the right ventricular myocardium. The three leaflets of the tricuspid valve, the anterior leaflet, the posterior leaflet, and the septal leaflet, are not exactly equal as you would see in this picture. It's largely composed by the anterior leaflet, and then a smaller portion of it is the septal and the posterior leaflet. It is important to note here that it is a 3D structure. So there is, you know, 2 points where it is high and another 2 points where it is low. It is important to understand this 3D configuration of the tricuspid valve. We were treating this as a 2D structure for many years, and it's with a lot of studies which came later that we realized that the functional tricuspid regurgitation occurs when there is when the 3D structure of this tricuspid valve is essentially lost. If you see in the right diagram, there is a flattening of the tricuspid valve. So this is what the normal tricuspid valve would look like. It's a little saddle shaped, while here it is flattened out. Now, it is in close relation to the aortic valve, as Dr. Hiramat had just emphasized. This is the aortic mound. It is in close relation to the AV node and the membranous septum. And the right coronary sinus and the non-coronary sinus are closely associated with the tricuspid valve. The anterior leaflet and the posterior leaflet are
Dr. Vijit, sir.
yeah.
Slides are not changing, sir.
Okay.
Go on slideshow view.
Yeah, just 1 minute.
Yes. Yes.
Is that okay?
Now it's okay, sir. It will be better if you use a slideshow view.
Can you see now?
Yes, sir. Sir, we are seeing the screen, sir. We are not getting the full view, sir. A slideshow.
Yeah. My screen is full slideshow, but I don't know, it's not properly transmitting. You know?
Okay, sir.
So, can I stay like this, because it's not on my screen slideshow. So
Okay, sir. Okay, sir.
yeah. So I will stay like this so that
Okay, sir.
we are probably not moving it. Yeah. So in relation to the tricuspid valve, the aortic mound and the AV node are very closely related, and here you can appreciate that the septal leaflet is in close contact with the AV node, which is at the apex of the triangle of Koch. The bundle of his, the AV node are again it's very important to understand this relationship with the septal leaflet, as all our interventions on the tricuspid valve, this is the area of the septal leaflet, which is almost about 30-40% of the septal leaflet. There is a danger of damaging the AV node. So it is in 2006 that an article by Fukuda in Circulation, which clearly demonstrated this 3D anatomy of the tricuspid valve, and this I showed. In the next slides I will show which are the high points and which are the low points. So you can see the saddle shape of the tricuspid valve, which gives it its integrity and its valve function. The tricuspid annulus is an elliptical structure. So what you see here, it's an elliptical structure, and the moment there is a dilatation of the posterior and anterior annulus, then it becomes a more or less flattened out. And the high points are basically the um, you can see these 2 points, which are towards the aortic valve and somewhere in the middle of the posterior leaflet, and the lower points are in the septal leaflet and the middle of the anterior leaflet. So this is something important to understand, that this structure, when once it starts dilating, it comes on to becoming a flat annulus, and it loses its functionality, and there that is when you get a functional tricuspid regurgitation. This is a normal tricuspid annulus, where you can see the high points close to the aortic mound, and here close to the anterior and posterior commissures, and the low points is the septum and the middle of the anterior leaflet. In most of, as you know, most of the tricuspid anatomy, I mean, the pathology that we see is a functional tricuspid regurgitation. So the anterior and the posterior areas, which are devoid of the fibrous skeleton, is where the dilatation takes place. So there is an expansion of these areas, and you get a functional tricuspid regurgitation because there is failure of coaptation. This diagram shows the asymmetrical dilated annulus when you get ventricular dilatation, and consequently you have annular flattening. So this saddle-like structure becomes more and more flat. The pattern of annular dilatation, like we had seen earlier, you can see in this diagram. This is the central fibrous skeleton. So this septal area remains non-dilated. This is important for a surgeon to know, because when you do your repairs, you have to understand that this is the area which needs to be brought forward. So this entire area, which is away from the fibrous skeleton, this is the region which becomes dilated. This is a diagram which is clearly shows a normal tricuspid annulus. So you can see it's a saddle-shaped structure with the aortic valve being one of the high points, and the posterior anterior commissure being another high point, and the other two quadrants are the low points. When you have an intermediate dilatation of the tricuspid annulus, then this is what you get. And once it flattens out, this is where one will see a tricuspid regurgitation. On the echocardiogram, one of the first features which you will see, which will guide you to knowing that the tricuspid uh, valve has a problem, is the tricuspid annulus. So it's very important, especially in cases of mitral valve disease, to measure the tricuspid annulus. There may be mild TR, there may be even trivial TR, but if the tricuspid annulus is dilated, then your RV is dilated, and this is something you should have a low threshold to go and repair that tricuspid valve, because consequently there is sometimes failure for remodeling of the tricuspid annulus, and the patient lands up with a late tricuspid regurgitation picked up much later, and there is a hesitancy to then reoperate that patient. Most of the time these patients come in late, and the mortality for a late operation is always higher. The effect of tricuspid regurgitation, these are very important graphs. If you can see that when there is significant tricuspid regurgitation, you're looking at 50% survival at 5 years. So this is just 50% survival at 5 years once there is significant tricuspid regurgitation. That is the reason that there have been a lot of literature and review of tricuspid regurgitation, and there should be a low threshold to go and repair the tricuspid valve, because once you've corrected this tricuspid regurgitation, then you can look at a much normal outcome for these patients. Here again you can see that once the patient goes into severe TR, this is just a follow-up of about 5 to 10 years, then the mortality, the survival is down to about 25%. The causes of tricuspid regurgitation is important to know. The primary causes for tricuspid regurgitation may be rheumatic, it may be myxomatous degeneration. Infective endocarditis is a common cause, especially in the West, where they have a large amount of IV drug users. Endomyocardial fibrosis was a disease which was seen in the earlier decades, but now it's come down. And then you have the congenital anomalies, of which Epstein anomaly is the commonest. The commonest cause for tricuspid regurgitation is secondary or functional. It's usually due to a left heart disease, either due to left ventricular dysfunction or a left ventricle or a left-sided valve disease. Any cause of pulmonary hypertension, COPD, CTEPH, left to right shunt can cause tricuspid regurgitation, and any cause of right ventricular dysfunction can also result in tricuspid regurgitation. The treatment of significant tricuspid regurgitation in pediatrics, you may bicuspidize this valve. The posterior leaflet is literally sort of buried, and then you make it a bicuspid valve. The older method of treatment, which we had followed in the 90s and 80s, was the Vega suture annuloplasty. This was a common method at that time. This is when we treated the tricuspid valve as a 2D structure. But we know now that this is a technique which should be given away, as its results are not good, especially in the long term. And the ring annuloplasty is the best method of correcting significant tricuspid regurgitation, for provided the leaflets are reasonably normal. So this is the tricuspid annuloplasty ring which has been sutured in, and then you have the tricuspid valve replacement if a repair is not possible. Just to give you an idea of what we used to do earlier, this is the De Vega's tricuspid valve suture annuloplasty. So we used to start from somewhere at the septal anterior commissure and then take these bites which used to go, we used to take care that these bites were alternate, so that it wouldn't tear through that tissue. So if the inner one was about, about 3-4 millimeters, then the outer one we would take alternating to that tissue. And then a sizer would be placed inside the annulus, and the suture would be tied over that sizer according to the size, according to the nomogram of the patient. Bioprosthetic valve replacements have been usually the choice, and when you do that, you follow the same technique as you would replace a mitral bioprosthesis. So pledgets on the ventricular side, and it's the same mitral valve that we would use. The mechanical valve, again, we follow the same mitral technique of putting everting sutures for the mechanical valve. This is a very important thing to realize, that the 3D design of the annuloplasty ring was a major progress in the treatment of tricuspid valve. You can see the way now these rings are designed. It's got a 3D structure which follows the annulus and follows the anatomy of the 3D anatomy of the tricuspid valve. It was in 2001 that Dr. Patrick McCarthy began to develop a ring to treat tricuspid insufficiency. So he applied a rigid remodeling concept from the mitral annulus to the tricuspid annulus, and he matched the shape of the ring to the shape and the anatomy of the tricuspid annulus. So the incomplete ring avoids the sensitive conduction system. So it fits in perfectly to the septal leaflet and avoids the AV node. If you look at the generations of tricuspid valve annuloplasty ring, here you can see the earlier generations were essentially 2D. They were two-dimensional rings. And it was only in the last generation that you will see that there is a definite 3D contour, like the Medtronic 3D contour, which has given it the anatomic configuration. So when you saline test a tricuspid valve annuloplasty, you can see here that it's just usually a reduction annuloplasty, and the valve is usually it is a competent valve. The latest in what tricuspid valve um, treatment options is what is happening around the world is the transcatheter tricuspid valve implantation, and there is again different approaches to the transcatheter interventions. It may be a direct ring annuloplasty, a coaptation, enhancement, or even valve replacements are being tried out. It's still very much not fully approved yet and in the trial period, but it is promising because some of these patients may not be many a time fit for an operation. I'd like to conclude here and thank you for your patient listening, and I would like to thank Jacob for including me in this symposium. And over back to you, Jacob.
Good morning, everyone. And thank you, Vijit, for your nice presentation on the tricuspid valve. I'll continue now with the morphology of the right ventricle, the interventricular septum, and the RV outflow tract. This slide is not moving. Okay. So right ventricle, as we know, is also known as a subpulmonary or the pulmonary ventricle, because in a heart with atrioventricular and ventriculo-arterial concordance, it receives blood from the right atrium and pumps the blood to the pulmonary circulation. Because it is designed to work in a low pressure system, the right ventricular musculature and mechanics has been designed for working in a low pressure. And as such, it is supplied by a single coronary artery as opposed to the left ventricle, which is supplied by two coronary arteries. The morphology of the right ventricle is very relevant for surgeons who practice treatment for congenital heart diseases. But as Vijit was talking just now, the relevance of right ventricular function and the functional tricuspid valve regurgitation is more and more being recognized in the adult cardiac surgery also. Now, this is a very good specimen which shows the relationship of the valves at the base of the heart. Both the right and left atrium has been removed from this specimen. And here you can see the aorta, the aortic valve, which is directly related to the mitral valve by the aortomitral continuity. This is the area of the central fibrous body, the left fibrous trigone, and the tricuspid valve. Now, the noteworthy thing here is that the tricuspid valve and the pulmonary valve are widely separated by this area of the muscle, which is known as the infundibulum of the right ventricle. And pulmonary valve has got nothing to do with the central fibrous body or the fibrous skeleton of the heart. It is totally elevated by the infundibulum. Now, there are basically three components of the right ventricle, as it is known as a tripartite ventricle. So there is an inlet component through which the blood comes in from the right atrium. There is a trabecular component of the right ventricle, and then there is an outlet component which supports the pulmonary valve. We will have a look at all the three components one by one. Now, the inlet portion of the right ventricle contains the tricuspid valve, and it is limited by the attachment of the tricuspid valve and its tension apparatus. So you can see here in this specimen, these are the chordae of the tricuspid valve which are getting attached to the septal surface of the right ventricle. And this is one of the demarcating features of the right ventricle and the tricuspid valve, because on the left side, the left atrioventricular valve or the mitral valve has got no attachments on the septum of the interventricular septum. It is septophobic, while the tricuspid valve has got direct attachments to the interventricular septum. That's why it is known as septophilic valve. Now, the second component of the right ventricle is the trabecular component. Now, here in this specimen, you can see this is the cut section through the right ventricle and the left ventricle. The left ventricular trabeculae are fine trabeculae, while the right ventricle has got coarse trabeculations, which is one of the hallmarks of the right ventricular trabeculations. Now, this diagram shows the septal surface of the trabecular component of the right ventricle. And basically, the importance of this trabecular surface is that it can have VSDs in multiple locations. So if you start from the anterior part, you can have anterior muscular VSDs in this location. You can have mid-muscular and posterior muscular VSDs. And then you can have VSDs at the apex of the trabecular septum, which are known as apical VSDs. Now, Dr. Ventra had given a very interesting theory about these apical VSDs. He said that the right ventricle apex has got two components. One is the apex of the right ventricular inflow, which is this area. And the second is the apex of the right ventricular outflow, or the infundibular apex. And most of these apical VSDs are located in the infundibular apex, or the apex of the right ventricular outflow. That is why, if you see in this echo picture, this is the moderator band, and the VSDs are concealed usually beyond the moderator band. And when you try to look through the tricuspid valve, we are usually not able to approach these VSDs from our transatrial routine approach to approach the VSD. And that is why in these cases particularly, a apical right ventriculotomy is the best way to approach these VSDs. Even then we have to divide some trabeculae, but we can directly approach these apical VSDs, and it is easier to close through the transventricular approach. Now coming to the third component of the right ventricle, which is known as the outlet component. The outlet component of the right ventricle is a complete muscular structure, which is also known as the right ventricular infundibulum. And this supports the pulmonary valve. The three leaflets of the pulmonary valve have got no fibrous ring or annulus, because as I showed you in the first picture, it is not related to the central fibrous body of the heart. Instead, these pulmonary valve leaflets are attached to the infundibular musculature in a semilunar fashion. I will come to this pulmonary valve towards the end of the talk. Now we are coming to the most important part of the right ventricle, that is the septal surface of the right ventricle, because this is the surface where when we operate a child with congenital heart disease, we have to look for the VSDs, we have to look for the RV outflow obstruction, and all of these things happen in this septal surface of the heart. Now the septal surface is again divided into three components based on the division of the right ventricle. This is the inlet component of the septal surface. This is the trabecular component. I showed you that most of the muscular VSDs occur in this trabecular component. And this is the outlet component of the septal surface of right ventricle. And this is the area of our interest, because this is where all the malalignment and RV outflow obstruction, the infundibular septum, the VSDs, the malalignment VSDs, they all take place in this area of the infundibular septum. Now we have come to the outlet portion of the septal surface of right ventricle. Now this outlet portion, if you see, is relatively smooth as compared to the other areas of the right ventricle, which are more trabecular. The outlet portion again can be divided into three components. The largest component of the outlet portion is this infundibular septum. This is the infundibular septum. Then the second component of this outlet portion of the right ventricle is the anterior limb of the trabecula septomarginalis, or the septomarginal trabeculation. And the third very small component you can see here, this is the superior extension of the trabecular septum, which comes a little bit in contact with the pulmonary valve towards the anterior surface of the right ventricle. So basically the outlet portion of the septal surface has got three components: infundibular septum, anterior limb of the trabecula septomarginalis, and a trabecular component which is very small. Now we'll come to the infundibular septum. Infundibular septum actually is the posterior part of the subpulmonary infundibulum, which supports the pulmonary valve. And as you can see in this diagram, it separates the tricuspid valve from the pulmonary valve. The pulmonary valve is here. This is the tricuspid valve, and unlike on the left side, there is no continuity between the tricuspid and the pulmonary valve, which is because of this infundibular septum. Now, if you look at the morphology of the infundibular septum, if you see this medially, this is known as the septal extension of the infundibular septum, and it goes and attaches to the Y of this trabecula septomarginalis. The trabecula septomarginalis divides into a Y, which has got an anterior limb and a posterior limb. In between this Y, the infundibular septum goes and attaches. And if it fails to attach here, or it is malaligned, this leads to the malalignment type of VSD. An anterior malalignment causes tautology of fallow type of defects, and a posterior malalignment causes LV outflow obstruction with a VSD. So this is the leftward component of the infundibular septum, which attaches in between the limbs of the trabecula septomarginalis. Now, if you come to the rightward component, this is known as the parietal extension of the infundibular septum. Now, this parietal extension comes above this is the part of the membranous septum at the junction of the septal and anterior leaflet of the tricuspid valve. This comes anterior to the membranous septum and goes and joins the right ventricular free wall. And in this area, it is known as the ventriculo-infundibular fold. This area of the heart where the infundibular septum joins the anterior right ventricular wall is known as the ventriculo-infundibular fold. Now there is one term which is used by some morphologists. This whole area of the infundibular septum and the parietal extension is also known as supraventricular crest or crista supraventricularis. Crista supraventricularis is nothing but another term for this infundibular septum and its parietal extension. Based on this term, supraventricular crest, we have sometimes designated this perimembranous VSDs as infracrustal VSDs because they are inferior to the supraventricular crest or this component of the infundibular septum. And the outlet VSDs or the VSDs, subpulmonary VSDs are sometimes called as supracrustal VSDs because they are above the supraventricular crest. So this term is sometimes confusing. Crista supraventricularis or supraventricular crest. It is nothing but another name for this infundibular septum and its parietal extension. Now we'll come to this ventriculo-infundibular fold. I had talked to you about the ventriculo-infundibular fold where the infundibular septum merges with the anterior right ventricular free wall. Here the right ventricular free wall has been removed, and this is the area of the ventriculo-infundibular fold where the infundibular septum coming from here is joining the curving and joining the anterior right ventricular free wall. This is that area. Now this is another specimen which beautifully shows this. This is the area of an infundibular septum, the ventriculo-infundibular fold. And the outside the heart, it is related to the right coronary sinus of the aorta and the right coronary artery. So if sometimes during infundibular muscle resection, we make an incision into this ventriculo-infundibular fold, we actually come out of the heart in the region of the right coronary artery, and we should try to avoid making this deep incision into the ventriculo-infundibular fold when we are doing resection for the tetralogy or DORB with PS. Now this is one transesophageal echo of a patient with the RSOB from the right coronary sinus. Just to demonstrate the relationship between the right coronary sinus and the right ventricular outflow tract. You can see beautifully this sac, which is the aneurysm of the right coronary sinus bulging into the right ventricular outflow tract. So this is exactly the relationship of the right coronary sinus to the right ventricular outflow tract. Now we want to see this dissection where the infundibulum of the right ventricle has been removed under the pulmonary valve. But I just want to demonstrate here that this right ventricular infundibulum and the infundibular septum are actually not completely, they are not interventricular septum. Most of it is part of the inner curvature of the heart. And so if you can remove the right ventricular infundibulum, still you will not enter into the left ventricle because they are not interventricular. The most part of the infundibular septum is not an interventricular septum. And I will show it here again. See, this is the infundibular septum which is attaching between the limbs of the trabecular septum marginalis. And this is the area of the ventriculo-infundibular fold. Now, if you remove most part of the infundibular septum, you will come out of the heart into the region of the right coronary artery and right coronary sinus, but still you have not entered into the left ventricle. Now look at this area. This is the area where the infundibular septum is got attached between the limbs of the TSN. Now if we remove this part of the infundibular septum, then only we will enter into the left ventricle. So the message here is that most of the part of the infundibular septum is not an interventricular septum. Rather it is, if you divide it, you will go outside the heart. And because of this fact, you can actually take away the entire pulmonary valve for the Ross procedure. And this is the basis of this dissection of the pulmonary valve, where we can remove it without creating any VSD and use this pulmonary valve for aortic valve replacement. Now coming to the final part of this right ventricular outflow talk, that is the pulmonary valve. Actually, if you see, the pulmonary valve does not have any fibrous annulus, and it has got a semilunar attachment. The only anatomical ring here is a ventriculo-arterial ring, which is the junction of the right ventricle to the pulmonary artery. But the pulmonary valve is not attached to this ventriculo-arterial ring. In fact, we can see three rings here. One is the topmost ring, which is the highest point of the commissure of the pulmonary valve, which is also known as the sinotubular junction. Second is the anatomical ventriculo-arterial ring, which is again not a fibrous structure, but it is just a point where the muscle transitions into the pulmonary artery. And the third lowermost ring is a hemodynamic ring, which is the lowermost point of attachment of this semilunar pulmonary valve. And this is the hemodynamic ring because above this ring is the pulmonary artery pressure and below this ring will be the right ventricular pressure. So this is the basic anatomy of the pulmonary valve, 3 semilunar valve attachments, but without a fibrous annulus. So to summarize, right ventricle is a tripartite structure. Knowledge of the anatomy of the septal surface of right ventricle is essential to understand the morphology of congenital anomalies, especially if you are going to correct through the transatrial route, such as this VSD, stretology, and DORV. When you are trying to repair this thing, you should have a good knowledge of the right ventricular septal surface. And to reiterate that right ventricular infundibulum is a muscular structure which supports the pulmonary valve. And only a very small component of the infundibular septum is actually an interventricular septum. Most of the part of the infundibular septum is outside, it is supporting the pulmonary valve. So that is all in the right ventricular morphology. Thank you very much.
Thank you, Dr. Ravi Agarwal. That was indeed a beautiful lecture on the right ventricle. One of the most fascinating and fabulous parts of coronary of cardiac anatomy is to talk about the structures on the right ventricle, especially the septum. Many of us don't really understand because most books are not very clear on this. And Dr. Ravi Agarwal, our pediatric surgeon, he has so beautifully told us very crisply and clearly that we have a very clear idea of the right ventricular structures and the anatomy and also their surgical significance. We'll just go through a few structures here on the right side. So here you can see the pectinate muscles being transilluminated for you. So we start here with the right atrial appendage. This is the broad-based and nose-like or triangular appendage. Okay. Here we have the okay, once we open this, we get into the sinus venarum part of the right atrium. Okay, this is where the SVC joins us and the IVC joins us from below, and the smooth part on the inside is the sinus venarum part. Okay, so that smooth part there is the sinus venarum part. This is the rough part. The crista terminalis is here. We made this would be the area of the crista terminalis, and the pectinate muscle go off at right angle to the crista. Okay, the sulcus terminalis is this groove on the outside. So the sulcus terminalis corresponds on the inside to the crista terminalis. From where the pectinate muscles are taking origin. And this is the vestibule which leads to the tricuspid valve. Okay, so the sinus venarum part, the appendage part, and the vestibule are the three parts of the right atrium. Now let's open the right ventricle. You open the right ventricle, thus this large sail-like structure is the anterior tricuspid leaflet. I will start with the septum. So this here is the trabeculum septum marginalis. Okay, this is the Y-shaped structure that Dr. Ravi talked to you about. So this is the main limb of the trabeculum septum marginalis. And here it divides into the two Ys. The anterior part goes this way and it supports the pulmonary valve. So here you find the pulmonary valve here. The anterior limb supports the pulmonary valve. So the anterior limb goes this way towards the pulmonary valve. The posterior limb goes this way. So between the anterior limb and the posterior limb, we have the ventricular-infundibular fold, which is where the heart embryologically bends. Okay, so posterior limb, anterior limb. At the junction of the posterior limb and the main TSM, you have the medial papillary muscle. So this is the medial papillary muscle, also called the muscle of Lancisi or the muscle of Pushka. This is an indicator of where the bundle penetrates inside. Okay, so this is the medial papillary muscle. This supports the anteroseptal commissure of the tricuspid valve. So the anterior, the septal commissure is there, the septal leaflet is there. So this would be the anteroseptal commissure of the tricuspid valve, and that is supported by the medial papillary muscle. Now, the TSM continues this way as the moderator valve. So this is the moderator valve, and that turns anteriorly upwards, giving rise to this large anterior tricuspid papillary muscle. Okay, so this supports most of the anterior leaflet of the tricuspid valve. So this is the anterior papillary muscle of the tricuspid complex. The posterior muscle is behind here. Okay, so that would be the posterior muscle of the tricuspid complex, and that supports a part of the anterior leaflet and the anterior-posterior commissure and a bit of the posterior leaflets. These are the septal leaf commissures. These support the septal leaflet. So that would be the septal papillary muscles. We have septal papillary muscles only on the right side, and they support the septal leaflet of the tricuspid valve. On the left ventricular side, there will be no septal leaflets, because if we had them, they would go across the LVOT, across the aorta, and that would not be feasible. So septal papillary muscles are seen only on the right side. Dr. Ravi showed you a nice specimen where the ventricular-infundibular fold, if we open in the area of the ventricular-infundibular fold, we enter into this area outside the heart in the region of the right coronary artery. So that is shown in this particular specimen. So we have cut off the ventricular-infundibular fold area. This is the crista supraventricularis. Okay, so this is the crista supraventricularis, and just outside that is the right coronary artery. The right atrial aortic sinus, the area of the right coronary artery. So just outside the infundibular septum is this area, RCA area. Here, if you see, this is the medial papillary muscle of Lancisi, and this is the anterior tricuspid leaflet. So that's for your orientation. I will show you a nice little Tebesian valve here. So this here is the Tebesian valve. Can you see that? The coronary sinus goes in here, and one can see the Tebesian valve here. this is the eustachian valve, and both of them join together forming the tendon of Trodaro, which inserts into the right fibrous trigon. So that, that's right. So that is the area of the right fibrous trigon. So that would be the area of the right fibrous trigon. This is the septal leaflet. This is the membranous portion of the atrioventricular septum. This is the muscular portion of the atrioventricular septum. And this is the Tabasian valve, tendon of Trodaro this way. Okay. I would sometimes the Tabasian valve may be large and they would obstruct the placement of a coronary sinus cannula for retrograde cardioplegia. Sometimes you find that the Tabasian valve may be fenestrated. So here you find fenestrated Tabasian valve. So a few fenestrae. So that is a fenestrated Tabasian valve. Okay, fenestrated Tabasian valve. Entry into the coronary sinus. All right. Now, so here I'm trans-illuminating the fossa ovalis. So the bulb is in the left atrium, and this is the fossa ovalis. This is the only part of the true interatrial septum. Okay, so Dr. Hiramat was explaining that to you. Okay, so this is the oval fossa. The medial, lateral, and the upper borders are quite well seen, and is a bit deficient posteriorly. So that is the trans-illuminated oval fossa for you. This portion, this part of the septum, my finger is in the aorta, and I'm moving it for you to show you the aortic mound. So that is the torus aorticus. So if you make an incision in the septum and you close it, and if you take large bites here, you are likely to take the RCC, the right coronary cusp of the aortic valve in your bites. So across here is the right coronary sinus and the right coronary leaflet. So one needs to be careful about taking deep bites in this area. So that's the torus aorticus. Okay, so now this bulb is there in the left ventricle, and here you see the membranous septum. So we have trans-illuminated the membranous septum for you, and you can see its relationship to the septal leaflet. So that's the septal leaflet, and that's the anterior leaflet, anteroseptal commissure, and that's the membranous part of the atrioventricular septum. So right atrium to left ventricle, atrioventricular septum. And if you have a defect there, that's called a Gerbodia defect. So this is the membranous part of the atrioventricular septum. Just below that would be the muscular part of the atrioventricular septum that does not trans-illuminate. And at the junction between these two, the bundle penetrates. Okay, so that is where the bundle penetrates. So I think we've had a good idea about the structures on the right side of the heart. Now we shall move on to the left side of the heart. We have Dr. Suresh Kumar. He is our adult surgeon, and he will be talking to us about the left atrium. Over to Dr. Suresh Kumar.
Good morning, everyone. Now we briefly see about the morphological anatomy of the left atrium. The name atrium is of Latin origin, refers to the central room of a Roman house from which one can enter into several rooms. The principal role of the LA is to modulate the LV filling and thereby its performance by functioning as a reservoir for the pulmonary venous return during the ventricular systole, and its conduit function for pulmonary venous return during early ventricular diastole. It also acts as a booster pump which augments the ventricular filling during the late ventricular diastole. Let us see about the interplay among the left atrial function and its ventricular function performance. The reservoir function is mainly governed by the atrial contractility and relaxation, but it's also influenced by the descent of the LV base during the systole and by the LV in diastolic volume. Its conduit function is mainly influenced by the atrial compliance, but it's also closely related to the ventricular relaxation and its compliance. The booster function of the left atrium not only depends on the atrial contractility, but also depend on atrial preload and the afterload, as well as LV systolic reserve. This is the diagram showing the measurement of the functions of the LA. The reservoir function of the LA can be measured by finding out the left atrial filling volume, which is the difference between this maximal volume and the minimal volume. The conduit function of the LA is measured by the left atrial passive emptying volume, which is measured by maximal volume by minus P volume. The pump function may be measured by the atrial active emptying volume, which is measured by P volume minus minimal volume. While considering the embryology, the left atrium is developed from left half of the primitive atrial chamber and the left of the atrial ventricular canal and absorbed portions of the proximal part of the pulmonary veins. This explains the major three components of the LA. The anterior or central part of the LA is the smooth walled, and it's the largest component. It's not fixed to the pericardium, so relatively it is mobile. And the venous component of the LA is relatively immobile. It's surrounded by the pericardium and the great vessels. It has the lowest contractility functions. While the LA appendage has a distinct pattern of contraction, it's more dependent on the LV function than the LA. This embryologic picture showing the trapeculated part of the left atrium derived from the primitive atrium is mainly LA appendage only. The major part is the smooth part of the LA is formed by the incorporation parts of the proximal parts of the pulmonary veins into the atrial wall. This is the diagrammatic representation of the same. The primitive pulmonary vein, which is developed from as an evagination from the dorsal wall of the atrium into the sinoatrial regions, and its incorporation into the LA wall is forming the smooth wall nature. Unfortunately, this animation video is not working. Seeing the shape of the left atrium, it's a cuboidal or quadrangular in shape. It forms the base of the heart. Due to the obliquity of the plane of the atrial septum and the different levels of the tricuspid and mitral orifices, the LA is the most posteriorly placed cardiac chamber. Posterior to this LA is the esophagus and vagus nerves and thoracic aorta. LA lies opposite to the middle thoracic vertebra T5 to T7. This is the sagittal sheet picture showing the most posterior cardiac chamber LA. This is the diagrammatic representation of the base of the heart, which is mostly formed by the LA. This is the diagrammatic representation of the relations. Anterior relation is aorta and the pulmonary trunk, while the posteriorly tracheal bifurcation, esophagus, aorta, and the vertebral column. We will also consider the transverse and oblique sinuses next. Oblique sinus formed by the reflection of the pericardium onto the pulmonary veins of the heart. anteriorly by the left atrium and posteriorly by the parietal pericardium. Below it opens into the pericardial cavity. This is the diagram showing the relation of the transverse and oblique sinuses to the LA. This is the relationship to the pulmonary arteries. In the right side, you can see the right pulmonary artery is overlying the roof of the LA, while the left pulmonary artery very close proximity to the left atrial appendage. This is a diagram showing the relationship of the aorta and the esophagus. The anterior wall of the left atrium is just behind the aorta, is the thinnest portion, that is also known as the unprotected area. The posterior wall is also relatively thin at the level of superior pulmonary veins. There is a possibility to the atrioesophageal fistulas in surgical and interventional procedures. The relationships of the nerves. The right phrenic nerve is closely related to the right pulmonary vein, while the left phrenic nerve is related to the left atrial appendage. When in seeing the atrial walls, McAlpin is described this attitudinal orientation of the LA walls, and he described this as superior or roof and posterior wall, left lateral wall, septal or medial wall, and the anterior walls. These atrial walls are smooth walled but not in uniform in thickness. Thickness is varying like this. Superior wall may be 3.5 to 6.5 millimeter, and the lateral wall into 2.5 to 5 millimeter. Anterior wall in 1.5 to 4.8 millimeter. It becomes very thin near the vestibule of the mitral annulus. This picture showing the non-uniform nature of the myocardial thickness, and this branch illumination showing the thinness of the atrial walls and the near the pulmonary veins and the atrial appendages. While we studying the structure of the LA, we'll consider this kind of division: pulmonary venous component, septal component, vestibule or outlet of the LA, and left atrial appendage as a distinct entity. This is showing the septum and the vestibule and venous component and appendage in the heart. As we see the venous component, this classic 4 pulmonary vein drainage is seen in 74%, in which 31% may have a short vestibule or common vein format. 5 pulmonary vein drainage is found in 17%, and the common vein on the left or right side is seen in 9%. See, left pulmonary veins are more superior than the right-sided pulmonary veins, and inferior pulmonary veins are anchored more posterior than the superior pulmonary veins. Accessory middle right vein seen in around 20%. This is the diagram showing the classical 4 pulmonary veins and the relationships of the left pulmonary vein superior to the right pulmonary vein, and inferior veins more posteriorly anchored than the superior veins. It's also showing the myocardial sleeves. You will see that at next. This is 3D CD reconstruction of the left atrium and the pulmonary vein anatomies. Myocardial sleeves are nothing but atrial musculature extending between the subepicardium and the tunica media of the pulmonary veins, which is thickest in the inferior wall of the superior pulmonary veins and the superior wall of the inferior pulmonary veins. The veno-atrial junction also have a ganglionated cardiac intrinsic nerve plexus. Functionally, it may act as a sphincter, but its clinical importance is more rely on the it may have that focal electrical activity. This diagram again showing the histologic picture showing the ganglionated nerve plexus and the muscle fibers present around the myocardial sleeve. This is a histological picture showing the right superior pulmonary vein near the left atrial attachment, having the outer aspect venous wall have a muscular fiber sleeve. Next, we will see the left lateral ridge. In 1907, Keith termed this as a left tinea terminalis, which lies between the left pulmonary veins and the left atrial appendage. It is nothing but the left atrial fold may appear like a ridge. Externally, this left lateral ridge is demarcated by the oblique vein of Marshall, which is an embryonic vestige of the left VC, which is wrapped in the ligament of marshal. This oblique vein joined with the great cardiac vein and the postlateral vein to form the coronary sinus. This is the morphologic picture showing the left lateral ridge. This is also another picture showing the left lateral ridge. And this is left lateral ridge at the superior level around 5 and the inferior level around 9. Showing the oblique vein of the marshal joining the great cardiac vein to form the coronary sinus. This is the embryological development of the oblique vein of the marshal derived from the left common coronary vein. This is the also a picture showing the great cardiac vein and the coronary sinus formation. Clinical importance is the on echocardiographic examination, the prominent left lateral ridge may be mistaken for the thrombus or atrial mass. This is known as Q-tip or drumstick sign. For the same reasons, it may also called as Homardin ridge. This profile of that fold is may varying from flat, round, or pointed. When it is completely separates the atrium by membrane-like structure, this is a clinical condition called carparatrium sinister. This is the diagrammatic representation showing the Homardin ridge. Next, we see about the septal component of the LA. This is very complex to understand since its plane of atrial septum is obliquely angled around 45 to 60 degree and runs posteriorly from the left to right side. Right to left side. The true septum is the partition between the two chambers. One can safely enter into from one to another without exiting the heart. In that sense, the true septum is confined to the floor of the oval fossa lunata, which is correspond to the foramen ovale on the right atrial side. These boundaries are blurred when it blends with the superior wall and the posterior wall and vestibule. See the normal variants of the septum like septal pouches and PFOs, which are all around 40% in the general population. Its clinical relevance is maybe a potential site for the thrombus. This is the morphology. The crescentric margin we can appreciate. The green rod kind of thing enlightened to the pouch-like structure. It is not able to enter into the right. This is a diagrammatic representation of the fossa lunata and it's merged with the other walls of the LA. This is the anterior portion of this dissected specimen removed to appreciate the true nature of the septum in the LA wall. These are pictures showing the internal features of the septum, like crescent-like margin and PFOs. This is another variant, lipomatous hypertrophy of the interleateral septum, showing the echo picture. The outlet of the left atrium is a smooth walled without a pectinate muscles. This is closely related to the AV node and the bundle. See, adjacent to the aorta can produce a mount-like structure area in this area of mitral aortic intervalvular fibrosa. Its clinical importance during surgical procedures like replacements. This fibrofatty tissue at the annulus level serves as the insulating plane between the atrial and ventricular masses. You see the isthmuses. Mitral isthmus is the musculature between the orifice of the inferior pulmonary vein and the annulus, which is known as mitral isthmus. This endocardial surface have pits and rubs in the cardiac veins called foramina linearum. This clinically related to the RF ablation of the atrial fibrillations. This is the most common adjuvant linear ablation line to improve the pulmonary vein isolation and the recurrence after the procedure of AF ablation. Alternate to this line is the superlateral mitral isthmus line to avoid the vessels like great cardiac vein and left circumflex and marshal vein. which are present in the mitral isthmus. This is the morphology picture showing the isthmus and its close relation to the great cardiac vein and the circumflex artery. The same shown in the histological picture. See, other RF lines for importance are left atrial appendage isthmus line, left atrial medial isthmus line, roof line, anterior medial line, anterolateral line. It's all connecting lines between the left atrial appendage and the mitral annulus is the left atrial appendage line. Left inferior pulmonary vein to the mitral annulus is the mitral isthmus line. And in between the superior pulmonary vein line is called the roof line. And the left atrium to the annulus is called the anterior line. Right superior pulmonary vein to annulus is called anterolateral line, and the left superior pulmonary vein to annulus is called the anteromedial line. When we consider the interatrial connections, the most common known is the Bachmann's bundle or interauricular band. This is the prevalent conduction pathway of the sinus impulse to the anterior left. It has left and rightward arms which rejoin after passing around the neck of the LA and runs into the lateral and posterior inferior walls. Only at the interatrial groove, it appears as a distinct bundle because it's separated by the fibrofatty tissues from the atrial wall. This is the dissected specimen showing the right and left wings of the Bachmann triangle bundle. These are other pictures diagrams showing the Bachmann bundle in the interatrial groove. This is also a histological picture and the morphology picture of the Bachmann bundle and right and left arms. Finally, we see the left atrial appendage morphology. This is the only remnant of the primitive pulmonary primitive atrium of the left atrium. It's highly variable in the size, shape, and the number of lobes and other things. Usually, it is a multilobular having a small orifice and a narrow neck, all potential for the formation of thrombus. Based on the number of lobes, 2 lobes will be seen around 54%, 3 lobes in the 23%, and 1 lobe in 20%. 4 lobes is very rare and 3%. Orifice shapes may be varying from round or oval or triangular or water drop kind and foot-like appearance. This is a picture showing the frequency of the lobes in the left atrial appendage. This is the variant morphology of the left atrial appendage osteums. This is the multimodality viewing of the left atrium by key cine angios and the 3D CT, and also now by the MRI of the cardiac MRI. These are all mainly important to the left atrial appendage process. The Wang classification of the left atrial appendage divides into 4 types. One is chicken wing type, and second one is cactus, and third is a windsock type, and fourth is the cauliflower type. The risk of stroke and its relations are studied in extensive. Chicken wing type is the less pathogenic than the others. Cauliflower type is an independent risk factor for the stroke. This is based on the multi-dimensional CT imaging, various types of the left atrial appendage: horseshoe type, finger type, fan type, wing type, hook type, wedge type, and swan type. These are all, as I said, it's left atrial appendage closure. These are all important to study this anatomy and prepare for that. Okay. End of the slide. Thank you all for the listening.
Thank you, Dr. Suresh. That was a very complete talk on the left atrial appendage. We now have with us Dr. Sanjay Theodore, the chief surgeon from the Chettinad Hospitals, Chennai. He would be talking to us about the mitral valve. Over to Dr. Sanjay.
Thank you, Jacob, for having me here again on your meeting. My topic for today is the mitral valve morphology. During this short talk, I'll be looking at the normal morphology and pathological morphology as well as its clinical implications. The mitral valve is a saddle-shaped structure. The annulus has two high points at the 12 o'clock position and the 6 o'clock position, and two low points at the 9 o'clock and 3 o'clock position. The annulus is more oval rather than circular, with the anteroposterior diameter being shorter than the intercommissural diameter. The annulus is basically a fibroelastic structure which contracts by about 20%, and it promotes the coaptation during systole. And loss of this saddle structure will lead to early degeneration of the valve, because this saddle structure is important in reducing the strains developed in response to the stress during the 3 billion cycles of valve motion. As you can see here from this echocardiographic diagram, the annulus has a variable shape, and in systole it is D-shaped, and in diastole it becomes more circular. This is because of the fact that the posterior area of the annulus is not continuous. The fibroelastic structure of the annulus is complete in the anterior areas and is incomplete in the posterior areas. The posterior leaflet frequently inserts onto the ventricular myocardium and the atrial myocardium. Hence, the dilatation of the annulus secondary to ventricular dilation and giant left atrium. There are two leaflets attached to the annulus: the anterior leaflet, which attaches to 1/3 of the circumference, and the posterior leaflet, which attaches to 2/3 of the circumference. The height of the anterior leaflet is about 2 to 2.2 centimeters, and the posterior leaflet is 1 to 1.2 centimeters. Essentially, both the leaflets have an equal surface area. The leaflets are further divided into basal areas, the middle clear area, and the rough zone close to the coapting edge. And this rough zone is the area in which the caudal attachment occurs. The thickness of the mitral valve also varies from the basal areas up to the edge of the leaflet. The basal areas are the thin areas, with the thickness being around 1 millimeter, and the thickness at the edge is about 2 millimeters. The posterior leaflet has two prominent indentations, which divides this posterior leaflet into 3 scallops. And the anterior leaflet does not have any indentations or scallops, but is named according to the corresponding posterior leaflet scallop. The scallops extend from the anterolateral commissure to the posteromedial commissure, A1P1, A2P2, and A3P3. Now, the third important component of the mitral valve is the caudal apparatus. The number and morphology of the caudal apparatus is highly variable. However, in a normal valve, there is about 25 cords, 8 to 9 in the anterior leaflet and 13 to 14 in the posterior leaflet, and 2 intercommissural cords. The cords are further divided into primary, secondary, and tertiary cords based on where they insert onto the leaflets. The primary cords insert onto the very edge of the leaflet. Elongation of or rupture of these primary cords will cause a flail segment, usually resulting in significant mitral regurgitation that will require some kind of intervention. The secondary cords insert into the area just behind the primary cords, and each leaflet has one extra thick secondary cord called the strut cord. Elongation or rupture of these cords will cause a billowing of the leaflet into the left atrium and loss of coaptation and prolapse of the leaflet, frequently requiring some kind of intervention. The tertiary cords are specific to the posterior mitral leaflet. They arise directly from the ventricular myocardium and insert onto the base of the leaflet. These cords also have some clinical implication, because when we choose to repair a mitral, rheumatic mitral valve or an ischemic mitral valve, we can divide these cords to get a little more mobility in the posterior mitral leaflet. The last component of the mitral valve apparatus is the papillary muscles. There are 2 of them, which insert onto the area in the ventricular myocardium between the apical third and the middle third. The anterolateral papillary muscle is more constant in shape and morphology, usually having one head. The postomedial papillary muscle usually has 2 or 3 heads, and rarely it can be sessile with the cords rising directly from the ventricular myocardium. Now, the cords from each of these papillary muscles is very specific in insertion. The cords from the anterolateral papillary muscle insert onto A1, P1, and the lateral part of A2, P2, and postomedial papillary muscle A3, P3, and medial part of A2, P2. Now, it is quite important because when we think of repairing the valve and using neocords, we should make sure that we do not cross the midline when we insert or place these neocords. The microscopic anatomy, though it's not actually within the brief of this topic, I'd just like to mention it because this microscopic anatomy is extremely important in maintenance of the morphology of the valve through an entire lifetime. The leaflet is divided into 3 layers: the atrialis, the spongiosa, and the ventricularis. The atrialis layer has elastic and collagen fibers, and they are in a very crimped, and they are arranged parallel to the annulus, and they help in reducing the stress and strains of opening and closing of the valve. The middle layer, the spongiosa layer, is made of proteoglycans and glycosaminoglycans, and this is the shock absorber layer of the valve and distributes the stresses and strains through the valve, preventing degeneration of places with high mobility. The ventricularis is the tough layer of the valve leaflet and has tightly packed collagen and usually faces the brunt of the ventricular forces. There are also 2 cell types, the valvular endothelial cells and the valvular interstitial cells. Interactions between these 2 cell types are extremely important in keeping the valve in a state of flux and continuously repairing and regenerating the valve so that the normal morphology is maintained through a lifetime. All these structures become extremely important in disease. The valvular interstitial cell is probably the key to understanding the most disease processes. In the normal state, it is in a fibroblast phenotype, and the net secretion of anabolic and catabolic proteases are 0. Now, in disease states, this changes. Now, looking at the valvular morphology in disease, the commonest is the degenerative mitral valve. There's a large spectrum of the disease. At one end of the spectrum, we have the fibroelastic dysplasia, where the valve looks essentially normal. The annulus is also not dilated too much, but frequently there is rupture of cords and elongation of cords. This is due to damage to the elastic and collagen fibers due to degenerative processes because of the alteration of the morphology of the valvular interstitial cells. It is usually seen in the older age group, but there may be a genetic component as well with some chromosomal abnormalities. When these flail segments occur, usually you'll have to address it with a neocord, and usually you put in a ring just to stabilize the repair. Now you move along the spectrum, you come to the typical Barlow's disease. Now you look at the Barlow's disease, the annulus is affected, it is frequently dilated, the shape is lost, the saddle shape is gone and it's flattened out, and this increases the stress and strains and promotes degeneration of the leaflets. So second, you look at the leaflets are both significantly enlarged, the PML more than the anterior leaflet, and you can see that the coaptation point is moved forward, making this valve susceptible to systolic anterior motion and mitral regurgitation. The subvalvular apparatus is affected as well. There is elongation and frequently rupture of cords. Though the cords may appear thickened, they are more fragile and prone to breakages. So when we address a patient with a degenerative mitral valve disease, we should not think of it only as a type 2 kind of Carpenter's pathology where there is prolapse. We need to address the annulus, we need to address the leaflets. We also have to address the ventricular wall in the sense when there is significant dilatation of the ventricle, you also will have a type 3 kind of regurgitation. So there will be some amount of apical tethering, and this also has to be taken into account when doing a proper repair and even in Barlow's. The next common pathology causing mitral regurgitation is the ischemic mitral regurgitation. The primary pathology is apical tethering of the valve due to papillary muscle dysfunction or due to akinesia, dyskinesia of the adjacent ventricular wall. As you can see here, the tethering is not symmetrical. The tethering is more in the A3, P3 region. Some new rings are addressing this asymmetric tethering, but still the results of repair are quite poor, with early recurrence of regurgitation in up to 60% of the patients. There are also additional pathologies we have to look at when we look at the ischemic MR. Frequently, there is caudal elongation, rupture, rarely papillary muscle rupture. The annulus is frequently dilated secondary to the ventricular dilatation. So all these different pathologies have to be looked at and identified and applied to the repair before we can get a good repair. One of the things which is often overlooked by most surgeons is the papillary muscle position. It is frequently seen that these patients have displaced papillary muscle, which are responsible for the early recurrence of the regurgitation after a good repair. So there is a school of thought which thinks that tissue valve replacement with caudal preservation may be the way forward for many of these sick patients. The next pathology which is important in causing mitral regurgitation is the hypertrophic obstructive cardiomyopathy. Treatments have varied from mitral valve replacement to just myomectomy. But now people are recognizing more and more that the mitral valve intrinsically has a lot of problems in these patients. Up to 70% of the patients have intrinsic abnormalities of the mitral valve. They have a feeling that this might be genetically linked. And as we know, the HOCM has a lot of genetic components. This also may be a part of the disease. We all know that the main mechanism of regurgitation in HOCM is the systolic anterior motion secondary to the Venturi effect. Now, apart from the Venturi effect, there are two other major pathologies which also contribute to the mitral regurgitation. Many of these patients have significant enlargement of the posterior mitral leaflet. This is independent of the left ventricular outflow tract obstruction and the Venturi effect. People think that there's an intrinsic abnormality like in Palos, which causes enlargement of these leaflets. There is also papillary muscle positional changes, which is very difficult to repair in these patients. So many experts of this HOCM will tell you that you do adequate resection, you're going to get a good mitral valve competence. But this is not true. In fact, you may have to add an additional procedure to the mitral valve in many of these cases to address the elongated posterior leaflet as well as the papillary muscle displacement. And one of the simple procedures which has been advocated and which has good results is the Alfieri stitch, which takes care of the posterior leaflet enlargement and prevents systolic anterior motion. And the papillary muscle displacement doesn't really matter because you're causing physical apposition of the valves. Last but not the least is something which is very familiar to probably everybody in the audience is mitral stenosis secondary to rheumatic mitral valve. And here there is a autoimmune destruction of the collagen in all the layers of the leaflet. There is the typical commissural fusion. The leaflet, the annulus is not enlarged much, but it's usually fibrous, sometimes smaller than normal. The leaflets are restricted, thickened, fibrosed, and in later stages calcified. And you look at the microscopic anatomy, you see that the valvular interstitial cells have taken a myofibroblast or an osteoblastic phenotype, which promotes fibrosis and calcification. The subvalvular apparatus is also involved. There is fibrosis, shortening, and significant tethering of the leaflets, both in systole and diastole. Many of these valves are not suitable for repair, and probably they are better suited to a replacement. But in early stages of the disease, when there is mitral regurgitation, there's frequently elongation of the cords and anterior leaflet prolapse with mild dilatation of the annulus, and standard repair procedures can be applied to this. In conclusion, I'd like to say that the mitral valve is an extremely complex structure. Multiple pathologies contribute to mitral regurgitation. We also need to understand that the disease is progressive. So we are only doing a palliative procedure when we do a valve repair. So we should be extremely prudent in patient selection and replace the valve when required. always repair. I know most surgeons will feel a great sense of satisfaction when they do a complex repair, but we should always know that the complex repair is going to fail sooner rather than later. Thank you.
Thank you so much, Dr. Sanjay. That was a very illustrative talk. Thank you so much. We now go on to the aortic valve. We now have with us Dr. Mohammed Idris. He has great wealth of experience with the aortic valve and the aorta, and he would be now speaking to us about the aortic valve. Over to Dr. Idris.
Good morning to all and all. I thank Dr. Jacob James Raj and his team for giving me this opportunity, and I appreciate Dr. Jacob James Raj for his constant effort in building up the education program across the country and this 12th in the series of morphology course. So the topic for me is aortic valve. So this aortic valve is initially it was demonstrated by Leo da Vinci way back in the 16th century, when he described in his artistic works about the aortic valve, the closure, the opening, and he went on to describe even the sinuses of the aortic valve, the sinus of Valsalva, and further he also described the vortex across the valve. He even further went and described the bottle model of aortic valve with the sinuses for this complex structure, which we still try to understand and evaluate. So the aortic valve as such means only the three semilunar leaflets which are present. But the aortic root as a component involves the sinuses, interleaflet triangle, sinotubular junction, leaflet attachment, etc., etc. As I will go on, you will be understanding what are the components of the aortic root. Let's understand the relationship. So it is no wonder it means that aortic root is the center piece of the heart, which connects with the left ventricle and the ascending aorta. And from inside to outside, the aortic root is in relation to all the other chambers, left and the right ventricle, the left atrium and the right atrium. If you think this canopy is the import stands on this center pillar, similar as the heart, where the aorta is a central pillar and it encounters and it holds the entire structure together. Even the skeleton of the heart shows the such. So the relationship of the heart is in two directions. That is the external direction, that is the horizontal relationship across, that is the external relationship, and the internal relationship, which is just below the valves, that is the internal relationship. We see one by one. So all my diagrams in the entire talk will be positioned in such a way as for the surgeon's view. On top of the screen will be the assistant surgeon, and on the bottom of the screen will be the operating surgeon, and the position of all the diagrams will be in such a way. So we have the three cusps here. We'll just go by each cusp. The non-coronary cusp is positioned here. We have the left atrium and the right atrium. The non-coronary cusp is in relation to the left atrium and the right atrium on both sides. Then we have the left coronary cusp. We have the coronary artery, and then in relationship we have the at this juncture we have this towards the non-coronary we have the left atrium, and towards the right coronary we have the pulmonary artery. In between is the left coronary artery, and there is no other structure except the epicardium of the left ventricle. And the right coronary artery, right coronary cusp is in relation to the most of the portion is in relation to the RVOT, or the right ventricle. It is related. So this is the entire piece where the non-coronary is related to the left atrium and the left atrium and right atrium. The left is in relation to the left atrium, the epicardium, and the pulmonary artery, and the non-coronary and the right coronary, is in relation to the RVOT. So then we move on to internal structure. That is the structures in relation to the aortic valve, which are just below the aortic canal research. So these are structures. The structures in relationship between the non and the left. We have the aorta mitral curtain, which is represented in green color in this diagram. So this is the aorta mitral curtain. So the aorta mitral curtain is in relation to the non-coronary and the left coronary. And then between the right and the non, we have the AV node. So apart from that, all other areas are in relation to the RVOT, the brown color which is represented over here. And there is a small portion which is represented by the left ventricle free wall. So this orientation is very important for the multiple procedure which we perform across the aortic valve on the anterior part and across the aortic valve which we are going to perform. So the non-coronary in this region is related to the membranous septum, as Dr. James Ray was showing in his specimen, where you could see the illuminated membranous septum, which is in close relation, which is directly in relation to the right atrium, the segment. That is where the AV node penetrates and becomes a lobes. So moving on to the individual structures, the aortic valve has multiple components. So we read one by one. So this is the belly of the aortic valve, which is the stress bearing area. Then we have the base, that is the site of the attachment of the aortic valve. So in a semilunar manner. And then we have three commissures across the valve. So these are the three commissures where all the valves meet at a point. Unlike the mitral valve, where the valves are together at the commissures, in mitral valve, at the level of the commissures, the valves are not united; they are separated across. So individually, each valve can be excised. And there is a point called node of Arantes, where all the three cusps meet together to form the point of coaptation. That is a node of Arantes. So this point is very important, reconstruction of the prolapse of aortic valve. So we have to make sure that these 3 points coapt exactly for the valve when we are doing a repair of the aortic valve. At the base of each valve, there is a lowest point is called the nadir of a valve. So this point, so remember all these anatomy as we go on, you'll be able to understand why we are mentioning all these things. The commissures, the nadir, and the node of Arantes. So this aortic valve represents the hemodynamic junction between the LV and the aorta. Superior to it, distal to it is the arterial pressure, and the proximal to is the ventricular pressure. And it is so designed that this tri-leaflet gives the best optimal solution. Any one less, that is a bicuspid, or any one more, the quadrileaflet design will not have such an efficient solution. As you will see, these patients will always present with more stenosis than as compared to a tri-leaflet valve, which lasts longer. Have you ever wondered why this aortic leaflet, which is handling an aortic pressure, is thin as compared to the mitral valve, which is more thick, which is handling only a left ventricle? The reason behind this is that the aortic valve opens in systole and it is closed during the diastole, which means that the aortic valve is subjected only to the diastolic pressure. And while the mitral valve is closed during the systole, which means it's handling a higher pressure, the higher systolic pressure. And the force of the mitral valve is such that it flows only in two directions, whereas the aortic valve moves in two directions. One is towards the aortic valve, other is a bookward direction, where you can see which is marked in the yellow color. So it moves in a bookward direction, like book, and other is towards the aorta. So there are two motions of the aortic valve, and these two functions are important in maintaining the competence of the aortic valve. So the measurement is like the base of the aortic valve is 1.5 times, the measurement is 1.5 times rest of the free margin. And this free margin is twice the length of the height of the cusp. So this is 1.5 times. This is the free margin is twice that of the height of the aortic valve, height of the cusp. So moving on to the more complex structure, we call the annulus. So annulus as such is derived from the Latin word called annus, and it means a ring. But in reality, there are multiple definitions. So aorta is here, the marked in yellow color, left ventricle is brown in color. So this has to be a true annulus, but in reality, that is not. That is not. It has more than one definition. So between these two, which is marked in yellow color, we have the ventricular-atrial junction, and the attachment of the leaflet. So here you could see this is the muscular part and this is the aortic tissue, and this yellow color line is represented the ventricular-atrial junction. And then the attachment of the aortic valve, which is a crown-like structure, is represented by that is a crown-like coronet structure is there. The leaflets are attached in the semilunar junction, which divides part of the aortic tissue as part of the ventricular tissue will function as aorta, and part of the ventricular tissue will be functioning as a part of aortic tissue will be functioning as a ventricular because of this semilunar, because of this attachment. The point of the maximum connection, that is the point of the commissures together will be joined, is called a sinotubular junction, and the point which we connect all the nadirs are called the virtual versal ring. So we go in detail to each one of those as we go ahead. The radiologically, what the radiographers or the echocardiographers measure is this point. That is another which they measure. They won't be able to measure at this point or at this point. They will be measuring at the nether. So they measure at this the point C. This they measure the virtual basal ring. That is one level below the ventricular atrial junction. While as for a surgeon, the surgeon analyzes where across all the three junctions where we remove the valve and we take a suture line across the semilunar valves. So for the surgeons, this is the annulus. But in reality, there is no histological difference or an anatomical boundary exactly to fit this one. For all practical purpose, we take the smallest diameter between this pathway, between the LV and aorta. That is the portion of the prosthetic valve sizer which fits into it. So that is where we always say supraannular or infraannular for this. Jabrin El-Khoury, the one who has the maximum experience across the globe for valve functioning, and he has described a lot of procedure for his to his name. And he described the entire unit as a functional annulus, functional aortic annulus, where he is taken into the sinotubular junction, the attachment of the valves, the red color in color, and the valve sinotubular junction, which is blue in color, and the virtual basal ring, which is the green in color in this picture. Entire unit is called the functional aortic annulus. There is a reason for why it's being said, because a malalignment or mismatch, any one of this will lead to an aortic regurgitation. So, as I already mentioned, the ventricular-atrial junction is an anatomical junction, histologically, which is marked by the yellow color here. And the virtual basal ring is just a virtual line. It's just a virtual line. There is nothing exists there, but it is a virtual line connecting all the others. That is the lowest point of the. So, the ventricular-atrial junction has a different thickness at multiple areas. So, if you could see more towards the RVOT, represented by this one, it is a muscular septum. Here the thickness will be around 0.7 to 0.8. And near the itomatrial curtain, where it is more of a fibrous tissue, it is around 0.5. And towards the membranous septum, it is around 0.3. So on average, it is around 0.4 to 0.3 across the circumference of this ventricular-atrial junction. So moving on to next to the sinotubular junction. The sinotubular junction is the superior margin, which I have already mentioned, connecting all the commissures. So the measurement is the architect of this functional aortic annulus is very important. So as over the age or during the or patient with hypertension, there are always a dilatation. But this geometrical dimension is maintained across all the things. So A represents the sinotubular junction, which is around 0.57, that is 75% of the maximum diameter of the sinotubular junction, of the maximum diameter of the sinus of Valsalva. And it is 1.3 times larger than the measured annulus at the which is called as the virtual basal ring. Any mismatch where the STJ is enlarged, that is, it will separate apart, it will move apart the commissures, causing regurgitation, or a sinotube, or there is a junction where there is a dilatation in the sinus of Valsalva. There will be a mismatch, and patient will present with aortic regurgitation. So this sinus of Valsalva is a small bulge which you could see, which is present over this area, which is enclosing the different valves. So this is where it is named after the Italian anatomy is called the Antonio Valsalva. As you would have known, it is actually three, named after the coronary cusp, right, left, and the non. So the function of this is to create vortex, and this vortex will reduce the stress of the long-standing aortic valve. So that this valve doesn't get earlier, doesn't undergo wear and tear earlier. Further, it provides a constrict vertex so that the blood flow into the coronary artery is extremely good and it is maintained. And here you could see the anatomy of this sinus of Valsalva is not the same. Across the movement, it will just move from a funnel shape to a reverse funnel shape. That is how the function of this sinotubular junction is measured. So this is the law of inertia, where a fast moving car is there and somebody doesn't wear a seatbelt. And when there is a sudden brake, the person without a seatbelt will just move forward and is the one who gets hits first. It's a similar way, and this is the law of inertia, where if you don't keep that movement in constant, because of this anatomy, what will happen is the fast flow junction, fast ejection will create a hitting on this particular area, creating a dilatation. So to avoid this one, there is a funnel and reverse funnel shape of this sinotubular junction, which is being happening. This is a study which was published in JT series Grade 2 in 2004. They've studied the flow pattern in a normal route and a patient who has undergone a valve replacement with a straight trap. You could see the velocity as the velocity comes down after during the diastole. The vortex is maintained here for that the coronary flow is being maintained. As compared to the replaced aorta, where the vortex is not being maintained and the flow is very much hampered, and that could be a displacement of the blood flow. Laminar flow can be displaced. So another segment of the sinus of Valsalva is that all the sinus of Valsalva is not aligned, is not of same sizes. They are totally asymmetrical. Even though they look similar, they are totally asymmetrical. This is because there is an angle between this junction, that is the green line, that is the virtual basal angle, and a sinotubular junction. There is an angle of around 10 degrees, 5 to 10 degrees is there. This is because of the curvature of the aorta. The aorta is being curved across the greater curvature to lesser curvature. Where the lesser curvature, the left coronary is maintained at the left at the lesser curvature, and the greater curvature we have the non-coronary or the right coronary. And because of that curvature, the angle between these two are around 5 to 10 degrees. So there is an increased stress in the right and the non-coronary. So, which is geometrically, we'll see a dilatation in these two at the early stage. And the smallest of which is the left coronary, left sinus of Valsalva, where the dilatation is the minimum. The next anatomical structure is the interleaflet triangle. That is exactly opposite to the sinus of Valsalva in the ventricular segment, where this called where it marked as the pink in color. That is the interleaflet triangle. The interleaflet triangle are very important. You'll understand why. So these assets are also not of same size and they are totally asymmetrical, and they are very vital importance for maintaining the normal function of the aortic valve. So in a bileaflet valve, there is one leaflet which is an interleaflet triangle which is very small. So this probably on a longer run, which can cause a stenotic lesion or a regurgitation because of the mismatch of this interleaflet triangle. So the anatomical relationship of these triangles are very important. So this is a triangle. So we have the left and the non-coronary here, and this juncture, just below that we have the aorta below the left and the angle. Between the non and the right, where the AV node is there, the membranous septum is all present over this area. The membranous septum and the AV node here. So during taking stitches for a normal aortic valve, we have to be very careful at this point. We can injure the membranous septum. Or else in a patient where there is a remodeling, we have to place a suture at this segment, at this level, which can injure the where we could injure the aortic valve in the AV node. So this segment is very, very important. That is the interleaflet triangle between the right and the non. And the third segment is between the right and the left, where it is below the muscular septum, and it is of smallest size. So moving on to the clinical anatomy of what we have already mentioned, we have the AV node between the right and the non. A deeper stitch here could injure the node, and patient can postoperatively can have a nodal block. Then we move on to a more complex root enlargement, where we have to divide. So remember my earlier diagram which I showed you. So this is the right, left, and non-coronary, and the perfect anatomy which we showed you. We have the left atrium, epicardium, PA, RVOT, and the right atrium. And these are the valve cusps, which we mark, where the non is marked in blue, then violet by the left, and yellow color by the right side. And these are the internal structure which is made. Green is maintained by the green is the aorta metal curtain. This is the septum, and this is the membranous septum here. So the Manojin procedure is where we cut across between the non and the right, where we cut across this segment. It is between these two, extending into the left atrium and into the aorta mitral curtain, and finally into the mitral leaflet. So this is the Manojin procedure. So eventually we have to reconstruct the left atrium, the aorta, and the anterior mitral leaflet. The next procedure is where there is a transaction at this level between the on the leaflet or on the right coronary, on the non-coronary leaflet into the mitral pattern, and this doesn't extend into the anterior mitral leaflet. Now, but it extends in the left atrium, so we have to reconstruct the left atrium as well. And the coronary is an anterior root enlargement at this segment, that is on the anterior segment. It is between these coronary ostium and not towards the not between the left and the left and the right coronary cusp. On the right coronary cusp, the incision is made. So it is at this segment which is being made here. At this segment. At this segment. So if you make any incision here, there could be an injury to the right coronary artery. So the incision is made here. It will cut across the RVOT, the leaflet, and into the muscular septum. So the reconstruction has to be. So we have to reconstruct the ventricular septum, the RVOT free wall, and the aorta. So I already mentioned the functional anatomy is being maintained by all these structures, which has to be intact. Otherwise, the patient can have a problem. So the anatomy, the mechanism of AR can be because of the functional unit or the pathology of the individual leaflet as such. So that is how the Debrine has classified this classification, where in type 1 aortic regurgitation, the aortic root, the aortic root is normal, and only the distal segment, the STJ, is dilated. In this segment, the leaflets are normal. So this is a type 1 aortic regurgitation, where you just need to replace the ascending aorta and correct the STJ. So the remaining segments are normal. Usually this will get corrected. And if it extends down below into the sinus of Valsalva or the interleaflet triangle, that is when we need to remodel the remodel in the aortic root. So that happens in type 1B, where the STJ and the sinus of Valsalva is dilated. In such cases, we have to reimplant or remodel the aorta. And type 1C is where there is no problem with the aortic root. It is a problem with the leaflet. So that is a perforation because of an endocarditis or because of the pathologies, where just a patch closure is enough. Prolapse of a mitral valve is a prolapse of the leaflet, and the root is being maintained. So most of the time, when the root is being maintained, the prolapse can be corrected with the valve procedures. The valve procedure is enough. But if there is association of the root dilatation, if you remember, I have told you that the non-coronary sometimes gets dilated more. In such cases, there might be a annuloplasty of the functional aortic ring, where we might require dilatation. We have to repair also the prolapsed sinus of Valsalva as such, with the reimplantation of remodeling technique as such. And type 3 is cusp retraction, where we need shaving with more of an aortic stenosis combined with regurgitation. Cusp shaving, all those parts will be required. So to conclude, aortic leaflet is, which aortic valve just means the leaflet, and aortic root, which has the aortic leaflet, sinotubular junction, the basal ring, that is the annulus, functional aortic ring, then interleaflet triangle, and sinus of Valsalva. And each component has a unique function to maintain the function of the aortic valve. To understand and to conduct a proper surgery, we need to know about the external anatomy, the horizontal anatomy and the internal anatomy, and the function of all these things. So before getting into operating. So I thank the team for giving me this wonderful opportunity. Thank you, one and all.
Thank you, Dr. Mohammed Idris. That was a fantastic talk, and that was Dr. Idris for you, with all his experience with the aortic valve, and also his beautiful pictures. He is a wonderful illustrator. Thank you so much, Dr. Idris. Thank you.
Thank you, sir. Thank you.
We now move on to the left ventricle. We have Dr. Rani with us. She's the adult surgeon there at Madurai, and she is going to talk to us about the left ventricle. Over to Dr. Rani.
Good afternoon to everybody. First of all, I want to thank Dr. Jacob for organizing such a nice course to enlighten us, to refresh us periodically. The topic given for me is left ventricle. The left ventricle, you know, it's a very important chamber among four. The whole cardiac action is expressed only through this discharging chamber, left ventricle. So in this view, it's the left laterally placed left ventricle. It's, you are seeing the whole left ventricle nicely. Once you go for the anterior view, you'll see only the sternocostal surface well. So it's highlights of left ventricle is the important chamber among the four. It's a powerful chamber. It's provided with more of myocardial mass. It's unique in many features. It's a maximum myocardium, I said. It's a thick wall chamber that interacts with the left atrium through the mitral valve and with the ascending aorta through aortic office. So more than half of the weight of the heart is by the left ventricular muscle mass. So this is a conical muscular chamber. It gives the apex of the heart and small part of the sternocostal surface is contributed by this left ventricle, and the majority of the left 2/3 of the diaphragmatic surface and the inferior border is contributed by the left ventricle, and the left border and the left surface of the heart is also by the left ventricle. So this is the sternocostal surface. You are seeing the anterior aspect of the left ventricle is only the minimum. Not much, only the right ventricle is shown fully. The left ventricle, left lateral surface alone seen here with the apex pointing left lateral side. So this is the posterior aspect. More than 2/3 of the left ventricle posterior surface is occupied by the left ventricle and demarcated from the right ventricle by the posterior interventricular groove. So this is related to the right ventricle and the anterior aspect. The right ventricle, it's hugging the left ventricle above the interventricular septum. The most leftward rim is projecting the cardiac silhouette as the apical region. The anteriorly, it's related to the interventricular chamber septum over that right ventricle. Posteriorly, it is related to the descending aorta, left vagus, and also sympathetic chain it comes. Superiorly, it's separated from the left atrium by the atrioventricular groove of the left side. Right side is related to the right pleura, left side to the left pleura and the phrenic nerve. The sternocostal surface is separated from the diaphragmatic surface by the short inferior border. The region where the inferior border meets the left border forms the apex. The anterior and the posterior interventricular groove separates left ventricle from the right. Both grooves meet at the apex. So this anterior and posterior interventricular grooves are very important landmarks for the left ventricle. It separates from the right ventricle. Anterior interventricular groove is seen on the sternocostal surface that contains anterior interventricular artery, that is LAD, and great cardiac vein. The posterior interventricular groove is seen on the diaphragmatic surface, the centrally placed one, that largest interventricular artery and middle cardiac vein. The meeting point of both the grooves, the posterior interventricular groove and the posterior part of the atrioventricular groove, that is called the crux of the heart. So we have to study the dimension of the LV. That's very important. That's overall reflect how the heart is, how it's a functioning status, whether it's very much dilated or the cavity is reduced. Reduced means was restrictive cardiomyopathy. It's very much dilated. So dilated cardiomyopathy. With all the inferences, we get only by seeing that left ventricle through echo. So normal dimensions of the average adult heart is 2 to 4 centimeters in systole, and in diastole 3.5 to 5.5 centimeters. All of you know how it comes in during systolic. So that's called fractional shortening, systolic indrawing of the wall. The dilated heart, the chamber size, the dimension goes beyond 5.8 centimeters, and the wall is also very much thinned out. So with this, we can calculate ejection fraction and a fractional shortening. The big heart is not a good heart, it's a bad heart. It predisposes all sort of complications like arrhythmia, thrombus formation, aneurysm formation. It is also the high risk for sudden cardiac death. So left ventricle is the thickest muscle wall among all 4 chambers. The mass, the ventricular mass axis is thickest at the base than at the apex. So it's more thicker in the base. It's around 10 to 12 mm. Once it comes down in the mid cavity level and the apex level, it reduces. At the apex, it's only 1 to 2 millimeter thickness. This property is utilized for many procedures. In systole, the thickness is more, 9 to 12 mm gets thickened, and diastole, it's only 6 to 9 mm. When comparing with the right ventricle, it's 3 to 6 times thicker than right ventricle and produces 5 times stronger contraction. In athletes, the thickness will increase even up to 40 millimeter. So how thickness varies from the basal level to the apical level. This is depicted in this picture. This is very important for the surgeons, where to handle, where should be careful. Everything can be assessed with this image. This is the volume of the left ventricle. This also differs in during systole and diastole. The difference between is only the stroke volume. So when it goes beyond this limit, the heart is not in good. And systolic volume increases, the ejection is not good. And diastolic volume increases, the contractile function of the heart is not good. So the thickness of the cardiac wall is shown well. This also designs the shape of the chamber. The right ventricle, this produces semilunar shape because of the bulge of the interventricular septum into the right ventricle. The left ventricle is getting the circular shape because of the muscle mass, also the concavity of the interventricular septum. So in dilated cardiomyopathy, see how the muscle mass, the left ventricular mass is very much thinned out. The circular nature is gone. It becomes spherical. That's one index called the sphericity index. That means the dilated chamber, the contractile function is out. So this is the chamber, the good cardiac muscle mass. So the weight of the heart is around 280 grams. It varies with males and females. In old age, the weight may increase. And there's formula to calculate how the left ventricular mass, the whole heart mass, and also the LV mass. This point is very important. So the big mass heart people are prone for sudden cardiac death and that mismatch between the demand and supply. And if the LV mass, it's more than 200 grams, that happens in hypertrophic obstructive cardiomyopathy. The demand will be more. The coronaries may not be able to supply or will get into trouble. So the LV mass comes when indexed to body surface area, it's around 110 to 120 per square meter, but in HOCM it goes beyond 200. More muscle mass is not going to help the heart to contract more. It's going to affect the cardiac function by increasing the stiffness. The relaxation property is not good. The diastolic volume definitely will come down. The cardiac output also will come down. So this will predispose to coronary artery disease also. So while calculating the cardioplegia dose during our cardiac surgery, the LV mass to be taken into account. In aortic stenosis, we are operating, the LV mass definitely will be more. Better go for little higher doses. Instead of 10 to 20 ml, you can give more. The sudden cardiac death is also protected in these people. The free wall of the left ventricle is the portion, the ventricular, not from the IVS, and also from the apex, the portion which is not in contact with IVS. This extends from the LV groove, from the region of the aortomitral continuity to the lateral to the IVS. It's divided into 5 segments. This is all very important to study the regional wall motion in these chambers to decide on ejection fraction, the whole left ventricular function. The base of the left ventricle is from the papillary muscle to the plane of atrioventricular groove. That is the infundibular part, the first part of the left ventricle. This is separated from the LA by the atrioventricular groove anteriorly and from the coronary sinus and the coronary sulcus posteriorly. The apex, this is very important part in surgical anatomical aspect and also the cardiac surgeon's point of view. This is directed anterior inferior and is away from the vital structures. So this point is utilized for making as an entry point for the valvular therapies. The myocardium is well thin in this area. This is used for placing LV assist devices and also for drainage tubes. But while manipulating the heart also, we have to take much care, avoid perforation. And because of this only, the catheters and the electrodes are used more on the RV side. This part of apex is prone for dilatation, aneurysm formation, and thrombus formation. So the left ventricle systolic function is assessed with all variables. We are very familiar with the ejection fraction, the amount of blood is ejected during systole, and it's by the end diastolic volume cube minus end systolic volume cube divided by end diastolic volume cube into 100. Normally it's around 60%. Which less than that, we say its cardiac function is coming down. It's dilated cardiomyopathy and all, it will go even below 30%. The fraction shortening is the term used how the cardiac muscle coming in during systolic. should have at least 30% of indroid. If it is there only, it's a normal heart. If it's not that much, there is a regional wall motion abnormality, it's a hypokinetic or akinetic or dyskinetic. We can decide on that. The stroke volume, you know how much is ejected. The regional wall motion analysis are all very important for the cardiologist to view the chambers in different levels, and they calculate the total number of segments and how the status of the segment, whether this is normokinetic, hypo or akinetic. Based on that, they'll assess the regional wall motion abnormality index. There's a tissue velocity and the tissue tracking all utilized to assess the LV function. The segments of the left ventricle, as I had told it, to assess the regional wall motion abnormality is totally 17 segments. If it is normokinetic, normally moving segments, you'll get 1. The index is 1. So if it is the hypokinetic, the fractional shortening is less than 30%. If it is akinetic, no inward movement at all. Dyskinetic, instead of coming in, it goes out during systolic. Aneurysmal, all the 3 layers thinned out and it's prolapsed and forms a bulge. It gets filled up during systolic. So this is the echo image showing how the each segment is. And with CD, you can assess how it's moving, whether it's normokinetic, akinetic, or dyskinetic. This is the segmental model. All segments in number with the coronary arteries distribution also. So when going to the interior, when we open the left ventricle along the lateral border, we'll enter into the interior of the left ventricle. There are 3 parts in the interior, as the inflow part, trabecular part, and outflow part. Inflow part is more concerned with mitral valve. That's dealt very much by Dr. Theodore. And this is rough part only. It starts with mitral valve to the papillary muscle. This is with the caudate tendinae and the papillary muscles. It's very important. See, left mitral apparatus. This is as a single unit. It has 6 components: left atrium, mitral valve leaflets, mitral valve annulus, chordae, papillary muscles, left ventricle. Everything to work in together in synchrony to get a nice morphological mitral valve and function. If anything is altered, you get abnormal mitral valve function. The trabecular part, when comparing with the right ventricle, the trabeculation is a delicate, fine. It's not very rough. Dr. Ravi was showing one image with coarse trabeculations in the right ventricle with a fine in the left ventricle. And there are ridges. Ridges is surface elevations of the left ventricle, and bridges connects the surfaces. And the pillars, the surface elevations of papillary muscles are called pillars. And then fine small trabeculations will be present. The false tendon is the one entity. So differential diagnosis like a moderate band in the right ventricle. This arises from the papillary muscle, but not going and getting attached to the mitral valve. It gets attached to the wall of the free wall of the left ventricle. So developmentally, this part of the left ventricle is from the left half of the primitive ventricle. Then outflow part, this is called aortic vestibule. It's a very smooth part. The septum lining that part is also very smooth, no trabeculations at all. Embryologically also the origin is different. It's from the bulbous part. The definition between the first part, inflow part, trabecular part, outflow part, it's all very indistinct only, not clear-cut margins. So this is the image how both the atrioventricular valves, which and the aortic valve comes in, and left ventricular outflow tract. See, normally it's a left-sided structure. It goes to the right. We remember with one mnemonics, PALS, P-A-L-S. Pulmonary arteries left and superior. Now my LV outflow tract is going to the right because of the right ventricular infundibulum. That's the reason the LV aortic orifice to the right of the pulmonary valve. So the trabecular cornea of the left ventricle is similar, but it's smooth. And 2 papillary muscles are very important. There are posterior-medial and anterior-lateral. No moderator band causing this one. The papillary muscles are connected to the cusp of the mitral valve by the caudate tendinae. The trabeculations, the papillary muscles here well developed in the left ventricle when comparing with the right ventricle. So one clear-cut distinction is no septal attachment. There in right ventricle, you get a right ventricle septal muscle attached. The hypertrophic heart, the trabeculations are increased. There will be abnormality in the caudate, papillary muscles, the origin and the insertion and the anatomical and the gross appearance, accessory papillary muscles, and more papillary heads, and all abnormalities will be there. Even if you go for calcification and all things happen. The orientation is very crisscross. The presence of this tubercular cornea helps LV and augments LV without causing the thickness of the left ventricle. Here is shown how the smooth tuberculations of the left ventricle, and this part is aortic vestibule. The septum lining here is free from tuberculations. So just already informed points only. They develop from the primitive ventricle inflow part. That is the part it concerned with mitral valve and its apparatus. The outflow part is aortic vestibule. It's from bulbous cordis. This lies below the aortic valve. The membranous part of the interventricular septum and anterior mitral leaflet that divides the outflow and inflow part. The rough part due to presence of the tuberculations in the inflow part. Here it's smooth outflow. So this picture was shown by Muhammad also. See, we know the ventriculo-aortic junction. There is anatomical and hemodynamic. But in the interleaflet triangle, my ventricular myocardium gets in. So any changes in the pathology will be there in this myocardium also. Any ectopic focus can cause ventricular tachycardia. This part to be remembered. And dealing with this myocardium, it can be dealt with RVOT of the right ventricle. There are two openings. Both openings dealt well by the previous speakers. And this point to be remembered by the students, because the chambers, my left ventricle is not the left chamber. It can occupy in more positions and cardiac abnormalities. And if it is diseased, it's very difficult to differentiate which is right ventricle and left ventricle. So these points to be remembered, even while doing echo, we have to see each and every point. Right ventricle, that infundibulum now separates the pulmonary valve and it's not getting into the central skeleton of the heart. So right ventricle is semilunar. The thickness of the wall is only up to 3 to 4 millimeters. 3 papillary muscles are there, not well developed in comparing with the left ventricle. The septal attachment of the septal papillary muscle helps to identify the right ventricle. The tuberculations are very close. TSM1 is very dominant feature in our right ventricle. The moderator band is present in the right ventricle. The tricuspid valve attachment is more towards the apex than the mitral valve attachment in the septum. So the distance between the tricuspid valve attachment and the mitral valve attachment is the atrioventricular septum. So the distance is very important. If it is more, we have to think of Epstein anomaly. That part only, a lot of vital structures coming out and taking bites and dealing with that area, we have to be very, very, very careful. The supraventricular crust is present in the right ventricle, and right ventricle contributes mainly to the inferior border. So in coming to the left ventricle, everything is ultra of that. Its aortic vestibule forms the upper anterior border. All the partitions are ill-defined one. It's a circular chamber. The muscle thickness comes to 9 to 12 mm. All papillary muscles are well developed with the fine tuberculations. No septal attachment of the papillary muscles. This point will be remembered. And no supraventricular thrust, no moderator band. As I already told, the mitral valve attachment is behind the tricuspid valve. So the blood supply, it's dealt very well by Dr. Jacob James Raj. My part, that left ventricle is mainly dependent on LAD supply and also from the LCX, and posterior interventricular artery also gives branches to the posterior surface. So all branches coming and helping. So this is shown how all vessels supplying my whole of the left ventricle. Cordon tendineae, it's discussed already, but little more of my left ventricular component. It's a thick, strong structure. It's like a pulley, connects the mitral valve and the papillary muscle. So this is a very important component. This now helps for the mitral valve closure and also for the LV cardiac function. If anything goes down, no, the cardiac rupture happens during myocardial infarction. The LV function is also affected. The closure of the mitral valve is affected. It goes for mitral regurgitation. So it helps for maintaining the geometry of the LV and function of the LV. So during our surgical procedures like mitral valve replacement, if you are able to preserve the chordae, the configuration of the LV will be good. The post-op outcome also good in these people. Anatomically and functionally, and the study of the chordae tendon is very important for the surgeons. So where the preference is given because the mitral valve sparing surgeries now, Theodore sir was telling how to be more towards replacement than repair. But nowadays, more fancy towards repair procedures. For that, the anatomy and the appearance of all chordates and which chordae is very important, how the commissural chordae all to be differentiated and the abnormal chordae to be identified, and that replacement of the chordae we should be able to do. So this is very important for the surgeon's point of view. So this the chordae, it gets attached to different levels in the anterior leaflet and posterior leaflet. There are marginal chordae and rough zone chordae and free zone. Basal chordae only to the posterior leaflet. So these are different names for the different caudal attachments. So one point to be convinced here is both papillary muscles give chordae tendinae to the both leaflets of the mitral leaflet, both leaflets, mitral valve. So if anything goes wrong, one leaflet, one papillary muscle is affected. Very commonly, the posterior medial papillary muscle is affected because of the single blood supply. The whole valve get into trouble, it regurgitate. So what are the types of chordae? Apical pillar chordae is the true chordae. Starts from the apex of the papillary muscle, goes and gets attached to the mitral valve. Basal pillar comes from the base of the papillary muscle. True chordae is if it goes up to the mitral valve. False is going to the free wall of the LV or other structures. Interpillar between the papillary muscles you are getting chordae. Pillar walk from the pillar to the wall. Cusp chordae, cleft, the cleft you know, the commissural chordae. There are first order, second order, third order chordaes, free zone, marginal, and rough zone chordaes. So types of chordae, whether this is straight, unbranched, or branched and fan-shaped and spiral, web-forming, and tendinous, muscular. There is muscular chordae. 14% of the cases will get muscular chordae. And membranous. See, everything to be assessed. See, if the straight chordae is going to the commissure, the function may not be that much good. We want branched chordae only for the commissures. So chordae is classified based on its origin, attachment, and its insertion and its distribution and the branching pattern, whether this is tendinous, membranous, or muscular. So this I want to tell the caudal, how we are going to replace. So this anatomy and all is very important for the surgeons who deal with mitral valve repair procedures. So this here I want to insist one point. This is the posterior medial papillary muscle. This is the anterolateral papillary muscle. The posterior medial papillary muscle is close to interventricular septum. Anterolateral papillary muscle attached to the sternocostal surface. See, this has dual blood supply. It's only single blood supply. So this looks just bulkier than this. The chordae, multiple abnormalities like bifid heads and all abnormalities common in the posterior medial papillary muscle. So the functions of the chordae as already told, maintains the configuration and helps for the contractile functions of the LV, augments, and it's very important for the mitral valve function. It prevents mitral valve prolapse during left ventricular systole. So this is the mitral valve apparatus. Everything acts as a single unit. Anything goes wrong in the muscle. So if there is any infarcted myocardium here, definitely this papillary muscle will be affected. The chordae coming from here will not be tension. The tension apparatus is lost here. That with this leaflet, the functioning will not be good. So the papillary muscles are conical surface elevations of the left ventricle. There are two papillary muscles here, anterior papillary muscle and posterior papillary muscle. They are small elevations and present in the LV cavity. It's very important for the function of the left ventricle. There are two groups I told to study the papillary muscles. In cases of single papillary muscle, there are abnormalities, bifid papillary muscles. A nice tool to study everything in detail is MRI. So anterolateral papillary muscle, it's from the anterolateral surface where it meets the inferolateral wall. It's in the sternocostal surface. Posterior medial papillary muscle is near its attachment to the septum. So one papillary muscle you are seeing close to the septum is posterior medial, and comes anterior aspect is anterolateral papillary muscle. So already discussed how many chordae from this varies from individual to individual. Each papillary head gives about 12 primary chordae. See, the level of origin, since at the tip of the papillary muscle, the number of chordae will be less. And the site of insertion, you will see plenty of chordae. After branching, primary, secondary, tertiary, it goes up to even 64. So each head gives rise to 64 chordae. So totally, it comes around 128. Even it goes up. Any damage, one papillary muscle will affect both leaflets. So the blood supply, this point to be remembered. It's very important for the surgeons. So anterior lateral papillary muscle has a rich dual blood supply from LAD as well as from LCX. That's why the muscle is also bulky. The posterior medial depends on the dominance. RV dominance will get from CA or LCX. So ischemic MR, it's very common with right coronary artery involvement. Posterior medial papillary muscle is affected in this. So the function of the papillary muscle as a whole is to help for the closure of the mitral valve, prevents the bulge into the left atrium during systole. This when it's ruptured, it definitely affects the LV function and also the mitral valve function. So the abnormalities in the papillary muscles can result in dysfunction of the mitral valve and also ineffective cardiac output of the left ventricle. So this is the echo image of the papillary muscles. One close to IVS is posterior medial papillary muscle. This interpapillary muscle distance is very important. So you are seeing the echo on short axis, you are seeing both papillary muscle. Just by looking at the interpapillary muscle distance, we can say how much is the EF. So it maintains a circular configuration and the distance is not very much, it's not separated. So this is a good heart. There are variations in the papillary muscle, congenital, maybe multiple papillary muscles coming symptomatic or asymptomatic. Symptomatic means what? More papillary muscle causing LVOT obstruction can present with left ventricular hypertrophy. Some asymptomatic people that present as a chamber-like structure and can cause only murmur, nothing much. And parachute mitral valve is a single papillary muscle or fusion of the two muscles. So chordae goes to both, but it's ineffective. It will present with mitral stenosis. The incidence is 0.5%. The papillary muscle abnormalities, as I already told, it's very common in hypertrophy heart. Multiple hits in the papillary muscle, accessory papillary muscles, and the distance and occupying more LV cavity and reducing the LV cavity. And with the more abnormalities in the papillary muscle, the ventricular relaxation function also will be affected. So very important part of LV is the myocardium. This is very unique for left ventricle. There are 3 layers in the myocardium. Superficial, the cardiac muscle unique. I don't want to go into the details. Provided with many mitochondria, it's attached to each is attached in chains. So when fired, all muscles will go in action in chains. So the myocardium content is more in the left ventricle comparing with the other chambers. So this myocardium is very important to have a very good cardiac output. So there are 3 layers. See, this muscles squeeze the left ventricle and produce good systolic slope volume. The contraction, it's all, there are many theories proposed how it acts. There is one vertex in the apex and the forces transmitted towards the aortic vestibule to have their good cardiac output through the aortic valve. And there are superficial layer in connection with the deep layer so that it twists, torsion nicely to have a good cardiac output. So it has an elegant and complex pattern with a figure of 8 pattern. It very much helps for the systole. And if anything goes down and the muscular contraction is affected, the cardiac function is very much affected. The 3 layers to be remembered very much, it should be known to all. Superficial layer, middle layer, and deep layer. Superficial is subepicardial layer. This is oblique. The orientation of the muscle fibers is oblique. This sweep into the interventricular septum and goes to the right ventricle. The obliquity is more in the right ventricle. And middle layer is the thickest layer of all. This is specific to the left ventricle. This is circumferential in nature. This only gives the squeezing property. And it's very near the base, and towards apex is very much less in thickness. It encircles the inlet portions. The superficial encircles the mitral valves and the roots. Here, inlet portions and outlet portions are encircled with middle layer. And the deep one is the thinnest layer of all. This is subendocardial layer. They fuse with all muscles. So there is no definite cleavage planes, but they fuse with each other to have a synchronized cardiac contraction. So this is how it works. It's not goes in one direction. Goes in a swirling pattern, goes in a torsion and pushes the blood out. So myocardial mass, the left ventricular mass, it's very important. More than 200 milligram. It's a hypertrophy in heart. The sudden cardiac death and all very common. And the muscle mass increases. Definitely the myocardial contractile function comes down because of poor relaxation property. The interventricular septum, it's already dealt during right ventricular anatomy. This is not in a one plane. It's very much oblique. This is because of three reasons. The process of the right ventricle, that infundibulum septum, the course makes LVOT to traverse from left to right. That makes that obliquity. Another one is the axis of the right ventricle is different from the left ventricle. Right ventricle is vertical axis. The left ventricle is oblique. All makes the interventricular septum is not in one plane. It's in an oblique plane. The right anterior interventricular groove and posterior interventricular groove is the site of attachment of the interventricular septum. The septum is thin near the aortic valve. So during aortic valve study, it's discussed. You have to be very careful. The membrane, fibrous tissue replacing the myocardium there. Have to be very careful while doing procedures there. So this is the membranous septum of the heart. This is muscular septum. Muscular septum is very much thick. The attachments of the tricuspid valve and mitral valve. This area is the atrioventricular septum. It has both fibrous component and a membranous component. Interventricular septum blood supply, it's anterior two-third is by the left ventricular LEAD, and posterior two-third is from the right coronary, period from the right coronary artery. Development of the interventricular septum, it's nicely discussed by Dr. Krishna Manohar. See, this is the dorsal and ventral AV cushion fusion. And also the muscular part of the interventricular septum is due to bulboventricular flange because of the differential growth of the primitive ventricle and the bulbous cordis. But membranous part, it's a neural crest. It connects the upper free margin of the bulboventricular flange and also the cushions of the AV canal. It's attached to also to the lower part of the spiral septum. That's called aorta pulmonale septum. So the AV septum, it's already told, it's between the septal attachment of the mitral valve and tricuspid valve. Again, the conduction system of the left ventricle is also very important. The left ventricular muscle is myogenic. No need of nerve impulse to come and trigger the LV muscle to start the function. So from SA node, AV node comes everything in our right atrium, and then the bundle of his comes that penetrates between the membranous and muscular part of the interventricular AV septum. Then it encases into the interventricular septum. The first right branch goes, and then the left branch, it divides into anterior and posterior branch. So this also helps for the left ventricle to contract in a better way, augments the left ventricular contraction. Now, one point to be mentioned here is the conduction system reaches the left ventricle. The first one gets twig is from the papillary muscle. So the papillary muscle contracts first before the LV contracts. So this property helps for the preparation and the early closure of the mitral valve and doing in a better way. So what are the variant anatomy in the left ventricle? There's double inlet. Both the right atrium comes, right atrium and left atrium draining into LV. Double outlet, both great vessels coming out. The parachute mitral valve is a single papillary muscle causing mitral valve stenosis. And congenital mitral stenosis may be the fusion of the mitral papillary muscles. There is one entity called Schon's complex provided with 4 components. One is single papillary muscle parachute mitral valve. Another one is supramitral ring, coarctation of the aorta, subvalvular aortic stenosis in the form of subaortic membrane. Double chambered LV, there's a good intervascular, the ridges, making the chamber into 2. Not causing much problem, it's asymptomatic. If at all, the murmur you can hear. The false tendon is not true tendon, it connects the caudate tendinate, connects the papillary muscle with the LV one. It may confuse the moderator, but the moderator tendon is as a unique course, not like this LV false tendon. There is one entity called aortico-left ventricular tunnel. See, this is the passage between the left ventricular cavity with aorta. That vessel runs through paravalvular through the aortic valve, not penetrating into the interventricular septum. So this shunt to be differentiated from VSD, RSOV, and aorta pulmonary window. This aorta left ventricular tunnel, VSD, you know, it's beneath the aortic valve. RSOV, it's above the aortic valve, below that sinotubular ridge. Anterior aorta pulmonary window above the sinotubular ridge into the pulmonary vein. But in the ALVT, this is above the sinotubular ridge, but it comes into the LV. So with color flow, we can differentiate what is this shunt is. Subaortic membrane, fibromuscular ridge and fibromuscular tunnel and all, the variant anatomy in the left ventricle, you can have it below the left ventricle. Subaortic membrane presence may not be diagnosed clinically or even missed in echo, just beneath the aortic leaflets. The clue to diagnosis, the patient may have a left ventricular hypertrophy. And in MO, you can see the premature closure of the aortic valve. These are the clues, but it has to be dealt. While doing echo for this patient, the anterior mitral leaflet attachment of this membrane, that anatomical point to be studied well before dealing with this. And then one entity is called a fibromuscular ridge. It causes LVOT obstruction, and the fibromuscular tunnel is a funnel-like tunnel obliterating the left ventricular outflow tract. There are related pathologies in the left ventricle, non-compaction, the persistence of the embryonic left ventricle. It's a spongy myocardium. This cavernous sinusoids are present, not well-developed vasculature. The spongy myocardium is present that obliterates the cavity. The ventricular function will not be that much good. The hypoplastic left ventricle, not well-developed wall, left ventricular hypertrophy to be assessed in detail. That should be dealt. Any condition causing left ventricular hypertrophy to be dealt. Otherwise, the muscle will go out of its function and the laxation property will last, and sudden cardiac death possibilities are more. LV aneurysm, as I have told it, there is different thickness in different areas. The apex has a less thickness, 1 to 2 millimeter. That part can get affected. Dyskinetic, akinetic aneurysma segments will predispose to aneurysm formation. Endomyocardial fibroelastosis is one pathology. Produces echogenic myocardium, the muscle mass, it's echogenic. In M mode also you can diagnose if it affects cardiac function. Cardiomyopathy is due to different causes, dilated cardiomyopathy, restricted cardiomyopathy, infiltrate disorders like amyloidosis, glycogen storage disease, all affects the myocardial function of the heart. The tumors can be primary, secondary, and secondary is very common. Metastasis, that's only 1% occurs in the heart. The primary is fibromas, papillomas, and myxomas. It's how LA myxomas common in LA, you can get in LV also. So just I want to run small video to show all my parts. So this is anterior aspect shown, so posterior aspect is shown, so posterior interventricular groove, anterior interventricular groove is here. So this is the left lateral wall, it's forming the apex here. And so cut open through the left lateral wall. This is the inflowing tract, mitral valve here. This is papillary muscles. Close to the septum is the anterolateral papillary muscle. This is mitral valve, the caudate tendinae attachment. This is called inflow tract. So the left atrioventricular orifice is the mitral orifice. We are seeing both anterior leaflet and posterior leaflet. The anterior leaflet is well shown here. This only forms boundary for the inflow and outflow. Both inflow and outflow makes a right angle. The outflow tract of the left ventricle is parallel with the inflow. See the inflow tract of the right ventricle, both parallel to each other. See the tabaculations, very smooth here. There are ridges, the surface elevations, papillary muscle and bridges here. This papillary muscle close to interventricular septum is posterior. The sternocostal surface is anterior. Anterior papillary muscle is bulkier than the posterior medial papillary muscle. The caudate tendinae here. Here we have to identify thick and strong caudate. That's called a stud caudate. So while doing surgeries, try to preserve that caudate. It's very important for maintaining the cardiac function, the left ventricle and mitral valve function in valve sparing surgeries. So this is identified. each muscle provided with 1 or 2 stud chordae. So other branching pattern, whether this is straight or branched or unbranched, how is the commissural chordae, how many chordae is going to the free zone, the basal chordae, all anatomies to be studied. In all cases, we happen to enter into the left ventricle. The outflow part is a very smooth one. The superior border forms a right aortic valve limits the outflow tract. So as I already told, anatomical junction is different from the hemodynamic junction. The ventricular myocardium enters into the interleaflet triangle of the aortic valve. The other part is already well discussed. See, this is not circular. There is commissures, intercommissural areas, there's gap. There only the ventricular myocardium gets in. This is lunulae, the thickened nodule is in between, the commissures between the two cusps, and anterior cusp. This is right anterior provided with right coronary sinus, left posterior, left coronary artery origin. This is non-coronary. The between the commissure of right coronary and left coronary is important. Membranous septum part. Have to be very careful when dealing with that area. This is the opening of the left coronary artery. So the left ventricle, it's forced that the blood flow through the left ventricular outflow tract. It's by the action of the vertex and the forces of it. It's coming like this. So muscles are very thick. It has to produce 120 millimeter of mercury to have a successful systemic circulation. When combined with the right ventricle, it has to produce only 25 millimeter mercury, but left ventricle has to work and produce more pressure gradient to pump effectively to have a successful, complete systemic circulation. Thank you. Thank you for the opportunity once again, Jacob. Thank you all.
Thank you, Dr. Rani. That was indeed a very elaborate talk on the left ventricle. Thank you so much. I think we'll just have a look at a few structures on the left side of the heart. So this is transilluminate. Okay, here now we are transilluminating the appendage. The left atrial appendage is finger-like, as you can see. The only part of the left atrium which has got the trabeculae carneae is within the left atrial appendage. The entire left atrium is very smooth. Here you find the oval fossa. There is no limbus here, and that tells us this is the left atrium. Identification of the chambers depends on the morphology of each chamber. A right atrium is not a right atrium because it's on the right side. A right atrium is a right atrium because it has a blunt triangular appendage and it has a limbus fossa ovalis, which tells us that it is the right atrium. So even if a right atrium is on the left side, it still would be the right atrium. So the morphology, the morphological features of the individual chamber is what decides what chamber it is. So for this left atrium, absence of the limbus here and this finger-like appendage are both what tells us that this is the left atrium. So this is the left atrial, this is the vestibule of the left atrium entering into the left ventricle. So why do we say that this is the left ventricle? Look at the apical part. The trabeculations here are very fine, as opposed to the huge trabeculations on the right side. So each ventricle is decided, what the ventricle is decided by its most common morphological feature. And for the for the ventricle, it is the apical part and the trabeculations of the apical part. The fine trabeculations of this ventricle tells us that this is the left ventricle and not the right ventricle. This is the anterior mitral leaflet. And if you have a look at the anterior mitral leaflet, you can see that you have a clear zone and a rough zone. The clear zone is the rough zone is what is the coapting area. So this is the rough zone and that is the coapting area. The non-coapting area is the clear zone, which is more towards the annulus. The A1, A2, A3 is how we say it this way, and this papillary muscle is the posteromedial papillary muscle. It is more towards the septum. This is the anterolateral papillary muscle. And if I put my finger in through this way, it goes into the aorta. There is no septal papillary muscle here, as I told you, because then they would go across the aortic pathway, and here we come to the aorta. And this is the aortic valve for you, the non-coronary cusp, the right coronary cusp. If I trans-illuminate for you, you know where the membranous septum is. So the membranous septum is between the non-coronary and the right coronary. So this is the membranous septum. This is the right coronary orifice, and that is at the middle of the sinus, and that will be at the same level as this. And here you find that each of these leaflets will have two lunules. One lunule to coapt with with its neighboring leaflet. So two lunules on each of the leaflets, and here in the middle you have the nodule of Arrhenius. So this is the nodule of Arrhenius. The plural is nodules of Arrhenius and not Arrhentii. Okay, Arrhenius is the name of a person. Nodule of Arrhenius, three nodules of Arrhenius. Now, this is the area of the mitral curtain. So the mitral curtain or the mitral continuity is between the non and the left. So this is where the mitral leaflet is slung, between the non and the left. For Hokum, when we do a Moro operation, the area that we cut is here. So you see the right coronary orifice to the leftward of that, and here is where this portion is what you cut for your Moro operation in your Hokums. A deatrialized specimen would tell us a little bit more about cardiac anatomy. So this is what we call the base of a heart specimen or a deatrialized specimen. So here you have the aortic valve, which is the king of all valves, sitting wedged in between all the other valves. This is the mitral valve, the tricuspid valve, and the pulmonary valve sits on a pedestal, and you have a free conus which pushes the pulmonary valve above the rest of the valves. And here, this is the central fibrous body or the right fibrous trigone, and the left fibrous trigone is here. So between that is slung the AML. So that would be the AML, and this would be the PML. And here you can see the P1, P2, P3 of the PML and A1, A2, A3 of the AML. Here you have the septal leaflet closer to the septum, the large anterior leaflet, and the posterior leaflet here. So this kind of tells us the anatomy and the interrelationships between all the different valves. The left circumflex going around the mitral, so also the coronary sinus here, and the right coronary artery going around the tricuspid here. We were talking about the fibers of the left ventricle. So here you find the inner circular fibers of the left ventricle, and these would be the longitudinal fibers of the left ventricle. So the longitudinal fibers and the inner transverse fibers. And Francisco Torren Guas had dissected out the LV fibers, and he showed us that the entire muscle of the heart is just one string. And this is our dissection of what Francisco Torren Guas had done, and this is that for you. The left ventricle has got two layers, the inner circular fibers and the ascending limb of the longitudinal fibers. The right ventricle has got one layer, and then here we have the entire LV muscle reassembled. I'm sure you enjoyed the structures of the left side. Now we will go on into a little bit about the functions of the valve. I'll show you a few valves and their function as how we have filmed it for you. Camera can go. Okay, wait. So this is the tricuspid valve in motion. We actually moved the tricuspid valve and we filmed it with a bronchoscope. This is the pulmonary valve in motion. See how it's opening and closing. This is the aortic valve in motion, the three cusps of the aortic valve opening and closing. We moved it with a bellow of air, and that's how we did it. This is the mitral valve, how it opens and closes, and this is the tensor apparatus of the mitral valve within that. I will now show you some of the this is the mitral valve opening and closing. It's a little bit stiff, so it's opening like as in a little bit of a mitral stenosis, but nevertheless, that's how the did the normal valves come? Okay. You have to share this. Okay, we can show it on the camera. Turn it around. Show it on the camera. Just a minute. So that's the tricuspid valve moving. This is the pulmonary valve moving. It's opening and closing. This is the aortic valve. We used a pillow of here to move it, open it, and close. This is the mitral valve. This is the tensor apparatus of the mitral valve. I'll show you the tricuspid valve once again. Keep. So this is the tricuspid valve. You see the large anterior leaflet, and this is how the tricuspid valve opens and closes. Okay, this here we see the bileaflet valve opening and closing. So this is how bileaflet valve looks like. Okay. This is how tilting this valve opens and closes. So a lot of these valves we show in a usual show implanted and how the chordae move with the cardiac relationship, especially when you do a caudal preservation and all that. So looking at it directly is a little bit different. I'm sorry we are not able to get you all that today, but maybe next year if the corona allows us, we will be able to show you all these valves actually in situ and with the relationship of the different cardiac structures as well. So this is the old Starenburg valve, and this is how the Starenburg valve moves. This is one of the ways in which you can get a valve and move it. This is we just connected to a balloon pump and we move the valves thus. This is one way of doing it to see how it moves directly. This is a fantastic valve. This is the mosaic valve in motion. It's one of our favorite valves, and this is the valve which we normally implant. See how beautifully it moves. You can even see the struts moving. So that was the valves in motion for you. We now move on to the microanatomy. We have with us Dr. Vijay Kumar, who is our cardiologist. Dr. Vijay Kumar has a lot of experience in the imaging of the plaques. So he will be talking to us about the plaques and how the cardiologist sees it. And we have with us Dr. Shiva, senior pathologist from the Apollo hospitals, and she will be talking to us on how they all look under the microscope. So a correlation between what is seen by the imaging cardiologist and what is seen by the pathologist for you in the next 20 minutes. Here we go.
Good afternoon, everyone. Spontaneous rupture of the atherosclerotic plaques with subsequent thrombosis is the most frequent cause for acute coronary events and sudden death. Autopsy studies have identified several histological characteristics. In these vulnerable plaques, that is, there was a large lipid pool, thin fibrous cap, that what we call as thin cap atheroma, and there were a lot of activated macrophages near the fibrous cap. So can we predict this imminent rupture of the plaque by imaging? So we need a good resolution in imaging to do this. So one of the modes of imaging studied is optical coherence tomography. And so in the next few minutes, we are going to compare the histopathological images of atherosclerosis, including vulnerable plaques, along with the optical imaging which have captured during optical coherence tomography. So the few stains in histopathology we are going to use to study the plaques That is one of the main staining we use in light microscopy, that is hematoxylin and eosin. Just an introduction for you that eosin stains the cytoplasm and hematoxylin the nucleus. And we are also going to use special stains. One of the stain is Movax pentachrome. It's nothing but it gives 5 different colors. For the nucleus, smooth muscle, we are going to study the elastic fibers, fibrin, that is which is present in the thrombus, and the nuclei. So that there is differential staining. And also we are going, some images will be in Masson's trichrome to highlight the collagen, and some immunohistochemistry to study the CD68 positive macrophages and the lining endothelial cells. So this is the normal artery. So normal artery, today we are interested in the intima. So we are talking about atherosclerosis, more about the intima. So the normal coronary artery has a very thin intima. So as during birth, it's very thin, just above the internal elastic layer. So here you see the cross section of the artery. So that is the inner surface is the tunica intima, then the internal elastic lamina, and then the tunica media, then tunica adventitia. So these are highlighted here. So we have a very thin intima here. So this is an elastic stain that highlights the internal elastic lamina. You can see that is marked by the arrow. So this is the artery, the cross section of the artery. And the adjacent luminal structure is the cross-section of the vein. So this is another cross-section highlighted by Masson's trichrome, cross-section of the artery. So you can see the very thin, this is just to highlight the very thin intima.
So we have just went through various histological, this thing, how the normal artery appears so far. And among the intravascular imaging modalities, optical coherence tomography is nearly closest to whatever you see on histopathology, not like that, but it is closest to that. So suppose you take microscopy, it has a resolution of 1 to 4 microns, and optical coherence tomography has 10 microns. So any structure which is more than 10 microns can be seen clearly with this optical coherence tomography. So this is a light-based modality. There are 2 basic properties. One is a reflection, a structure which highly reflects the light that appears as a bright structure, and it doesn't reflect strongly, it appears as a dark structure. And the second one is a penetration. So if the structure allows the light rays to go through it, you can see the deeper structure. And if it doesn't allow to go through it, you will not be able to see the deeper structures. So these are the 2 properties we just use to characterize the different type of images. So here you see that, as you already seen with histological imaging, the normal vessel is a 3-layer architecture. This is your intima. Intima is rich in collagen, so it appears as a bright structure, reflects light strongly. The second one is media. Media is mainly made up of smooth muscle cells, and again it doesn't reflect light strongly, so it appears as a dark structure. And the third layer is again rich in elastin and collagen, so that is your adventitia. It again reflects light strongly, so that produces a typical 3-layer architecture of your normal artery and OCT imaging. So this is your lumen. We just clear the lumen RBCs by injecting contrast, so it appears as a dark structure here. So, and this is your imaging catheter. And this is your lumen, this is your imaging catheter, and this is a typical 3-layer architecture in a strongly reflecting intima and poor reflecting media, and then again strongly reflecting adventitia. So bright, dark, bright 3-layer architecture. That is how normal artery appears on optical coherence tomography. And the updated recent classification of atherosclerosis divides the atherosclerotic lesions into 4 types. First one is a non-atherosclerotic intimal lesions. There are 2 types of these lesions. One is your intimal thickening. The second one is intimal xanthoma. So these 2 lesions are called as non-atherosclerotic because these are reversible. And so that's why it is called as non-atherosclerotic intimal lesions. Then the second thing is the progressive atherosclerotic lesions, mainly the pathological intimal thickening and fibroathyroma, which later evolves into thin cap fibroathyroma. That's why that is the one which ruptures and create all your ACS. And another two mechanisms responsible for plaque growth are plaque fissure and intraplaque hemorrhage. And the third one is the lesions which are responsible for your ACS, that is the lesions associated with the thrombi. There are three types of lesions. One is a plaque rupture, second one is plaque erosion, and third one is calcified nodules. When these lesions organize and heal, they produce healed lesions. Healed lesions either can be a healed plaque rupture, healed plaque erosion, or healed calcified nodule that may even later result in a calcified plaque or a totally occluded vessel. Next, we'll just go through the pathologies of each one.
So coming to non-atherosclerotic intimal lesions, the first is intimal thickening. It is just natural accumulation of smooth muscle cells. There is no lipid, macrophage foam cells, or no thrombosis. This occurs during the course of your life from childhood to adulthood. There is just slow accumulation of these smooth muscle cells, and then after that there is a stage intimal xanthoma. So there is superficial accumulation of foam cells without a necrotic core, or there is a fibrous cap, or there is thrombosis. So this is the longitudinal section of a blood vessel. You can see the arrow on the picture located on the top. That is called the fatty streak. And so there is accumulation of lipids in that, and below, the picture below shows yellowish thickening of the intima. Those are all lipid. So coming to intimal thickening, that is the histopathological view there. So that is a low power view. That is A is a low power view. You can see the intima. The previous pictures, normal anatomy, showed very thin intima. Here you can see that there is mild thickening. And you can also see some spindly cells. Those are all smooth muscle cells. There is also an image in that to show you the spindly smooth muscle cells. And the intimal xanthoma, there are foam cells. Those are all the clear cells marked by arrow, in addition to the smooth muscle cells and some matrix.
And this is how these two non-atherosclerotic lesions appear on your OCT imaging. Here you can just, we have provided a cartoon here. This is your intimal thickening, which, as we already mentioned, it is mainly made up of smooth muscle cells. And this is the histological section. Again, already has been explained. This is your intima, and this is your media, and this is your adventitia. There are no macrophages in this. So this is how typical intimal thickening appears on your histology. How do you differentiate this intimal thickening from a normal vessel on your OCT imaging? So we can't identify all these features clearly on OCT. We use an arbitrary criteria to define the normal intimal thickness. Normal intimal thickness is about 300 microns. And anything more than 300 micron, but less than 600 micron. So that is called intimal thickening on your OCT imaging. So this is a high power view of intimal thickening. So here you can just see that this is your thickened intima, and this is your media, and this is your adventitia. So anything of 300, less than 300 is normal thickness. Anything 300 to 600 is intimal thickening. And there is no shadowing here. That means there is no macrophage in this area. So the presence here, this is an example of intimal xanthoma. It appears almost similar to this thing, but here you just see that confluent punctate spots here. You can just see the bright spots here. So these are all macrophage foam cells. These cells cause a distal shadowing. So you can just see here the dorsal shadowing caused by these macrophages. So this is a typical appearance of the macrophage. So here intimal thickness is about 300 to 600, and the presence of macrophages. So this is the OCT appearance of your intimal xanthoma.
So next we are going to study about the progressive atherosclerotic lesions, that is pathological intimal thickening without macrophage and with macrophages. And then comes the fibroathyroma, early, late, and thin cap fibroathyroma, and the plaque fissure. So coming to pathological intimal thickening, so the plaque now becomes rich in smooth muscle cells, and there are matrix, hyaluron and proteoglycan matrix, and focal accumulation of extracellular lipid. So now also there is no thrombosis. And then coming to fibroathyroma, there is going to be macrophage activity. So early necrosis, there is focal macrophage infiltration into areas of lipid pools. There is an overlying fibrous cap. But during late necrosis, there is loss of matrix because of this macrophage activity. A lot of cytokines are involved, and there is extensive cellular debris, but there is an overlying fibrous cap. And calcification may or may not occur, but there is no thrombosis at this stage. Later, there is the necrotic core becomes larger, and then there is an intraplaque hemorrhage, and also there is some neoangiogenesis. If the necrotic core communicates with the lumen through the fissure, then there is thrombosis, and sometimes there can be minimal tear without obvious thrombosis. Thin cap fibroathyroma, there is a thin fibrous cap. Usually it has a lot of macrophages underneath and lymphocytes. As I said earlier, they play a major role in liquefying, so the fibrous cap becomes thinner. So there are not much smooth muscle cells, and there is a lot of necrotic core, and intraplaque hemorrhage and fibrin may be present. So in this section, this is a light microscopy. You can see there is thickening of the intima. So there is thickening of the intima, the EL that is marked as the extracellular lipid present. And you can see in the high power towards the right side, there is a lot of extracellular lipid present. This is pathological intimal thickening.
And so the hallmark difference between pathological intimal thickening and fibroathyroma is presence of organized extracellular matrix with no damage to the extracellular matrix, because there is no macrophage activity in this thing, and an extracellular lipid pool. Unfortunately, OCT imaging it doesn't differentiate between your necrotic core and extracellular lipid. Both appear as dark areas inside the plaque. How do you then differentiate these two things by OCT imaging? Usually the extracellular lipid accumulation happens closer to media. That means it is a deeper part of your intima. So that is how. But however, when the necrotic core develops, it just slowly moves towards your intimal surface. So, and when your signal loss is closer to your lumen, that most probably is your necrotic core, and it is fibroathyroma. When the signal loss is away from the lumen towards your media, and is most probably it is extracellular lipid, and that is your pathological intimal thickening. And another identification feature is in pathological intimal thickening and early fibroathyroma, there is not much lumen narrowing. When you progress to late fibroathyroma and thin cap fibroathyroma, there is significant lumen narrow. See, these are the various features we use to differentiate pathological intimal thickening from fibroathyroma. So this is example here. And this is all smooth muscle cell rich intima, and in the deeper part there is a lipid, so that appears as a dark area on the OCT imaging. And here you can just see that punctate confluence spots, what we saw with your intimal xanthoma. So this is a late stage of fibroathyroma, sorry, pathological intimal thickening. That is the one with macrophages inside. And this is a cartoon. So this is a pathological, this extrapathological section showing that this is an extracellular lipid which is closer to your media. So these are the features we use to identify pathological intimal thickening by OCT.
So this image shows us there is a fibrous plaque, and necrotic core starts developing in that. That NC with that thick arrow shows the necrotic core, and the right side is a hyper view of the necrotic core. And the pictures below show another pathway. There is fibrosis and calcification. So you can see this blue color, blue areas are all calcified areas. So there is a thickened plaque with fibrosis and calcification. So this is a gross image of a longitudinal section of the vessel wall. You can see along the branches, that's where the thickened atheromatous plaques usually start. So those arrows point out to the branches, and that's where there is pathological intimal thickening. And the picture below shows atherosclerosis of the vessel wall, and the picture towards the right shows along with thrombosis. These are the other features present in the atheroma. The picture A shows the formation of new blood vessels we call new angiogenesis, and there is also hemorrhage. In B and C shows fibrosis and calcification. Those blue ones are all calcified areas. And the picture D shows thrombus within the lumen, and E is an immunohistochemical stain for macrophages. We use CD68 to identify macrophages. Macrophages play a major role in liquefying the core, so that's why it is highlighted. Whenever macrophages are present close to the luminal aspect, then we have to be careful. In this thin cap fibroateroma, a lot of macrophages will be close to the luminal aspect.
And these are the fibroateroma images on OCT. Here you can just see, as I already mentioned, when you develop fibroateroma, the signal loss just moves closer to your lumen. So this is an early fibroateroma because it is a widely patterned lumen. And these are all necrotic cores, so that you can just see an area of signal loss inside your intimal plot. And this is actually your fibrous cap, because OCT has already mentioned it is a high resolution imaging which can image anything more than 10 microns. So you can easily measure the fibrous cap thickness with OCT. So this is a typical thick cap fibroateroma. And then again, this is early fibroateroma because your lumen is widely patterned, and this is you can just see that significant lumen compromise, and this is your laced fibroateroma. Still, your fibrous cap is very thick, and you can just see that circumferential necrotic core in this image. So this is a corresponding pathological specimen showing that necrotic core with the intra-block hemorrhage. This is all necrotic core. So this is much only is your lumen, and this is your thick fibrous cap. And here you can just see that this is again fibrous cap, lipid pool here, the necrotic core. So this is a high power image showing the same. And
so this is a cross section of the vessel wall. You can see the lumen is very narrowed. So the arrow points towards a thin fibrous cap. So you can see the fibrous cap is very thin, beneath which is a necrotic core and along with a lot of cholesterol clefts. And below that is the blue colored areas of calcification. Here you can note that there are also in the part located above the arrow, you can see there is also focus of hemorrhage. So this is mainly to show you the thin fibrous cap and narrowing of the lumen.
so this is how typical thin cap fibroateroma appear on OCT imaging. Here you can just see that this is all necrotic core and a very thin fibrous cap separating the necrotic core from the lumen. This is a high resolution, high power image. Is a zoomed image here, just showing the thick cap here, and this area, the cap is very thin in this area. So because OCT's resolution, you can exactly measure. So OCT by thin cap fibroateroma is defined as a fibrous cap thickness of less than 65 microns. So, zoom this image. And zoom this image, please. Okay, that's fine. Yeah. So this is where it just, because of this macrophage activity, it rupture and opens, and then you see an empty cavity in patients with a plaque rupture that we are going to see later.
So coming to lesions with acute thrombi, so one of the things that thin cap fibroateroma can rupture, that is cap disruption can occur. And thrombosis occurs because the blood is exposed to the contents of the atheromatous plaque, and the luminal thrombus also communicates with the underlying necrotic core. Then is a plaque erosion. This has another pathogenesis. The fibroateroma is actually intact. There is endothelial erosion and there is thrombosis. It may or may not be occlusive. No communication of the thrombus with the core is noted. Then comes the calcified nodule. There is shedding of the calcified nodule with an underlying fibrocalcific plaque with minimal or no necrosis. Thrombosis usually is not occlusive. So this is the gross images of the heart with longitudinally open coronaries. You can notice thrombus and occluding almost the entire lumen. And one cross section also shows here with the thrombus occluding the lumen, and the other image shows atheromatous plaque, and also in this image there is a thrombus. So this is a cross section of a thin cap atheroma with rupture. You can see the lipid core with thrombus in the luminal aspect and the fibrous cap.
So what are the OCT appearance of plaque rupture and erosion, various mechanisms? This is a typical plaque rupture. Here you can just see this one I showed you already. This is a thin cap fibroatheroma. This is your necrotic core, and this is your thin fibrous cap. And this is because of this macrophage activity, it ruptures and opens. So all the necrotic core enters into the lumen, where it results in formation of thrombus, which may or may not be occlusive. When it is occlusive, it causes the ACS, non-occlusive, and it causes progressive enlargement of your plaque. And typically, you don't see this one. You typically, OCT-wise, you see one empty cavity, because by the time you do your imaging, all this necrotic material just got cleared by your blood flow. Here, you just see that this is a typical thin fibrous cap, and this is a breach in the continuity of the fibrous cap, and this is an empty cavity. So this is the typical appearance of plaque rupture, and you can just see that remnant thrombus inside. And if you do the adjacent frame here, and again attached thrombus on the lumen surface. So this is the typical OCT example of a plaque rupture.
So in this image, in cross section of the blood vessels stained by Mowatt's pentachrome stain, you can see the so you can see the luminal thrombus here, and this is communicating with the necrotic core. And another image showing CD68 positive macrophages close to the fibrous cap. So this is what the main culprits are. This causes necrosis, and that's how there is rupture. So coming to plaque erosion. So in this cross-section image, as I said earlier, you can see the intima is more or less intact. So here there is a breach in the endothelium. So endothelium lining is breached, and there is a thrombus on the luminal aspect, and beneath which there is a fibroatheroma. So coming to plaque erosion. So as I said earlier, this is another two sections showing plaque erosion. So the image marked as B, you can see the thrombus in the luminal aspect, and there is you can see there is no communication between the atherosclerotic plaque or the necrotic core if there is minimal, if any. So there is no communication, only the luminal thrombus is present. And to show the endothelial, I already said there is a disruption in the endothelial lining. That's what is the cause for thrombus. You can see images in the far right. So that brown staining here beneath the below image is a normal one, that endothelial cells are intact. The image present on the top, you can see the luminal aspect, there are no brownish lining. So that luminal endothelial cells are absent. So the images studied here, this is immunohistochemistry to study the presence of endothelium.
So these are the two examples here. The first one we already showed. So this is your empty cavity and breach in the fibrous cap, and this is a typical example of plaque rupture, the most common mechanism of all your ACS. It constitutes about 65% of all your STEMI and STEMI. The second mechanism here, you can just see that there is an intact intimal surface with attached thrombus. So this is a typical example of a plaque erosion. If you remember the pathological sections here, this plaque erosion happens in the early part of the atherosclerosis, either with your pathological intimal thickening or with your, if you see this one, so this is a typical pathological intimal thickening and your lipid pore is away from your intimal surface, or it occurs in the early fibroathyroma, again your nephrotic pore is well away from the lumen surface. So it happens in the early stage of atherosclerosis and results pathologically from intimal the endothelium covering the intima that get disturbed. So establish that exposes the subintimal highly thrombogenic material to the lumen surface that results in thrombosis. And because it occurs in the early stage of atherosclerosis, the lumen is most of the time it is non-occlusive. So when the patient presents with these type of pathology, you just remove the thrombus by thrombosuction. Most of the time, these can be treated without even putting a stent.
So this is a gross image of longitudinal section of the blood vessel. Here you can see the calcified wall. So this is to demonstrate the calcified athyroma. So this is the hematoxylin and eosin stains sections of the intima of the blood vessel. So you can see the NC is a necrotic core, and you can see those diamond-shaped empty spaces. Those are all the cholesterol clefts. And the calcium is a blue one, as I have marked earlier. So I have said earlier, the blue ones are the calcification. So calcification may be sheet-like, or sometimes it can be nodular.
And this calcium nodules usually occur in blood vessels, AV groove blood vessels, where there is a hinge movement. So what actually happens is plate type calcium breaks into pieces and form a nodule that breaches your intimal surface and get exposed to your flowing blood. That's how it forms a thrombus and ACS. How do you identify by this, by OCP? OCP wise, you just see the calcium in adjacent frames. The calcium appears as a well-defined heterogeneous area, and that is how your plate calcium appears. When this plate calcium breaks and to form the nodule, it results in protruding surface. You can just see that. So this is your nodular calcium, and this is your plate calcium here, and just broke into small pieces that is protruding into the lumen. When it breaches the intimal surface, that is where it forms a thrombus. So this constitutes about 5% of all your ACS. The most common mechanism is rupture, about 65%. Erosion is the second common mechanism, it constitutes about 25%, and 25 to 30, and this is about 2 to 8% is your calcified nodule. Usually occurs in elderly and renal failure patients. Usually you see extensive calcification in other areas.
So in this histopathological image shown in D, you can see that bluish calcified matrix is protruding through the intima into the lumen, and that incites thrombosis. So you can see those reddish areas are all thrombosis, and this bluish material is protruding inside the lumen. So any lesion has to heal. So these are the healed lesions you can encounter. So the first one is the image showing intraplaque hemorrhage, and the second one is a healed rupture. So single layer, sometimes multiple times, there can be insults and there can be healing. You can see as multiple layers. And sometimes there can be total occlusion, and then there is organization of the blood clot, and there can be renal recanalization also. But the recanalization may not be able to open up the entire vessel, so it looks sieve-like. You can see like sieve-like appearance. And then comes the fibrocalcific plaque and the nodular calcification. So the healed lesion usually is composed of smooth muscle cells, proteoglycans, collagen, and the disrupted fibrous cap will be healed and may or may not have necrotic core or nodular calcification. Lesions can also contain large areas of calcification with few inflammatory cells and have a small or no necrotic core. The fibrotic and the fibrocalcific rich collagen plaque is associated with significant luminal stenosis. And usually there is no thrombosis in this scenario. So you can see the lumen is very narrow towards the right, where there is a lot of calcification. So this is an image showing the healed, the first one is showing healed erosion. As we saw earlier, in erosion, only the endothelial lining is not intact and there is thrombosis. So you can see here there is the fibroathyroma usually doesn't have a necrotic core in that scenario. So you can see the thick arrows pointing out the healing. So the endothelium regenerates and there is mild fibrosis beneath and some smooth muscle proliferation. In healed rupture, you can see actually multiple layers. You can see the necrotic core well beneath it and there is fibrosis above that necrotic core and there is luminal narrowing. In total occlusion, as we saw earlier, that the lumen has been occluded by a thrombus and there is organization of the thrombus and you can see small recanalization happening and it has a sieve-like appearance.
So OCT-wise, the typical appearance of the healed plaque, one of the important mechanism of the plaque progression is a layered appearance. You just see that there are two layers of different signal intensities. It is a recent thrombus formation that is organizes with the smooth muscle cells and the superficial endothelial formation. And this is another episode of a plaque erosion. If it is plaque rupture, you see underlying lipid, so that appears as a signal pole area. So that this is one episode and another episode which appears gives a layered appearance. That is how it appears on your OCT image.
So this is a cross section. This is staining by Mowatt's pentachrome. So you can see the arrows pointing towards the luminal aspect. You can see the necrotic core marked as NC well beneath it. So the necrotic core has some cholesterol clefts also. And there is healing by fibrosis and there is narrowing of the lumen.
So to summarize, the atherosclerosis starts initially with the non-progressive lesions such as intimal thickening or intimal xanthoma. And this intimal thickening sometimes progresses with the extracellular lipid accumulation closer to media to pathological intimal thickening, and which either progresses to fibroathyroma. And fibroathyroma either stabilizes forming a calcified plaque or it can move into thin cap fibroathyroma. So this thin cap fibroathyroma is a typical underlying lesion for plaque rupture. Or as we already mentioned, this early fibroathyroma or pathological intimal thickening may cause erosion also. And the stabilized fibrocalcific plaque may result in calcified nodule. So these are the three underlying mechanisms for thrombotic lesions and ACS. So these lesions either can produce occlusive thrombosis that result in myocardial infarction and stable angina or sudden cardiac death, or as we already mentioned, either they can heal and that results in progression of your lesion, progressively narrowing more than 70-75% that causes stable angina, sudden death or congestive cardiac failure, or it can progresses into total occlusion. And sometimes the healed plaques can form fibrocalcific plaques that can become a nodular calcium and again calcified nodule into thrombotic substrate. So this is how your atherosclerosis progresses. Both can be identified ex vivo with your histopathological imaging or in vivo with optical coherence tomographic imaging. Thank you.
Thank you.
Thank you, Dr. Vijay Kumar, and thank you, Dr. Shiva, for that very different sort of a talk. We now go on to the last talk of today, or the penultimate talk of today. We have again Dr. Vijay Kumar, who will now show us the cross-sectional anatomy of the heart as we image it in different ways. So over to Dr. Vijay Kumar again.
Thank you. Just move to the slides. So, good afternoon again. So far we have gone through all the anatomical sections and the concerned discussion related to that on the various part of the heart. Now we are just going through imaging part of this anatomical sections. Just move forward next slide, please. Next slide. Okay, next. Okay. So as we all know, heart doesn't follow the traditional anatomical planes in the body. It is not the central organ, so it is rotated about 60 degrees in the horizontal axis. So the imaging modalities, whatever you use, whether you use an echocardiography, CT scan, or MRI, all based on the images through the cardiac axis rather than the axis of the body. So there are two type of axes. So that typically it is either a long axis. Long axis can either happen in the horizontal direction or in the vertical direction. And the perpendicular to the long axis is the short axis. Short axis happens through various levels in your left ventricle. So that is how this is done. So if you take here, so this is your cardiac axis. It is located in the body like this. So you just go through either long axis, which is in the horizontal direction. So this is like this, or in the vertical direction. These are the two long axes. You call it as a horizontal long axis or vertical long axis. Or you go through short axis, which is happening at perpendicular to your long axis. The short axis happens in different planes, either closer to the apex, in the middle part, or in the basal part. We'll go through in detail. Next one, please. So as we all know, the heart is located in the thoracic cavity and it is covered by lungs on the either side. So you have limited space to visualize your heart. So either it can be seen through the transthoracic images or otherwise transesophageal. If you remember whatever discussions made earlier, esophagus is closely related to your atrium. So imaging can be done from behind through the esophagus. And if you move into the stomach, which is related to the inferior surface of the heart, so all the images can be acquired either through the transesophageal route or from the transgastric. So these are the three places, either transthoracic or transesophageal or transgastric. And transthoracic, there are various windows. First window is your apical window. The second window is your subcostal window. The third window is your parasternal window. And the fourth window is your suprasternal. So these are the four areas. One is your apical, the second one is the subcostal, the third one is your parasternal, and the fifth one is your suprasternal. So these are the four windows on the transthoracic side. So let's go back, please. So how the next one? How the images are displayed traditionally in the echocardiography. So the two things you have to remember: wherever you place your transducer, either transesophageal or transthoracic, the structures which are closer to your transducer are displayed on the superior part of the image, that is upper part of the image. Structures in the far field, suppose you put your transducer here, the structure, the atria, which is in the far field, are displayed on the lower part of the image. And there is an index marker on your probe. Whichever side the index marker points, it is on the right side. So that is how your images are displayed on your echocardiographic screen. Go forward, please. Go forward, go forward. Now we start with, go back, the next one. Traditional short axis sections. So this is how you section your heart into different short axis images. Typically, there are 5 sections. This is your apical section that results in formation of an apical cap. The second one is apical third of LV. The third one is at the level of your papillary muscle. And the fourth one happens at the level of the mitral valve. And the fifth one happens at the level of your aortic valve. The last one at the level of the pulmonary bifurcation. As shown in the figure, these are the 5 sections that have been acquired in short axis images. Now we go through one by one. Go to the next one. So the first section I already told you that results in this apical cap. All the sections are done to image different segments of your heart. Traditionally, if you remember, ACCHA is already mentioned in the previous talks, that divides the heart and left ventricle into 17 segments. So that we made the 17 segments and assess the regional function of each segment. We are sectioning the heart into different, say, short axis sections, and we made this in different segments. So the apical most segment that results in apical cap. This is your 17th segment on your ACC-AHA classification. The second section is your apical section. In this apical section, just to keep one by one. So apical section, there are 4 LV segments. The segment, this is your right ventricle, this is your left ventricle. The segment which is closer to the septum, this is your septal segment, and this is your anterior segment, and this is your lateral segment, and this is your inferior segment. So these are the 4 segments you get when you section the heart through the apical section. The second thing is at the level of papillary muscles. And again, here, the papillary muscle level, there are 6 segments. So this septal segment, which is separating artery and LV, there are 2 segments. One is your anteroseptal, and this one is infroseptal. These are the 2 segments. We are dividing into 2 because each has a different arterial supply. This anteroseptal segment is supplied by your septal arteries from LAD. And this is your anterior segment. This anterior segment is supplied by diagonal branches from LAD. So LAD is in the anterior ventricular groove. The septal branches supply this segment, diagonal branches supply this segment. These are the 2 lateral segments. This is your anterolateral segment, and this is your infrolateral segment. These 2 are supplied by, this is your supplied LCX, this is your first marginal branch, and this is supplied by your second marginal branch. And this is your inferior. The inferior is supplied by, particularly usually by your PLV branch. And this segment, that is infroseptal segment, is supplied by your posterior descending artery. So that's how these 6 segments are supplied. And if you go to the next level, that is your level at the mitral valve. Again, you have, this is your mitral valve here, and this is your tricuspid valve, and this is your artery-free valve. Here again, you have 6 segments. Then, based on this thing, this is your anteroseptal, supplied by your septal artery, and this is your infroseptal, supplied by your medial branch, and this is your inferior supplied by your PLV branch, and this is your infrolateral, supplied by second marginal branch, and this is anterolateral, supplied by your first marginal branch. So that is how you can assess all your regional functions. Totally 17 segments. The apical cap and apical level, there are 4 segments. I told you that it's anterior, septal, inferior, and lateral, and the other 2 levels, level at the papillary muscle, level at the mitral valve, which all have 6 segments. So by doing these 3 or 4 cross sections, you can assess the segmental function of all the LV segments. So just go back. So there are 2 other short axis sections. Next one. Let's move to the next. So these things can be acquired from your transgastric images. If you see here, it is your inferior surface is lying on your diaphragm. Below the diaphragm is your stomach. When you put your transesophageal probe into it, you can get the same cross sections at the apical level, at the papillary muscle level, at the base level. Only the difference here is because they are imaging from below. What you see here is inferior segments are located closer to your transducer. So that's why they're displayed on the upper side. And the superior segment, that is anterior segments, are in the lower part of the image. That is a basic difference. So these cross sections can be derived either through the transthoracic images or from the transgastric images. There are 2 other levels of sections. You just go forward, go forward, go forward. So this is the one which happens at the level of your aortic valve. So aortic valve, this you can just see here. This typically you can see all 3 leaflets of the aortic valve. This is your left atrium, and this is your right atrium, and this is your right ventricular outflow tract. The leaflet which is closer to the outflow tract is your right coronary cusp here, and the one which is at the intra-atrial septum is your non-coronary, and this one is your left coronary. So this section is obtained mainly for imaging your aortic valve, and if you're an interventionist, this image is obtained to guide your transeptal puncture. So whichever is closer to aortic valve, it is anterior puncture, and whichever is away from your aortic valve, that is your posterior puncture. So this is your transthoracic image, which shows all the parts we have discussed. You can just see here in the middle part, that is your aortic part. Then you can see the left atrium behind and right atrium on the right side, and RVOT anterior and right, and your LA appendage on the other side. So this is the section at the aortic part level. Next. The same can be obtained from your transthoracic transesophageal. From behind, you just cut at the aortic wall. Go to the next image. So this is the image which is obtained from your transesophageal. It is in the other direction because your imaging starts from your esophagus, which is close to left atrium. That's why left atrium appears on the superior part of the image, and your RV will be on the inferior part of the image. Next one, please. And this is a little different angle to image more of RVOT. Next image, please. And then this is a final cross section. It is at that level of your pulmonary artery bifurcation. Here you can just see that this section, and then this is your left atrium, right atrium, and this is your aorta, and this is your pulmonary artery. What you see here is your pulmonary artery bifurcation, which is not shown in this cross section. So this is a fifth short axis image that is occurred during transthoracic imaging. Just to move next. And the same one which can move next one. Same one can be obtained from the superior part of your esophagus. Just next one. So this here we can just see that aortine cross section and the pulmonary artery bifurcation on either side. Go to the next one. This camera is not showing it. So check it. So I will Yeah. So we have completed all the short axis sections here. I just first discuss short axis, so it is easy to understand your long axis sections if you understand the short axis. So the various long axis views, first we start with the three-chamber view. Three-chamber view is nothing but imaging of your LV and your LA and aorta. These are the three chambers that appears in your three-chamber view. The section happens typically like this, which goes through your right ventricular outflow tract and goes through the anteroseptal segment and goes through the A2, P2 segments of your mitral valve and into your infralateral segment of your LV. That is how your images are acquired in three-chamber. So these are the various structures we are going to see the three-chamber image. Here you can just see here. So this is your left atrium here, and this is your mitral valve leaflet. Typically, this A2, E2 segments of mitral valve leaflet, and this is your anterolateral papillary muscle here, and this is your left ventricular outflow tract, and these are the two cusps, and this is your right coronary cusp, and this is your non-coronary cusp, and this is your aortic sinuses and asinotubular junction and the ascending aorta. And this is your right ventricular outflow tract, and this is your anteroseptal valve and segment of, and this is your infralateral one. So what are the various things you can see? This is the image which is used for us taking most of the measurements. You take aortic annulus measurement in this view, and you take your sinus measurements, sinotubular junction measurements, and early ascending aorta. All these measurements are made here, and particularly we take your LA size in this, and you take LV size in this, and you can assess regions involving anteroseptal. This is your anteroseptal segment, and this is your apical part. It is the anterior and apical segments, and this is all your infralateral, and here it is an inferior segment in the apical part, and this is your apical cap. And you make RVOT measurements in this view. So this is called the typical three-chamber view, and the typical three-chamber view can be acquired in four areas. One is either you can acquired from the parasternal. That is what has been shown in this image. Just move next one. Next one. This is the second one is an example. This is an image which is acquired from the apical section. That's why you see the apical on the topmost part of your image. So this is the second area, the same structures, but acquired from the apical window. The first one is a parasternal window, and the display is different because based on where is your transducer starts your imaging, that is where it appears on the superior part. Far field is in the lower part, and the index marker side is on the right side. So wherever you appear, the images appear differently. These are the two transthoracic views. Just go to the next one. And this is what you acquire from the transesophageal window in the mid transesophageal window at 120 degrees. That is where you acquire your three-chamber view. And the same view can be acquired from the gastric. So this is a zoomed view of aortic one. Move forward. And this is what you get from the transgastric window. So the three-chamber view can be acquired from the transapical window, or from the parasternal window, or from your transesophageal window, or from your transgastric window. Move forward. The next one is the two-chamber. The two-chamber, if you remember how we cut the three-chamber, and here we cut the two-chamber. Two-chamber which goes through the anterior wall and the inferior wall. These are the two things which are imaged. This is your section is like this. We don't see any RV at all. You just see only your anterior wall, mitral, and the inferior wall, and the other side is the left atrium. So this is how the typical two-chamber is acquired. So here you can just see that. Go back. So this is the two-chamber view that is acquired from the apical section. So this is how the two-chamber view, and this is your atrium, and this is your mitral valve, and this is your anterior wall, and this is your inferior wall. And this image is mainly used to assess again to assess the volumetry. One of the two images you take, one is a four-chamber view, other one is a two-chamber view for assessment of LA and LB volume, and assessment of regional function, that is your anterior wall and the inferior wall. And in this view, you see papillary muscles and cardiac activity. So better, so assessment of mitral valve function also from this view. So we'll move forward. And this is a typical two-chamber view that is acquired from your transesophageal window. Here you can see that LA on the top side, LB on the lower side, and the inferior wall on your left side, anterior wall on the right side, and on the side of the anterior wall, you see your left anterior appendage. We just assess the regional function and the volumes of LA and LB for volumetric assessment. Next one. And this is the image acquired from your transgastric, because this image it is upside down. You can just see that anterior wall is on the inferior side, inferior wall is on the superior side, because we acquire images from below. And this image is very important for assessment of your caudal apparatus, because it is very closer to the transducer, is very closer to your inferior surface. That helps in assessment of all your caudal apparatus. Okay, so this completes your two-chamber view. And the next view, what we acquire is called as your commissural view. So we acquire this view particularly for assessment of your mitral valve. So this goes like this. It cuts through from your postero-inferior to and your medial commissure to your lateral commissure. So you can make assessment of all the segments of the mitral valve in this view. So this is a view commonly used during mitral valve repair, either your percutaneous repair or your surgical repairs, so to identify different segments of the mitral valve. So what you see typically is on the left side is your P3 segment. So this segment is on the left side, A2 segments in the middle, and P1 segment is on the right side. So because the segments are labeled from lateral to medial. So this is a typical intercommissural view that has been acquired to show various segments of your mitral valve. Go on, please. And the other two long axis views, these two long axis views are called horizontal long axis views. That is your four-chamber view, and the second one is five-chamber view. And again, as similar to other views, the four-chamber view can be acquired from three windows. One is your apical window, where you can just see that apex is located on the superior side, or from the subcostal window, or from your transesophageal window. These are the three windows you can have four-chamber view, and this is the specimen which is showing the four chambers of your heart. This is your right ventricle, right atrium, left atrium, and left ventricle. And this is again used for assessment of your regional function. Here we cut through two segments. Two of the segments. One is this is your infroseptal, and this is your anterolateral one. So you can assess the regional function here, and you assess your mitral valve function, and you assess the areas of left atrium and right atrium for your volumetric assessment. And almost all the RV assessments are done from this view. So this is RV volume assessment, this view, and RA and RV volume and area assessments are done from this view. So this is your four-chamber view. What we have shown here is your transthoracic apical four-chamber view. Go forward. And this is your subcostal four-chamber view, because we are sectioning closer to your RV. The RV is on the superior side, LV on the inferior and right side, and RA inferior on the left side, LA inferior on the right side. So this is a typical appearance of your subcostal four-chamber view. Next one. And this is a transesophageal. It is upside down, so you just see because all the images are applied from closer to LA. That's why LA appears on the superior part of the image, LV on the right inferior part, RA on the left superior part, RV on the left inferior part. So this is the typical transesophageal four-chamber view. So then last one of the long axis views, your five-chamber view, and the five-chamber view is the one which where you image your aorta. You just see that you cut from here, and this is your LV, this is your LA, and this is your outward tract, and this is your aorta. So this is your typical five-chamber view. It is called five-chamber because it shows LA, LV, aorta, RA, and RV. That's why it is called as a five-chamber view. The five-chamber view can be acquired from the transapical position. What we have shown here is your transapical position. Move forward. It can also be acquired from the transesophageal position in the upper part of the transesophagus. You can just see that RA is on the left, the superior part of the image, RV, the left inferior part, and aorta in the middle, LA right superior, and LV the right inferior part. The same images can be acquired from the deep gastric view. This is a typical deep gastric view, and LV at the apical part of the image, LA on the right inferior part, aorta in the middle, RV on the left side of your image. So this is an image being used for assessment of the gradients during aortic valve surgeries in the intraoperatively. So this completes all your long axis and short axis views, and the two more views what we are going to see is the suprasternal views. Suprasternal views. Suprasternal views are used mainly for imaging your aorta and LA. So this is how the imaging section goes through. So it is, so you can just see here aorta. Aorta goes from anterior to posterior. So image from here that exposes to your long axis of your aortic arch and various branches. Just when you can show it. So you can just see that, and this is where your right pulmonary artery goes. So here you get a long axis image and short axis images of your right pulmonary artery. That is your right pulmonary artery, that is your aorta, and you can see the various branches, your left innominate and the common carotid and your left subclavian artery. So this is the suprasternal long axis view, and in suprasternal short axis view, aorta short axis view, and you see the innominate artery coming here, and so you see the innominate artery, and as we see on the superior part of the image, and you see this aorta that appears as in cross section, and because it cuts aorta in cross section, you can see the right pulmonary artery in the long section, and you see this all the pulmonary veins in this image. So we can just see that all four pulmonary veins in this image. It is typically called as a crab view. So this is the suprasternal, not short axis view. Go forward. So this is a bicadral view. It is not much importance for surgeons. It is mainly for cardiologists. This view is again acquired for your subtle puncture. So the image happens somewhere from here. You see superior vena cava, inferior vena cava, and right atrial appendage, and part of the interatrial septum. That is how you define how high is your on the septum. So higher puncture means you are closer to SVC, lower puncture means you are closer to IVC. So this is called bicaval view. It is not for surgeon, it is mainly for interventional cardiologists who does septal puncture. Next one, please. And the next one is one of the right ventricular right-sided view. So this is your two-chamber view that cuts through your right atrium, right ventricle, SVC, IVC, and outflow tract. So here you can just see that this point, just the right inferior part. You can see that inferior vena cava opening from below into RA, and the superior part is your SVC, and go back. And the middle one is your RA. Then you can just see the two leaflets of your, usually the anterior receptor leaflet. So that is what makes anterior and posterior leaflets that you see in the two-chamber leaf, and lower one is your RB, and the superior part is your outflow tract. So this is your RB inflow view. The next one, please. The same view can be acquired from the transcatheter position. It is upside down here. You can just see that the right side it is your RA, left side is your RB, and you can just see that RB OT from above. And because it is acquired from that position, you will not be able to see SVC and IVC in the transcatheter position. So move next one, please. So this is the typical coronary segments we already discussed in detail. So it can be the views are done in such a way that you can make assessment of all the regional function and the coronary blood supply. You can just start with your paras short axis view here. Already you explained the septal segments. Anteroseptum is supplied by your LAD, that is your septal branch. Infroseptum is supplied by RCA. Inferior one is supplied by your RCA, and the lateral walls, anterolateral and infrolateral, supplied by your LCX, and your anterior wall is supplied by your diagonal branch. Same thing happens at the papillary muscle level. The apical level, which show the lower one. Apical level, the third one, below. Come down. Yeah, the apical level, there are only 4 segments. You can just see that anterior segment, which is supplied by LAD, and the septum is supplied by LAD, inferior segment is supplied by RCA, and lateral segment is supplied by LCX. And if you take in total 7 segments out of 17 segments, 7 segments are supplied by LAD, 5 segments are supplied by your RCA, and 5 segments are supplied by your LCX. The same things can be seen in your all long axis views. Long axis views again designed in such a way that if you take a 4-chamber view, it assesses your infroseptum and anterolateral wall. If you take 2-chamber view, that assesses your anterior wall and inferior wall. And if you take 3-chamber view, it just assesses anteroseptum and infrolateral wall. So the regional function and the coronary distribution can be assessed either in long axis and short axis views. This is the coronary blood supply examples in this slide. Go to the next one. So what remains is your imaging of aorta. So aorta again is an ascending part of the aorta, which is imaged either from the transesophageal views. So here you can just see that if this is your esophagus. If you are in the upper part of the esophagus, you can image your ascending part of the aorta either with the long axis section. So that is what you are seeing here. So this is a long axis cut of ascending aorta. Here you can just see your right pulmonary artery on this side. So move next one. And this is your short axis section that has been acquired through your transesophageal view. And next, how do you image your arch and descending aorta? And if you see the typical relationship of your esophagus to, this is your esophagus here, and this is your arch of aorta here. In between is your trachea, and if you see that this part of the esophagus, this arch is related. It is so situated anterior to your esophagus. So your esophageal probe is like this, and imaging from posterior to anterior. When you move down to the descending thoracic aorta, and it is located on the side, it is on the left side. So you have to image from the side, and when it enters the diaphragm, actually esophagus is anterior to your aorta. So you have to image on the posterior side of the esophagus. This is what's shown in this image. Just see that aortic arch, which is anterior to esophagus, and the descending thoracic aorta above the diaphragm is on your left side. And once it crosses, enters the diaphragmatic opening, the esophagus comes anterior to your aorta. So these are then each level you can acquire both short axis and long axis images. Just go forward, and this is your aortic arch long axis image that has been acquired from behind. Next one, and this is your typical short axis image of your aortic arch. Next one. And this is a short axis image of descending thoracic aorta. Next one. And this is a typical long axis image of descending thoracic aorta. These images are used to assess ascending aorta, particularly for cannulation, to identify a place where exactly you have to cannulate the ground free space and to decide on the risk of stroke during surgery. And the descending thoracic aorta assessment is mainly for aortic dissection. Imaging in a sick patient where your CT imaging cannot be performed, and also to assess atherosclerotic burden in your aorta. Thank you.
Thank you, Dr. Vijay Kumar. That was a very complete talk on the cross-sectional anatomy. And that was Dr. Vijay Kumar, our cardiologist for you. Now we come to the final talk of the day. We now invite Dr. Vijay to talk to us about the new aortic bioprosthesis. Over to Dr. Vijay.
Yeah, good afternoon. Jacob, can you see?
Yes, sir, we can see, sir.
Yeah, okay. Good afternoon, friends. So just a brief talk on the newer aortic bioprosthesis. Shall I? I'll just try the full screen. Can you see my next slide?
No, sir. We are seeing only the new aortic prosthesis, sir. Bioprosthesis, sir.
Okay. I think this. Then okay. I'll just exit this. Some problem. Okay, so just looking at the evolution of the valve processes, we've come a long way from the Hufnagel valve through many generations of the valve. But at this juncture of cardiac surgery, we are threatened by the transaortic, the TAVI valve. So this seriously rivals the surgical aortic valve replacement. And unless the minimally invasive route is one of the ways to effectively fight the benefits of a TAVR. So these are some of the patients, after a few months, you won't even see that scar. The bioprosthesis has definite advantages. So the common problems with mechanical valves is the thrombosis, sometimes endocarditis, the pannus formation. And what plagues the bioprosthesis is its structural valve deterioration. So there are different types of aortic bioprosthesis available today. You have the stented, you have the stentless, which was a generation which was used about a couple of decades back. Now it's come to sutureless and rapid deployment valves, and then of course the transcatheter valves. There's a big choice of aortic bioprosthesis available today. So on our shelves here in India, we have the Medtronic Abeles valve, the Edwards Magna, the Edwards Inspiris valve, the Intuiti Edwards valve, the Livanova Perceval, the Crown PRT, the Abbott Trifecta, the Medtronic 3F available outside India, and the Merrill, which has come in recently into the market. There's an interesting paper I came across, which came in the JTCVS last month, and there's a breakthrough research in the mechanical aortic prosthesis. This is the phase 2 animal trials which has been published. It's come from Germany. So there's an interesting valve there. It's a novel valve with a central opening tri-leaflet aortic prosthesis. So this may be an answer to long durable valves. The sutureless rapid deployment valves have evolved from the need for minimally invasive valves, which need a smaller incision, and there's so many limitations that it has. So the sutureless and the rapid deployment valves have made a lot of sense. It in reducing the aortic cross clamp time for sick patients, and of course some criteria must be met for these implantation. It's not for everybody, and there's also a slightly higher incidence of permanent pacemaker implantation. So the nitinol cage is one of the designs which the newer aortic valves have used, the sutureless valve. So it's very interesting how this cage sits there without any suture and manages to stay there. But it's a design which will suit certain routes. And the ease with which this valve can sit is really very simple. So once it has been guided down with some guiding sutures, then it's just a matter of turning and balloon inflating that valve. So the whole procedure is almost over in about 10 minutes. The Medtronic Avalis aortic bioprosthesis is one of the new innovations that we have seen. It's got a larger effective orifice area. It's got a low profile. It's been designed for valve-in-valve procedures in the future. It's used the AOA treatment for anti-calcification, which promises to be a much more durable anti-calcification treatment. And then, of course, it's made all these precision laser cut leaflets, which have all contributed to much better hemodynamics. So the Avalis design, it's got these precision cut bovine pericardial leaflets. It's an internally mounted leaflets, which we'll come to later. It has a distinct advantage, and it has a supraannular design. So there is a dual component polymer frame here, which gives a lot of flexibility. At the same time, it's very durable. It's made of a particular chemical substance called PEEK, and this overall gives it a lot of flexibility. The AOA treatment is basically it inhibits calcium phosphate crystal formation. So this protects the tissue collagen, and it is much superior to the glutaraldehyde preserved tissue. And the AOA anti-mineralization treatment, it basically it mitigates the calcification, and this has been seen in the experimental lab, where they see that probably it can last for more than 20 years. These are some of the ways these valves are tested: the accelerated wear testing and the animal studies. And if you look at this video, you will see the pulsatile hemodynamic testing which is done on these valves. You have a very effective orifice area and regurgitation assessment, and the stents are made flexible to reduce the stress, and the visualization and the shear stress confirmation is very good in these newer aortic bioprostheses. I'm sorry, just go to the next. Yeah. So the design goals of these newer valves is the ease of implant. So you need only a single 30-second rinse to get this valve ready. There is a low valve profile and narrow commissure posts, which makes the coronary osteal clearance good, and there is more space for knot tying. there are sewing markers, and there is a soft and pliable sewing ring. And the streamlined valve holder is very good for your minimally invasive procedures, and it's a one-cut release. So all this is added to the convenience of the operator. Um, these valves, again, if you look at the sizes which are available, you have a very wide range of size going all the way from 17 millimeters to 29 millimeters. So this is giving the surgeon a much wider range of sizes for probably the entire population. And you have a low profile, and this whole design is much superior. And the few other notable factors is that the interior mounted leaflets and low profile, it gives you minimum risk of coronary occlusions in valve and valve replacement. So the design is for future valve and valve transcatheter procedures, and it is a MRI safe non-metallic valve, and built to be much more durable, and there is a radio opaque, and the visibility is important when you do transcatheter procedures. So all this has been kept in mind while designing these newer aortic bioprostheses. The future will be valve and valve compatibility and design. So you have a non-metallic stent which mitigates the risk of corrosion between the surgical aortic valve and the transcatheter valve. And the valve dimensions and geometry enable future valve and valve replacements. And the interior mounted leaflets also mitigates the risk of coronary obstruction in the valve and valve procedure. So these are all very distinct advantages if you are looking into the future of a patient having one surgery, and whenever this valve degenerates, a very safe valve and valve procedure can be done. The other valves in the market are the Edwards Inspiris Resilia valve. So this is another breakthrough where you have a dry storage valve. This valve has gone through a glycerolization treatment for durability. And again, like the Ablis valve, is designed for valve and valve compatibility. So if you look at the preservation technique, it's done away with liquid solutions. The Edwards Intuiti valve is another rapid deployment valve where they have shown very good hemodynamics, and it sits into the left ventricular outflow tract. And this is also promising for quick procedures and minimally invasive techniques. The Abbott trifecta valve is another uh, improved valve where you have a very large effective orifice area, low transvalvular gradients. The only problem is that it's an externally mounted valve, so may not be the best for a valve and valve procedure. And the Liver Nova again is the crown PRT is again a externally mounted valve, low profile. So I'll just conclude here that we today have a wide variety of aortic bioprocesses. The possibility of rapid deployment is now available to us. Most of these valves have been designed for MIVS and also for future valve and valve therapy. Definitely the anti-calcification treatment is superior, and we are looking at a durability projected to 20-25 years. So this gives the possibility of reducing implantation in younger patients. Thank you. Thank you, Jacob.
Thank you. Thank you, Vijit. That was an extremely good presentation. Thank you so much. So that brings us to the end of our day. We all had a good time learning, teaching, and sharing knowledge and information. Did you have a good time? We had participants from Argentina to Australia. We had a few people from a few countries in Africa. We had quite a few participants from Southeast Asia. We are quite happy that this has truly become a global event with more than 200 people participating from across the globe. Some of the people participating in their midnights. So that is a source of great encouragement for us. We would so much love to have this as a hands-on meeting next time. We would include a lot of other things. One of the things which we are planning to include next year is the Sennings operation. So we would be able to talk to you about how that's performed. You can have a look at it in different sections. I trust you had a look at all the structures that we could show you on the heart. We hope that it was a good learning experience and something that will further you in your own journey of passion with the heart. Thank you. Hope you had a good day.